salmon, trout, so these smaller fishes, not those huge fishes. So these tiny fishes, because they have very high vitamin D and omega-3 fatty acids as well. So when it comes to vegetarian sources, there is nothing available other than fortified foods. Fortified milk, fortified juice, fortified cereal, fortified cheese, and tofu. And fortified milk is widely available. So vitamin D influences over 2,000 genes. And vitamin D receptor is present in all cells. Vitamin D is used by all cells in the body, and that is why all cells have vitamin D receptors. So initially, when they were thinking about why the receptors are present everywhere, only then they understood, vitamin D is required for all cells. So why? And there is a story to this. So vitamin D is not only activated in the kidneys. In the books, whatever we know, we say, like from the skin, it goes to the liver, and then goes to the kidney, and then finally we have calcitriol. But then the new finding is vitamin D is not only activated in the kidneys, but it is activated in every cell of the body. So if every cell produces active form of vitamin D, will it cause toxicity? No, because after the action is over inside the cell, it gets deactivated inside the cell itself. And that is the beauty of the mechanism. So we need to know about him to understand how this all came about. So he is Dr. Niels Ryberg-Finns, and he got Nobel Prize in Medicine in 1903. So he was affected with Niemann-Pick's disease and had cirrhosis, and for some reason he felt like whenever he went in the sun, he felt better. So he used the same method and treated his patients with skin tuberculosis like lupus vulgaris with phototherapy with an artificial light which he devised himself. And this is how phototherapy came into play in our medical field, and that is why he got Nobel Prize. But he did not know what caused it. But he did not know how lupus vulgaris, how tuberculosis got cured in his patients. But then the answer was given 80 years later, and it was by Dr. Chan et al. In the year of 1984. In NEJM, he published this report. Like when the macrophages which have TB bacilli inside them, they produced 125 dihydroxy D3. So which means active form of D3 was produced inside the TB bacilli. So that is how we knew all the cells are able to produce D3. So the active form of D3 outside the kidneys, and a process previously thought to occur only in renal tissue. So this theory was rejected. Up to 1 billion people worldwide are deficient. Is that a major public health concern? Yes, because vitamin D is required for bone health, calcium absorption from the intestine and bone formation, and immune regulation, muscle strength, mental health, skin and hair growth. It also acts as an anti-inflammatory agent in chronic condition, increases insulin sensitivity, good for diabetes and dental health. Autoimmune diseases invariably have vitamin D deficiency, and it is very important for cancer prevention. So there are a lot of disease associated with vitamin D, starting from schizophrenia, depression, and asthma, urticaria, atopic dermatitis, and respiratory conditions like COVID-19 and tuberculosis, hypertension, cardiovascular disease, type 2 DM, type 1 DM, rheumatoid arthritis, IBD, psoriasis, and cancers like breast, colon, prostate, and whatnot, everything. So vitamin D causes, this is again a new concept. So gut dysbiosis, we are talking about gut more than ever. And gut dysbiosis, so increase in bad bacteria and reduction in good bacteria. So that is gut dysbiosis. Vitamin D causes vitamin D deficiency causes gut dysbiosis, and eventually it causes something called as leaky gut or intestinal permeability syndrome. So intestine layer is very thin, just one cell layer thick. So with tight junctions, the cells are held together. So vitamin D, when it's deficient, those tight junctions are lost, and there are a lot of space in between. So the gut leaks. So what happens, all the bacteria in the gut will enter the blood vessels. And that is how chronic inflammatory conditions come about. So we say autoimmune, right? So autoimmune is antibody produced against something is affecting our own cells. So the antibodies produced are actually against these bacteria which enter through the leaky gut. And that is why Autoimmune conditions, for autoimmune conditions, vitamin D supplementation is very, very important. So the bacteria and toxins produced and the other unwanted items which are produced in the gut will enter the blood. So Dr. Michael Hollick, it's very important to mention him because he was the first person to isolate 25-hydroxy-D3 and 125-dihydroxy-D3. So he did a study on pregnant women who were taking 600 international units per day. And he saw that 76% of the women after delivery and 80% of newborns were deficient in vitamin D. And again, a study conducted by him, he showed that there was reduction in the cesarean section by 400% when you're given a vitamin D of 2,000 international units per day. So vitamin D is basically required for muscle relaxation and muscle contraction. So basically all types of muscle function. So that is why vitamin D is very, very important. And maternal prenatal vitamin D levels, if they are low, dental caries were seen in infants. And in the labs, if we see the values, they say normal value is more than 30. So we think 30 is enough, but no, that's not the point. University of California, this is one institute which has done extensive studies on vitamin D by far, and they say the current vitamin D recommendations are very low, and ideally you should have at least 60 nanogram per ml. So 60 to 100 nanogram per ml is great, up to 150 is acceptable, above 150 toxicity happens. But vitamin D toxicity is very, very rare, so we don't have to worry at all. In fact, one other meta-analysis, they said that even if the patient is taking 40,000 international units per day, it did not cause toxicity. We usually give 60,000 international units per week, one dose per week. But even in patients who are taking 40,000 per day also did not cause toxicity. So lower vitamin D levels are related with higher rate of premature death. Premature death. That is, it affects longevity as well because it's important for all the cells, and if that is deficient, obviously longevity is reduced. And again, they said there is higher risk of higher levels of vitamin D correspond to lower cancer risk. So in this study, they found out that women with vitamin D levels of 40 nanogram per ml or greater had 67% lower risk of cancer. That is huge. And rheumatoid arthritis or any other autoimmune condition like SLE or Sjogren's, type 1 DM, everything is related to vitamin D deficiency, also disease activity. So if in these patients, if you supplement them with high dose vitamin D, then their disease activity comes down, the CRP levels comes down. Even there can be reversal of autoimmune conditions are also reported. And it can also cause depression in adults, and there is increased risk of colorectal cancer, type 1 DM. So what is the recommended dose? So RDA 400 international units, we've all read this, but forget it, it's not there anymore. So what is the best recommended dose? So this is like a combination of all the literature available on vitamin D. So for infants, infants also require vitamin D. Even pediatricians, they've started to prescribe vitamin D as soon as infants are born. So infants, 400 to 1,000, best is 400. For children, 1 to 18 years, 600 to 1,000. This is per day dose. So best is 1,000. For adults, it's 2,000 to 10,000. Best is 5,000. And for pregnant and lactating mothers, it's 2,000 to 4,000. And best is 4,000. So many prefer different types of doses, and there is no proof of which is the optimum dose. So treatment of vitamin D deficiency. But all these doses are acceptable by most of the people, most of the vitamin D experts. So if you have confusion, just remember just one number for each age group. So treatment of vitamin D deficiency. So when people are deficient, you put them on 60,000 international units per week until the level of 60 nanogram, it's not mg, it's nanogram per ml is reached. And then once that is reached, put them on a maintenance dose, which is 5,000 per day. So sunlight versus supplement. Many people say, okay, sunlight is enough. But is it true? No, because there are various factors which are responding, which is responding. When it comes to sunlight, there are various factors which will contribute to the amount of vitamin D which is formed in the skin. So for like example, time of the day, during midday. So 10 a.m. to 2 p.m. you should be under the sun. And then season, winter reduces UVB. Latitude, if you're very far away from the equator, UVB is reduced. Skin pigmentation, if you are dark, if there is more melanin, then vitamin D synthesis will be reduced. So this is a very, it's a very classical example of how beautifully body works. So if you're going to get vitamin D from the sun, if you keep on get exposed to the sun, and then vitamin D will keep on increasing, then you will go for vitamin D toxicity. So along with the vitamin D production, melanin production also increases. You get tanned. So once melanin production increases, melanin will stop vitamin D production. And that is the beauty of how nature works. And when it comes to age, older people, in their skin, they have very less 7-dehydrocholesterol. So for them, it's difficult. And then when there's a lot of clothing and sunscreen and air pollution, clouds, when there are a lot of clouds, and glass windows, they all block UVB rays. But vitamin D produced from sunlight stays 2 to 3 times longer than supplements. So it is very ideal to stand under the midday sun for at least 30 minutes. But don't forget, it's not important. Whenever you prescribe vitamin D, it has to have all these three also: calcium, vitamin K2, and magnesium. Why? Because when you give vitamin D3, calcium absorption is increased in the blood, and all the calcium will not only go to the bones, it will also get settled in the arteries. So calcium in the arteries will cause cardiovascular disease and death. So what you should do instead, you should give D3 along with vitamin K2 and along with magnesium. And then when you give K2 and magnesium, the calcium goes to the bones and not to the arteries, because there are various mechanisms by how they divert the calcium in the bones. So that is why it is vital to add K2 and magnesium along with calcium. So these four things, all these four things should be there if you're going to start vitamin D. So for example, how should your prescription should be? So vitamin D3 500, this is for a normal person. So vitamin D3 5,000, and then calcium 500 BD. You cannot give more than 500 in a single dose. So 500 BD is the actual dose. That is the maximum dose of calcium which you can give. And then K2 100 to 200 microgram OD. And then magnesium 300 to 500 HS, because it is a relaxing hormone, so it helps with sleep, especially patients with insomnia. We have a lot of patients with insomnia, and almost everybody is magnesium deficient. So these combinations are definitely available in the market and also in the pharmacies. So K2, D3, MG, D3, so everything is available. It's just we need to start prescribing more of these. And thank you all for listening. And the basic point is we should be under the sun, get a lot of vitamin D3, and get all the benefits of vitamin D. So if we are going to be aligned with the universe, then the universe will work its way out in our lives. So I think that's a very good thing to remember on this day of International Yoga Day as well. So thank you.
Thank you, madam. We'll have the discussion after the next session. Next, we will invite the speaker, Dr. Vignesh from Vellore. He is going to talk about the prognostic models in sepsis.
While the slides are coming up, I would like to acknowledge and thank the organizers to have given me this opportunity to present in front of eminent physicians. So I take this as my privilege, and respected chairpersons, thank you so much for the welcome. And with that, I'll start my talk on prognosis on sepsis. So over the next 15 minutes, I'll be talking on prognostic models in sepsis. So we'll start with a case scenario to decide as to why we have taken this topic on prognosis. So patient 1 is a 45-year-old female with UTI presenting with fever, heart rate of 95, a bit tachypneic, normal blood pressures, has got leukocytosis, but normal organ functions. And we have calculated some sepsis prognostic scoring, the Apache score, the SOFA score, QSOFA, SIRS, which seem to be in the lower limit of the range. And case 2 is a 60-year-old gentleman with pneumonia, has fever, tachycardic, tachypneic, borderline blood pressures, a bit confused, has got leukocytosis, a drop in the PF ratios, platelet counts just below the cutoff range. These prognostic scores, the severity scores, are a little bit in the intermediate range. Patient 3, a 72-year-old gentleman with abdominal sepsis post-surgery, has been hypotensive, tachypneic, low GCS, febrile, and has got organ dysfunction in the form of renal failure, liver function test derangement, and thrombocytopenia. And the septic scores appear to be a little bit severe. The last patient, a 68-year-old female with necrotizing fasciitis, shock, not responding to fluids, tachypneic, low GCS, lactates are very high, organ dysfunction in the form of AKI is present, there is thrombocytopenia, and the scores are almost on the upper end of the range. So given these scenarios, whom will you support? I mean, in what context am I asking this question? Suppose if it is a government or a public care hospital, and if there is only one ICU bed available, whom would you give this bed to? That's a decision that you may have to take. Of course, beyond influences, we'll have to be true to our conscience and decide on that. Similarly, in a private setup, say if you are eligible to give subsidy to one of the 4 patients, whom will you give subsidy to? So in that case, it will be better if we know the prognosis, and it will be wise to put the bet on the person who has got the chance to survive, rather than put it on someone in whom therapeutics may prove futile. So that is the reason why it will be good to know the prognostication factors. So the outline of my talk will be on what are the outcomes of sepsis, factors predicting the outcomes, prognostic scoring systems that are available, and performance of artificial intelligence. How does it perform in sepsis prognostication? And a brief outline of what has been our department's experience. So globally, sepsis is associated with around 20% of inpatient mortality. In India, there is a Sepsis India study which has reported about 36% inpatient mortality, and in our institution, in our department, it has been reasonably the same. We have observed about a 27% inpatient mortality. The other outcomes, not alone inpatient mortality, it also has a bearing on long-term mortality. So even the cumulative mortality seems to be escalating, and the risk of sepsis continues to progress even over years of follow-up. There has been documented functional decline. The quality of life scores have been documented to be low. There are readmissions similar to what is observed after a cardiovascular outcome. After MI, after heart failure, we do notice readmissions predominantly within the first few months of admission. Similarly, even after sepsis, we have noticed readmissions, not only because of repeated infections or reinfections. There have also been risk for major adverse cardiovascular events. That has also been a cause for readmissions after a septic episode. The factors that are independently associated with inpatient mortality can be classified as host-related factors, such as advancing age, presence of more number of comorbidities, the inflammatory response or the lack of it. So the absence of fever, the absence of inflammatory response in the form of leukocytosis have also been associated with inpatient mortality. Similarly, hyperglycemia, hypofibrinogenemia, the lack of procalcitonin response also seem to have been associated with mortality. Site of infection, respiratory has been observed to have a higher mortality, whereas UTI, urinary tract infections, have been observed to have been associated with a lower risk of mortality. Probably it's being picked up in the benign stage and treated early. That is probably the reason why UTI has got a better prognosis. Type of infection, nosocomial infection seems to have a worse prognosis when compared to community-acquired infections. And antimicrobial therapy, the earlier it is started, has been associated with better outcomes, so that increase in time delay has got a worse prognosis, and restoration of perfusion, say the requirement of inotropes not improving early, or the absence of lactate response within the first 48 hours also has been associated with a worse outcome. This is from our own experience on long-term mortality. As I said, it does not stop only with inpatient mortality, even the long-term mortality appears to be affected. And the variables that are associated with higher long-term mortality are once again advanced age, male gender, it's not sepsis, it's Q-SOFA score more than 2. So Q-SOFA more than 2 has been associated with a worse long-term outcome. Increase in number of comorbidities. As per Charlson's comorbidity index, the presence of respiratory infection and inotrope. So more or less the same risk factors which are associated with inpatient mortality are also associated with long-term mortality. Moving on to the next. So these are predictive factors. But if it is a combination of factors in the form of a predictive score, probably it may give us some better information. So what are the scores that are available? Plenty of scores are available. I'll just list out quite a few number of those. So some of those which are well known are the SOFA score, the sequential organ failure assessment, which has got 6 organ systems related criteria, and based on which the scoring is between 0 to 24. A shorter or an abridged version of it, Q-SOFA, quick SOFA, so that we can do it just within a minute at the bedside using respiratory rate, altered sensorium, and systolic blood pressure, that scores bit 0 to 3. The Apache, there are various versions coming up. We used to use Apache 2, the acute physiology and chronic health evaluation version 2, which already has got 12 physiological variables, age, and other chronic health conditions with scores up to 71. Now we have the Apache 4, which is a little bit more refined, and it has got all the Apache 2 variables, but also adds some other variables such as ICU admission, mechanical ventilation, and some other clinical details as well. It's a little bit of a complex algorithm, so it is difficult to calculate it manually, as you may be able to do it with Q-SOFA or even possibly SOFA. So this requires an algorithm or a calculator or an inbuilt server for you to be able to effectively calculate it at the bedside. Others, the simplified acute physiology score, the SAPS-2 score is there. I mean, if we overall look at all these things, all of them have overlapping variables. Most of these have some clinical variables, some biochemical variables in various permutation combination, and each of them are being used predominantly in their own setting. The new score, which is predominantly to detect sepsis early. That's when the new score was designed based on clinical features, oxygenation, and it's between 0 to 20. The MET score, the PIRO score, I can keep listing any number, but I will stop with the last 2 or 4. There is one called mortality probability model. The SIRS one, which used to be in vogue prior to the last decade, where most of the current faculty would have been using SIRS score previously, and this has been overtaken by many, many new scores. So in the last decade, we have almost been getting a flurry of scores. Okay, now that all these scores are available, which one do we use and where do we use? So if we look at studies, I have listed the references right below. So there have been multiple systematic reviews and meta-analysis, but there is no comparison of like a network comparison as to which is better than this, which is better than this. So those kinds of details are not available directly, and it will involve a lot of statistical permutation, combination, calculation to arrive at those. So it will more often be an indirect evidence. But as of now, what is known based on these studies? So far seems to have demonstrated a higher sensitivity and specificity for inpatient mortality, in-hospital mortality. Even then, sensitivity appears to be 89%, so 11% of the times it does not predict correctly. And SOFA score also has got a higher sensitivity for 30-day mortality. That's reasonably good with a sensitivity of around 97%. So if SOFA score is low, the possibility of them dying in the next 30 days appears to be a little bit lesser. The sensitivity of delta SOFA. So more than SOFA, people have also looked at SOFA scores at periodic intervals, say 0, 24, 48. And if there is a change in SOFA score, that appears to be a better predictor than initial SOFA score alone. which case the the diagnostic accuracy appears to be 78% in comparison to just 64% with SOFA alone. And when comparing Q-SOFA versus SIRS, Q-SOFA appears to be having a better specificity than SIRS criteria. That's why probably SIRS is being phased out. So I've given a complex view, this versus this, and what to do. So the problem is that all these formulae or all these predictive models have been derived based on Western data. And our population of sepsis may vary predominantly because of demographic characteristics, socioeconomic characteristics, environmental characteristics, patient preferences. All those are different. Our patients may seek healthcare a little bit later when compared to Western population. So these may predict outcome in them pretty well, but whether they will work in our population well, that is still a question mark. There are very small scale studies looking at 100 patients, 200 patients, where they have tried to validate these scores, and the predictive parameters, the sensitivity, specificity have not reached even what has been observed in Western literature. So there is nothing that we could definitely choose, but from whatever information we have got through these meta-analysis, it appears that probably SOFA score is better in terms of looking at sepsis, mortality and long-term outcomes, and Q-SOFA is better than SIRS. That's what we can probably infer at this stage. Okay, next looking at role of biomarkers. Are there any blood tests that can predict sepsis outcomes better? Of course, what is already known is that increase in lactate levels is associated with increase in mortality. Increase in troponin levels have also been associated with increase in mortality. And there is this particular article which has looked at multiple other chemokines, heat shock proteins, interleukin 1, 8 granzymes, lactates, everything was included in a decision analysis model. And they have looked at whether it is good in predicting outcomes. It looks like sensitivity is 85% and specificity 60%, which is once again hardly that we get it from usual clinical predictor models. So, and there is one called SPINK1, which has also not given any good values like this. So as of now, if we look at it, there seems to be no single biomarker that seems to be good enough to replace clinical judgments as of now. Okay, this is what is already known. Now that artificial intelligence is everywhere, can we depend on artificial intelligence to predict outcomes? Let's see. In fact, there is a systematic review which has been published last year, which has identified 18 articles which has looked at predictive value of artificial intelligence-based algorithms. The commonest algorithms that have been used in literature seems to be logistic regression and random forest. These are the two algorithms that have been used worldwide predominantly, followed by various other algorithms. So the variables that they have used in those AI models have been mostly general information like demographic characteristics, arterial blood gas parameters, some laboratory blood tests. So these are the predominant variables that have been used in these algorithms. How have they predicted? So if we look at it, every model, every study seems to be giving various area under the curves and various diagnostic accuracy. But there is one study which has given about 95% diagnostic accuracy, and the area under the curve is best as good as 99% for one particular model, gradient boosted model, which was designed in 2021. Okay, so once again, these are predominantly based on Western data, and these have been derived from the MIMIC database, which is once again a Western population electronic medical record database. So we thought, why not we try it out with our own database, and we had a small experience in our institution where we tried to see if any of these AI models work in predicting our own patients with sepsis. So we selected about 1,500 patients with sepsis and tried to train AI algorithms using all these variables that we have listed. So we have also literally used similar variables, but we have also included some variables such as inotrope requirement, ventilator requirement, the source of infection, blood transfusion. So these were other variables which we decided to utilize based on one algorithm called Borutal's algorithm. So how did the various AI models function in our population? So once again, if we look at it, the best sensitivity that we could get in the test data, as I can say that it is highlighted, appears to be around 83%, and the best specificity appear to be 91% in the support vector machine algorithm. So once again, it's not great at this point of time. As I said, even the prognostic scores appear to be giving similar sensitivities and specificities, and these AI algorithms are also giving only so much at this point of time. But maybe we do not know. We have trained it only with 1,500 patients. If we train it with many thousands and 10,000s of patients, that too from diverse background, not only in one hospital, but across multiple regional hospitals, it may be possible that its diagnostic or prognostic accuracy may improve. So when we looked at the ROC curve, here the random forest model appeared to have given the best ROC curve with the area under the curve of 97%. So at this point of time, hopefully I have reached the take-home slide when I reach 15 minutes. Numerous prognostic scores are available. SOFA and QSOFA may assist with prognostication. Certain AI algorithms appear to perform well. So the way forward, it will be best that if we could derive a prognostic score for our population, which is derived from our own population, and validate that particular score in our own settings. And there should be an ongoing quest for novel biomarkers, because none seem to exist which may solve. That is, one test serves for all. It will stay on for future. There is nothing like that. So the quest should continue. And I have named it as augmented intelligence, because artificial intelligence, I don't think it is yet there to replace our clinical judgment, but it can augment our clinical judgment. That may happen anytime in future. So I would like to acknowledge all the masterminds behind the study, all the co-authors, as well as the organizers of Tapicon. And because I took a section on artificial intelligence, I also took the liberty of getting some slides designed by artificial intelligence, so I acknowledge that as well. But I should acknowledge that most of my slides were done by myself only about 4 or 5 slides, especially the pictures and a few case scenarios were the ones that I took from help from AI, but I verified it before putting it in. With that, I'll once again thank the organizers. Thank you so much.
Thank you, Dr. Vignesh. Let me invite Dr. Aishwarya to the stage. We'll have a short discussion. Vignesh, you be.
Madam, as you correctly said, the mistakes done in vitamin D when doctor treats, he sees the lab value as normal 30, they give it and stop it. Literature very clearly said, as you said, we go up to 100, nothing will happen. And in that situation, especially in a diabetic, I give 60,000 per week that continues even for an year when it is not touching 100. My only doubt, I appreciate you, my only doubt is, what is the real role of parental D3? Some still use it.
Yes, sir. Many patients, if they're forgetting or if they don't want to take tablets, then definitely now also many are giving parental D3, so it's acceptable, I think.
Some literature.
But mostly, whatever I've read, they've only suggested tablet. I don't know why, but then we still, I've seen people prescribing with D3, and that is also working in people.
Some literatures in parental D3 say a toxicity, but practically we have not seen, but some experts may answer.
Nothing. When you give a oral vitamin D3, tell the patient to take with a cup of milk. It's a fat-soluble vitamin. A lot of times I've seen patients take with water, they take after food. Tell them best time is to take early morning with a glass of milk. Very important message to the patients, you must say.
Yes, sir, yes.
Yeah. I think sepsis, do we rely too much on AIs more than the clinical aspect? You look at the patient, look at his profile, how sick he is. Don't we go by that, or we only go by these complicated AI algorithms?
Yes, sir. I agree with your comments. It's more of it is absolutely clinical judgment.
Definitely,
That's why
definitely yes. You check at the urine output, how is the respiration, how is the blood pressure, how is the response, conscious levels. I think that will give a clinician a much value than put it all to your machine and then give a value out of it. I think it's
Yes,
not,
I agree with your comment, sir, that it is not there to replace the clinician.
thank you, doctor. Thank you.
Do we have any AI tool that will incorporate all these scores and give you the prognosis?
That is what we were trying. So we are still in the early stages. We just put in those variables and derived it. We are yet to validate it. So our next venture is to see if we can validate in an external population to see if it may be of some use in future. Maybe for a junior clinician who is not in experience and who's in ED, who has to be the only person who has to manage. Maybe in that scenario, if there is some augmented help that is available through AI, we thought, I'm not saying it's going to replace it or it's going to be beneficial, but that is somewhere where we can at least look at how it performs. That's our opinion, sir.
Don't say just juniors, even it will help us seniors also.
One question, madam, one question. Vitamin D role in case of the mild cognitive illness to dementia, because we are doing one paper where we found that this mild cognitive illness and dementia, any beneficial role?
Yes, sir, definitely. When it comes to dementia, mostly, if you take Alzheimer's, they call Alzheimer's as type 3 diabetes. So it is diabetes of the brain. So vitamin D is very important for increasing insulin sensitivity. So obviously, I would say, I put all my patients on vitamin D3. I'm it's my, it's my go-to to add even in sepsis patients, even in ICU. And when we see the patient clinically, how well they are improving, it's all, like evidence-based. Nothing is, we need years to get all this on paper. But then when the evidence shows, when I ask my patients, are you well? They say, like, my life has changed. The people are not related, but every person, they say, my life has changed. So when everyone keeps saying that, it is useful.
And in our paper, still our results are not out. We found out that we have done molecular docking up to the 600 generation. There we found out that the V3R4C gene, which recepts on the V3R receptor, it was found to have this mild cognitive illness preventing into the dementia. So that also could be useful. And my question to sir is that, sir, same thing we followed what Lakshmanan sir told in Chennai. When we followed it, we had made a profile where pulse, BP, respiratory rate, temperature, saturation, urine output, we maintain for every 2 hours we told to write. All that, and we found out that just in 1 month, sir, from 15 to 5 it came mortality down. So that was also done in our thing, sir. And this thing, one doubt is that, sir, in SOFA criteria, they told us to do every day. But what we had the problem in private institute, that cost of the patient was increasing very much. So in that case, we used this thing, means we had more benefits, sir.
Yeah, thank you for sharing your experience as well. So that is what we mean by saying that abroad they may be doing everyday ABGs because it's not the patient who is paying, it's the government that is going to pay for their cost. So all these scores are derived keeping in mind their setup of healthcare. So it will be ideal that we derive something out of our own healthcare setup which is appropriate for all our healthcare settings and also applicable for the same. So thank you so much for that.
Okay. Thank you, Dr. Aditya. We will conclude the session. And
yeah, sir. Momentos. Fast ಆಡ್ತು. I request Dr. Binu sir to give the memento to Dr. Aishwarya ma'am. I request Dr. Madhi Selvan sir to honor Dr. Vignesh sir. Honor Vignesh sir. I request Vignesh sir to honor Binu sir. Binu. Sir, Mari vande. Ma kudu ma. Yours is there, sir. I request Aishwarya ma'am to honor Madhi Selvan sir.
Now we shall begin with session 2. We'll focus on topic cardio-diabetes. We warmly welcome Dr. Javakar sir, Dr. Saranya ma'am. Kindly come up to dais as chairperson. I request Dr. K. Balakrishnan from Pattukotai to start the session.
I request Dr. Binu sir to speak on the topic diabetes and hypertension.
Good morning. Okay. Good morning. Let me thank the organizers for giving me this opportunity. Respected chairpersons, respected my seniors and my colleagues and juniors and postgraduates. I'll be talking about diuretics in hypertension, and my aim will be to understand the role of diuretics in blood pressure management. So hypertension is a serious medical condition. There is a risk of premature death. It affects kidney, brain, heart, and 1 in 4 men and 1 in 5 women over a billion, and there is over a billion people having diabetes. I mean hypertension. Sorry. So there is 1.28 billion hypertensives between the age of 30 to 80. 82% are in the low and middle income groups. That is, countries like India, Brazil, etc. will have a high incidence of hypertension. Of course, China has got a even higher incidence. 10% of all these hypertensives are due to secondary hypertension, which we often forget. 20% of resistant hypertension is often endocrine cause. Endocrine hypertension, we had a talk yesterday. So what is blood pressure? It is, for the postgraduates, it's the lateral thrust exerted by the blood column in the blood vessel. It is the product of cardiac output and systemic vascular resistance. So whenever cardiac output increases, blood pressure increases, systemic vascular resistance increases, blood pressure increases. Cardiac output increases, it's more of systolic blood pressure. Systemic vascular resistance, more of diastolic blood pressure. And anything that reduces cardiac output will reduce blood pressure. Anything that reduces systemic vascular resistance also will reduce blood pressure. So we should know hypertension, that is an increase in blood pressure. We will see what JNCA says. White collar hypertension is there where in-office BP is high. Mass hypertension, when we see blood pressure, it is normal, but at other times it may be higher. Resistant hypertension, you are using 3 drugs in optimal doses, even then BP is not controlled, provided one of which is a diuretic. Control resistant hypertension, when you have more than 3 drugs to control your hypertension. And refractory hypertension, when you are using 5 drugs in optimal dose and even then you are not able to control hypertension. And JNCH, we know, we have seen this 120 by 80 and 140 up to 140/90 is considered pre-hypertension. Then you have stage 1, which is 160 up to 160 by 100, and stage 2 anything more than 160 systolic, 100 diastolic. So we are India is among the high incident countries. Of course, we have our neighbor China having more incidents than us. In India, Tamil Nadu is again in the little higher incident area. And the rural incidence of hypertension is approximately 25% and the urban incidence is 33%. I mean prevalence, not incidence. So we can classify hypertension as primary hypertension, where there is no specific cause. 90% of hypertension falls in this category and 10% is in the category of secondary hypertension, in which you can have renal diseases, endocrine hypertension, and we can have many other things. And one important thing which we often forget is drugs. Always when you are seeing a patient in your clinic, remember to ask them if they had a smoke, if they had a coffee, and if they are fine, relaxed. See to it that they are relaxed. Did they take any cold medicines on the day or previous day? All these things can affect your BP measurement. And we often forget that our BP cuff bladder should cover 80% of the area where you are checking the blood pressure. Diuretics are first line agents in many of hypertension, or rather uncomplicated hypertension. It is the first line drug, and they decrease blood volume and thereby decrease cardiac output and decrease blood pressure. In long term, because they produce a reduction in sodium load, they will end up reducing the systemic vascular resistance, and even when the blood volume is normalized, the BP lowering effect will continue. So we have thiazide diuretics, loop diuretics, potassium sparing diuretics, aldosterone antagonists, and of course there are other diuretics like carbonic anhydrase inhibitors and osmotic diuretics, which are not used as antihypertensives. Let us look at one by one. So hydrochlorothiazide or chlorthalidone are examples of thiazide diuretics. They act in the distal convoluted tubule by inhibiting sodium chloride SIM porter, and they are clinically used as first line drugs in uncomplicated hypertension. So they act in the distal. Do we have a pointer here? Okay, you can see in that picture, distal convoluted tubule, they act. So loop diuretics act at the thick ascending limb of loop of Henle on the NKCC transporter, that is sodium potassium 2-chloride transporter. The examples are furosemide and bumetanide, and for postgraduates, if there are any, there is another loop diuretic, indacrenone, which is useful especially in people having gout, because that is the only diuretic which we know that is uricosuric. So they are reserved for use in CKD and heart failure associated hypertension, not in routine hypertension. And you have potassium sparing diuretics, example amiloride and triamterene. The site of action is in collecting duct. They inhibit sodium channels, thereby reducing potassium loss. Sodium comes in, potassium goes out, and when sodium is prevented, potassium loss is prevented. They are often combined with thiazides to prevent hypokalemia caused by thiazides. Not used as individual antihypertensives. Aldosterone antagonists, they are more useful in many other conditions other than hypertension also. Cardiac failure, it's a pillar. We use them in liver failures. Their mechanism of action is by blocking aldosterone receptors. They are used in resistant hypertension, primary aldosteronism, and of course heart failure. It is one of the main pillars. Okay, so this picture was the one which I was showing below the other slides. You can see all the different diuretics which we commonly use. The one is carbonic anhydrase inhibitor, two is osmotic diuretics, then loop diuretics, thiazide diuretics, potassium sparing, and aldosterone inhibitor antagonists. So thiazides produces hypokalemia, hyperuricemia, hyperglycemia. Added to this, loop diuretics produce hypocalcemia. Furosemide is known to produce ototoxicity also. Potassium sparing diuretics, of course, they produce hyperkalemia because they are potassium sparing. Spironolactone, in addition to hyperkalemia, will produce gynecomastia, menstrual irregularities, etc. So there are a group of diuretics called thiazide-like diuretics, and among which indapamide is one drug which is commonly used in hypertension. They are sulfonamide diuretics which has similar physiological properties like thiazides, but they don't have the thiazide benzothiazidine molecular structure. Thiazide-like diuretics are usually superior to thiazide diuretics because they are having lesser metabolic side effects compared to thiazide diuretics, and in addition, indapamide is having a vascular smooth muscle calcium influx blocking action which causes direct vasodilation, and in lower doses of indapamide you can use it for hypertension without much electrolyte and metabolic effects. So diuretic, let us look at the clinical guidelines. ACC, AHA, ESC recommends diuretics as first line drugs. Thiazide and thiazide diuretics are the ones which are advised as first line drugs in uncomplicated hypertension. So they act better in elderly people and black. But when you say elderly, always remember that elderly are more prone to hyponatremia, and they may be on many other drugs which are likely to produce hyponatremia, like many of them will be on pregabalin, many of them will be on some other anticonvulsants. Isn't it too early? Okay. Okay. So we have, I don't need such much time. So we have to remember that these patients, elderly people, are more prone for hyponatremia, and then we should be careful about hypoglycemia with more frequent monitoring of sodium. So JNC8 recommends use of thiazide-like diuretics or thiazide-type diuretics as first-line drugs in non-black as well as black when it is uncomplicated, and also in uncomplicated diabetic hypertensives. Of course, JNC8 also tells us that we should be using either one drug and go to maximum, or you can start with one drug, before going to maximum you can add a second drug, or straight away start with two drugs. For a stage 2 hypertension, it is always better to start with two drugs rather than starting with one drug and trying to get control. So in a stage 2 hypertension, we should be starting with two drugs, one of which should be a diuretic. Electrolyte monitoring is important in when we are using diuretics. Of course, potassium, low potassium, high potassium, hyponatremia, calcium. We should also be looking at uric acid. So remember, if there is a gout, we should be more careful with using these things. And comorbid conditions should always be in mind when we are starting a diuretic. Heart failure, CKD, etc. We will be using mineralocorticoid antagonists. In liver failure, we will be starting mineralocorticoid antagonists. And when you are using a potassium-sparing diuretic in combination with AC inhibitor and ARB, remember hyperkalemia. There are still a lot of unmet needs in diuretic treatment, not only in hypertension, in diuretic treatment as such. You can see that 65% of sodium is reabsorbed in the initial part of the nephron, where none of these drugs are working. So sodium reabsorption majority is happening in the initial part, where none of these drugs are working. And there are many other receptors which can be targeted for diuretic effects. We have aquaporin receptors, pendrin, renal outer membrane potassium channel, epithelial sodium channel. A lot of channels are there which can be targeted, and there are molecules being developed. Let us look some of these. The highlighted molecules are having possible or potential antihypertensive effects, and the non-highlighted molecules are not having potential antihypertensive effects. So we know tolvaptan, conivaptan, which are being used in hyponatremia. There are urea transportase inhibitors which may not be useful which does not seem to be very useful in as an antihypertensive. And of course, we have adenosine receptor antagonists. Remember the previous picture. Remember the previous picture where I saw the 65% sodium reabsorption is happening in the initial part. Adenosine receptor works there. So if you have an adenosine receptor antagonist, that can prevent or at least reduce the sodium reabsorption at this part, initial part of the nephron. So we conventionally use a lot of adenosine receptor antagonists in other conditions like asthma. We use theophylline, but those are not useful or being used as antihypertensive. But rolfylline is a drug which has got potential antihypertensive. Not here, I think there. Okay, fine. So rolfylline is a molecule which can have a antihypertensive action, but studies till date are not very satisfactory in case of rolfylline. We have natriuretic peptide receptor antagonists which can have potential antihypertensive effects. Nesiritide can be used. And we have ROMK inhibitors which are still in the development that may have. Then WNK with no lysine kinase, WNK SPAC inhibitors, closendenal, rofaxenate. So those things also are having going to have antihypertensive activity. And there is a protein which helps in the transport of bicarbonate, formate, etc. across the renal membrane called pendrin, and this pendrin inhibitors like niflumic acid, tenidap, etc. they also are potential antihypertensive agents. So in summary, diuretics are essential in hypertension management, and all the guidelines tell us to use diuretics as first-line drugs, except in special conditions. Diuretics are supposed to be first-line drugs in hypertension, and the choice depends on patient profile and comorbidities. And we should always try to balance the efficacy with safety and side effects. Thank you very much. So these are my references. Thank you very much. We will I think we will have the question and answer session at the end.
Thank you very much, sir, for a nice lecture on diuretics and hypertension.
Thank you, sir.
Right now, we'll welcome Dr. L. Raghupati on the topic diabetes outside isolates.
Thanks for the Tapicon coordinates and thanks for all the senior teaching faculties. I am a practicing physician. This topic is a little tough topic to me, but it is only to enumerate that there are a lot of conditions where the blood sugar is high other than the routine conventional diabetes which we think. Maybe type 1, type 2, sometimes LADA. The defect may be in the pancreas, or defect may be elsewhere. So I am enlisting the conditions and what we can do with that. Getting stuck in the slides. Yeah, ma. Slide. இது ஒர்க் பண்ணுதா இதில் பண்ணலாமா இல்லை okay. So, okay. A fool is known by his speech and a wise man by silence. So you are all silent, I am speaking. See, whether we call all the high blood sugar as diabetic may be okay. And we have many conditions where the blood sugar is high, which we don't conventionally call as a diabetes. So there are situations where the high blood sugar is not coming up to the level of a frank diabetes, but still it is not normal. One such so I coined the term diabetes outside the islets. That means all the hyperglycemic events outside the islets. We know this classical classification. You look into the other causes where problem in beta cell function, problem in insulin action, exocrine pancreatic disease, endocrinopathies, drug-induced infections, and immune-mediated and other genetic syndromes all will have a high blood sugar, which is not the routine diabetes. Pre-diabetic is considered as a non-diabetic hyperglycemia. We all know about IFG, where there is hepatic insulin resistance, then IGT, there is a muscle insulin resistance, and there are so many factors we should know. We all know age, gender, ethnicity, inactivity, weight, cholesterol, high lipids, family history, sleep. We know it very well. But why we should give importance to pre-diabetic? Three things. If you don't address properly, they are the future diabetics. There is already an increased cardiovascular risk even in a pre-diabetic stage. And any illness may become worse even in a pre-diabetic stage. We know when we control all the factors, when we control the diet, definitely we can postpone the pre-diabetic to a frank diabetic even more than a decade. Now these are the main I's which are conditions where the blood sugar is high. Infections like pancreatitis, myocardial infarction, infractions where the patient is not cooperating, infants' problem in pregnancy diabetes, ischemic heart disease, drugs use, iatrogenic, the wrong use of drugs, maybe steroids, patient misuse, then so many other conditions like type 1 where the blood sugar is high. So we know all these conditions. Pheochromocytoma, there is catecholamine excess, hyperthyroidism, excess thyroid hormone, glucagonoma, excess glucagon. We have Cushing syndrome, we have acromegaly, we have pheochromocytoma. All these have and hyperthyroidism, glucagonoma, and pancreatic disorders. All these have high blood sugar where they are not diabetic. One word about pancreas. All exocrine pancreatic disease may be an acute infection or a chronic infection that destroy the exocrine system. They in turn destroy the endocrine system. We know about the fibrocalcareous pancreatitis. They cause a lot of pancreatic stones, gallstones. If you don't attend them, they go into a diabetic stage. If not controlled, they go to a type of insulin-needed diabetes mellitus. as I said, there are causes, pancreatic causes, PCOS, Cushing's, drugs, infections, trauma, surgery, they all raise blood sugar, which is not a conventional diabetic. The symptoms are same like our routine diabetic. See, when there is any critical illness, when there is hyperglycemia, there is increase in counter-regulatory hormones, increase in cytokines, and we give a lot of drugs to treat. So there is a hyperglycemia, and infection is a very important point in chronic illness. We all know about the COVID, where it has infected the adipocytes, infected the beta cells also. So those who are admitted, those who receive nutrition support, those who receive IV fluids, these are all the conditions where the blood sugar is high. In orthopedic patient, a prolonged bedriddency, patient is not mobilized with stress, they develop high blood sugar. See, if you take many components in obesity, please note that this obesity itself will cause high blood sugar. If you correct obesity, blood sugar may come down. So don't allow them to go into a frank type 2 diabetes. And if there is a glucotoxicity and lipotoxicity, which we describe, they also affect all the cells of the body, including pancreatic cells. So there is a glucotoxicity in pancreatic cell that affects the beta cell also, and there is lipotoxicity. In metabolic syndrome, it may be an insulin resistance or frank high blood sugar. When you take PCOS is a one condition which is not restricting itself to only to the ovary. It involves brain, adrenal, ovary, uterus on one side, adipose tissue, skeletal muscle. There is insulin resistance, hyperinsulinemia, and androgen overload. High blood sugar is a component. So here on one side we have insulin. On the other side we have counter-regulatory hormones like glucagon, growth hormone, cortisol, epinephrine. They try to raise the blood sugar. In all the conditions I described, these counter-regulatory hormones are on the upper hand. So in the result, we should address adipose tissue problem, liver problems, muscle problems, circulatory and electrolyte problems. When you don't address even this non-hyperglycemic diabetes, they may end in sepsis, multi-organ failure, and death. This is so important. So as I said, it affects liver, muscle, and adipose tissue. And there are so many insulin genetic defects which are noted. You can have some clinical clues in patients with acanthosis, hyperinsulinemia, ovarian androgenism, and blood sugar will be high. This gives a clue that we are dealing some high blood sugar, not the routine diabetes. And this affects usually all the organs, pancreas, pituitary, adrenals, adipose tissue, liver. So another clue for us is when you do the GAD antibodies and IF2 antibodies, usually they are high in type 1 diabetes. When they are absent, it may be a type 2 diabetes, or it may be any one of the acquired causes like endocrinopathies, acromegaly, Cushing's, exocrine pancreatic disease, and diabetes after a malignancy, after pancreatic malignancy. There is one condition, rare condition called mitochondrial diabetes. There is also a genetic mutation where the blood sugar is high. The antibodies, the GAD antibodies are negative. Here, deafness is one of the commonest symptom which give clue. You can use oral drugs, but metformin is usually avoided for lactic acidosis. And we know the multi-endocrine organ systems where type 1 and type 2 both have diabetes type 2 and type 1. And these are all the hormones which I said, growth hormone, cortisol, glucagon, catecholamine, thyroid hormones, and other hormones causing all these endocrine pathologies, all raises their blood sugar. Now, in patients, how you will suspect this? One, clinical features of these endocrine disorders. Number two, a known diabetic who was on good control, suddenly the control is not there. We think only diabetic cause. There are other causes, or in some patients where there is a severe insulin resistance, from the beginning they don't get control for the diabetes. These are the clues. So initially there is the insulin resistance, primary failure. When it fails, frank diabetes may develop in all the endocrine disorders. We have so many genetic syndromes, I can enlist, and metabolic syndromes where high blood sugar is there, a high index of suspicion must be there. So coming about drugs, there are some people that is first degree relative diabetic, race, those with PCOS, gestational diabetes, high blood pressure, high A1C. These are all the people, they have a more chances to develop hyperglycemia when they take some drugs. All the commonly used drugs raises blood sugar. Remember, some drugs like immunosuppressants, HIV drugs, biologicals, they raise the blood sugar so high, and drugs like glucosamine, thiazide diuretics, they raise the blood sugar marginally, which you can easily tackle. And steroid is a one drug that causes havoc. We should remember, exogenously given steroids. As I said, antipsychotics and antidepressants, they cause weight gain, high blood glucose levels, and elevated abnormal lipids. And thiazide, when you give in a therapeutic doses hypertension, now we listen, the chance of raising the blood sugar is very minimal. But here, when the dose is high, the more the blood sugar rises, the more the low is the potassium, and we should be careful when we use thiazides. So when you use steroids, both endogenous and exogenous, that goes and affects the liver, pancreas, gut, circulating system, and adipose tissue. So it causes glucose uptake reduction. It causes the blood sugar not easily converted to glycogen, and sometimes glycogen may be more broken down, put more glucose in the blood. And when you get a patient with a high glucocorticoid-induced hyperglycemia, initially, depending upon the duration, we can use oral drug, one or more, or at the end, we may have to use insulin on a long run. So therapeutically, if you give a steroid for a patient, up to 2 weeks, you give and stop. HbA axis is not bothered. But when you give it for a long time or the patient misuses, definitely it causes the problem. When patient takes a long-term steroid, do not stop it completely because it reverses the condition. The patient goes into hypoaldosteronism, low blood pressure, lethargy, steroids will be no. So we have to taper the dose. Maybe you can switch over this beta-methasone and dexamethasone to oral prednisolone that reasonably not affecting the HbA axis at the initial stages. The fasting blood sugar is more affected with the glucocorticoids than the postprandial blood sugar. As I said, the excessive steroids affect the liver, gut, pancreas, skeletal muscle, adipose tissue, and blood vessels. As I said, in any illnesses, you will have a high blood sugar where the stress hormone release is more, increased glucose production is the more, glucotoxicity and fat toxicity, lipotoxicity is more. That causes hyperglycemia. In all these situations, inflammatory situations, a lot of cytokines and hepatokines are released, resulting in high blood sugar. There are treatment causes from the patient side, patient causes, disease causes, organ dysfunction, and endocrine causes that causes high blood sugar. We all know about the high blood sugar in stress. When I say stress in medicine, not a psychological stress, a prolonged illness, prolonged infection, trauma, surgery, they are all stress. They induce this excess hormone changes starting from pituitary up to gonads, increasing inflammatory markers, resulting in hyperglycemia. In cardiac problems, when there is an acute cardiac injury, myocardial infarction, myocarditis, acute cardiac failure, infections there, the inflammatory markers are more. Sympathetic surge. Initially, the heart takes little more blood sugar for utilization, but later it fails, there is high blood sugar. In post-infarction, sometimes you will have high blood sugar for a period of weeks. Even that must be addressed. And in trauma, naturally, you will have increased cortisol secretion, peripheral insulin utilization is less, there is finally hyperglycemia. Same mechanism. In all these conditions, the blood sugar is not disposed, not utilized by the muscle or the periphery or any cell, while the blood sugar storage is reduced, problem in the liver. So in pancreas, this is very important. There is a destruction of pancreatic islets, abnormal glucose metabolism, insulin resistance, increased release of counter-regulatory hormones, pro-inflammatory cytokines are increased, there is hypoxia. In any pancreatitis, immediately use insulin to control. If you leave, diabetes mellitus may become permanent. And in children also, this should be addressed. If you leave it, they will become future diabetics. So in the short period of high blood sugar, how will you measure? Routine blood sugar measurement, best is CGM. And fructosamine, though we say which reflects the last 2 months, 2 weeks, we are not using routinely. HbA1c only in a chronic phase. So whenever you think of endocrine cause for a high blood sugar other than diabetes, you always think diabetes first, yes, then thyroid and adrenal. All the three you should not forget. There are surgical stress, drugs used, anesthesia used, preoperative conditions, and patient's factors all raises the high blood sugar. And in perioperative situation, give only insulin. Oral drugs better avoid. If you use metformin, that causes lactic acidosis. When I say lactic acidosis, in a normal person, maybe it's not an important problem, but in situations like this, AKI, hypoxemia, alcoholism, cirrhosis, contrast dye injection, sepsis, shock, where lactic acidosis easily sets in these situations, do not use metformin. In here, perioperative stage, do not use metformin, use insulin. All the oral drugs, you can use it little by little later once the patient recovers from the illness. In anesthesia, again, anesthetic drugs, IV fluids, surgical stress, and anesthetic release of counter-regulatory hormones, they cause high blood sugar. As I said, in surgical stress, there is metabolic derangements and there is endocrine alteration. Now, a practical clue, somebody comes with high blood sugar, you want to control the blood sugar for surgery, they are sending the patient to physicians. Acutely controlling for a few days, what benefit you will have? Metabolic correction and infections. A long diabetic, not controlled properly, having all the complications, when they come to surgery, by controlling the sugar for 2 days, it makes no difference. You will run all the complications. So when you control the blood sugar in a surgery, only 2 things, metabolic and infections. And in orthopedic patient, because of prolonged illness, there is induced hyperglycemia. There is one thing called type A insulin resistance syndrome, which has got some characteristic, obese people, acanthosis, hirsutism, menstrual problems. Here it may be responding to metformin. These are some clinical pictures which I got from an endocrinologist. There is Donahue syndrome, Robertson-Mental Health syndrome. And this is common, lipodystrophy. Anything will cause lipodystrophy, even from the younger ages, diabetes, insulin-resistant conditions, PCOS. In lipodystrophy, definitely the abnormal fat distribution is there. High blood sugar is a long-term complication. These are some clinical pictures given by an endocrinologist. And HIV lipodystrophy, we commonly see as a physician, where it must be addressed where there is insulin resistance, hyperglycemia, and hypertriglyceridemia. Acromegaly, one of the conditions where there is IGT or over diabetes. Cushing's, commonest, they will have high blood sugar in up to 60% of patients. It usually affects all the endocrine things, fat, liver, and muscle metabolism. In thyroid toxicosis, very important, initially it will be an IGT only, then frank diabetes may develop. And as I said previously, in controlled diabetes become uncontrolled, worsened. That gives a clue that there may be hyperglycemia. In all these situations, when I say about other causes, please remember a known diabetic may be missed. A known diabetic may be found for the first time when other conditions are coming into our view. Pheochromocytoma, again, diabetes may come or IGT may come. In pheochromocytoma, again, muscle, liver, and fat are involved. Hyperaldosteronism, there is high blood pressure, IGT, and hypokalemia. The frank diabetes is usually not there, but later it can occur. There are some genetic syndromes. Turner's, Klinefelter's, hemochromatosis, Down syndrome, Lawrence-Moonbiddle, Prader-Willi. All these genetic syndromes may be detected if they have a clinical clue. So to summarize, when somebody comes with a high blood sugar, and maybe it's diabetic, nothing wrong in treating the patient as type 1 or type 2. But when there is a clinical feature suggesting something else, is it an endocrine problem? Or look into all the drugs which he takes. All the drugs may cause high blood sugar. If the drug is a must, you have to give. Commonly, steroids for rheumatoid arthritis, exacerbation. There is no other way except to give. The blood sugar will rise. We have to give drugs for the blood sugar. And there are conditions where you can avoid it for a short period. Unnecessary use of the drugs. But anti-malignant, immunosuppressants, biologicals, we have to give a long time. So this is a net result of awareness. I only give an awareness that there are so many conditions where the blood sugar is high, which we should tackle other than the routine diabetes. Thank you very much.
இங்கே ஸ்லைடு போகலையா போனது இல்லை.
Sincerely thank Dr. L. Gagubati for a wonderful talk. It was very enlightening. The next speaker.
Next, I invite Professor Dr. Panneerselvam to talk on endogenous GLP-1 in diabetic milieu.
Good afternoon to all of you. So at the outset, I thank Vellore API for giving me this opportunity, especially the entire team and my senior colleague, Dr. Vetrivel and Dr. Manikandan. So my talk today is role of endogenous incretins, GLP-1 and GIP in the management of diabetes. Of course, the entire world for the past 5 or 6 years keep on talking about exogenous GLP-1, that is your semaglutide, or tirzepatide and dulaglutide, so many other glutides. How the endogenous GLP-1 is going to help in the management of diabetes is today's topic. Therapeutic understanding of GLP-1 and GIP from 1995, hardly 30 years old. Otherwise, those who have finished MBBS during 70s, 80s, or even 90s, so we may not come across. So I did my UG in 80s and PG in 90s. Then during 90s, it was not there. The hypothesis that inhibition of enzyme dipeptidyl peptidase might constitute a novel endocrine-based approach to the treatment of type 2 diabetes was first published in 1995. The mechanism of action described by Decon et al. In 1995 only involved the specific pharmacological the inhibition of physiological enzymatic breakdown of glucagon-like peptide and glucose-dependent insulinotropic polypeptide, resulting in accumulation of biologically active forms of both the hormones. Otherwise, by blocking the DP4 enzyme, we are going to improve GLP-1 and GIP. What are all the biological effect or therapeutic effect we are coming across for the past 30 years, or after introduction of gliptin from the 2007, almost now 18 years over, what are all the therapeutic benefit we come across? So they regulate islet cell function and mass. Dr. Rabadi informed about away from islets, how the blood sugar is getting raised. Now islet is the main cause. Even away from islet, if hyperglycemia develops due to various reasons, the beta cells should secrete sufficient amount of insulin to overcome that. If beta cells are not secreting sufficient quantity of insulin, automatically the blood sugar will rise. So we are getting GIP from duodenal mucosa K cells and GLP from the L cells of the jejunum and colon. So the incretins, once we take food, it goes to the GI tract, release gut hormone, that is incretins, active GLP-1 and GIP. After reaching the pancreas, beta cells and alpha cells, in the upper one, your glucose-dependent insulin from the beta cells, that is GLP-1 as well as GIP. In the glucose-dependent glucagon from the alpha cells, that is GLP-1 alone. Here, there is no GIP. So both, whenever the blood sugar goes high, it stimulates the beta cells, controls the blood sugar, and suppresses alpha cells. Whenever the blood sugar goes down, it suppresses beta cells and stimulates the alpha cells, by which the normal blood sugar is getting maintained. Suppose their GLP and GIP is degraded by the DP4 enzyme. Once you block the DP4 enzyme, GLP and GIP quantity will go high in the circulation. Endogenous GLP and GIP will go high. See, in natural history of diabetes, not only fasting postprandial blood sugar, insulin resistance, insulin level also coming down, and incretin effect also coming down. Beta cell function also coming down. So incretin effect is one among the pathophysiology of type 2 diabetes. Similarly, in pathophysiology, decreased incretin effect is one among the pathophysiology of hyperglycemia. So what is your incretin effect? If you give oral glucose, the insulin level will be high, and if you give IV glucose, the insulin level will be low. Otherwise, the oral glucose stimulates the L cells and K cells, releases more amount of insulin to keep blood sugar well under control. Whether you give IV or oral, the glucose level is same, but the insulin level is at higher side. So another study also told that in type 2 diabetes, incretin effect is low. So inhibition of DPP4 enzyme. So if you inhibit with the DPP4 inhibitor, acute GLP-1 action augments glucose-induced insulin secretion, inhibit glucagon secretion and hepatic glucose production, slows gastric emptying, increases glucose disposal, and long-term GLP-1 action is increases insulin biosynthesis, promotes beta cell differentiation. Of course, this reference is 2003 reference, before the introduction of gliptins. Multiple actions of GLP-1 act to reduce hyperglycemia. GLP-1 has multiple actions that act to reduce hyperglycemia, including glucose-dependent stimulation of insulin secretion, glucose-dependent suppression of glucagon secretion, slowing gastric emptying, improvement in the beta cell function, increase in beta cell mass, function, and islet neogenesis or new islet formations. GLP-1 treatment has been associated with reduced food intake and reduction in the body weight. So they restore post-meal nutrient excursion to normal, increase early insulin secretion only during hyperglycemia, decrease excess glucagon secretion only during hyperglycemia. Otherwise, physiological control of diabetes with the pharmacological agent. By giving DPP4 inhibitor, your GLP-1 level is going high, physiologically the blood sugar is getting corrected. Reduce excess free fatty acid, decrease in insulin resistance and metabolic abnormality, preserve or increase beta cell mass. Whereas while we used before 2000 sulfonylurea, insulin and metformin, so they are not preserving the beta cells. So this molecule is preserving the beta cells. GLP-1 preserves human islet morphology, control section and GLP-1. Pancreatic islet cultured in the absence of GLP-1 lost organization after 5 days. That is control group. By day 5, 45% of the islet in control culture had lost their 3D structure. Only 15% of the GLP-1 treated islets only lost 3D structure. Otherwise, it is persistently intact. Chronic treatment with the DPP4 inhibitor will attenuate or reverse the loss of beta cell mass and function. Experimental evidence shows DPP4 inhibitor restores beta cell function. Again, 2003 reference. Normalization of beta cells and alpha cells ratio, improvement in beta cell insulin content and improved glucose-stimulated insulin secretion when compared to sulfonylurea by DPP4 inhibitor. Otherwise, these are all the reference before the introduction of DPP4 inhibitor. While we go through the article, we were wondering at that time how this molecule is going to change the scenario. At the end, I will show some of my case records also. DPP4 inhibitor increases circulating levels and prolong the biological activity of endogenous GLP-1, by which the insulin secretion is augmented and glucagon secretion is reduced via glucose-dependent mechanism. So what are all the incretins available? Oral incretins are, otherwise incretin enhancers, various gliptins like sitagliptin, vildagliptin, saxagliptin, allogliptin, there are a lot of gliptins are there. Incretin mimetics, that is GLP-1 analog, that are all parenteral, exenatide, liraglutide, dulaglutide, tasvaglutide, albiglutide, semaglutide and terpisatide is now ruling the global market. Especially semaglutide, Novo stopped manufacturing even your mixed rod pen. They started switching over the semaglutide preparation, your Ozempic and Wegovy preparations. They have closed the, to that level, the semaglutide market is keep on increasing, especially in Western country. They want to thrust that market in India also coming future. But how your so-called gliptins are helping our patients only is the today's topic. So the difference between the exogenous and endogenous, exogenous, that is GLP-1 receptor analog, glucose-dependent insulin secretion, both. Glucose-dependent glucagon static, glucostatic is both. Effect on fasting plasma glucose, almost similar only. Only thing is, this is parenteral, that is oral. Similarly, your GLP-1, etc. But the parenteral is causing nausea, vomiting, sometimes other side effect also. The islet cell enhancers gliptins. Of course, they have studied vildagliptin. After giving vildagliptin, the DP4 activity is vildagliptin drastically suppressed when compared to placebo. And active GLP-1 is at higher side in vildagliptin arm when compared to placebo arm. Similarly, in your active GIP also more at vildagliptin arm when compared to placebo arm. So the glucagon is getting suppressed when compared to placebo arm during postprandial phase. During postprandial phase, if glucagon also at higher side, in addition to meal raising the blood sugar, glucagon also will raise the blood sugar, whereas it is getting suppressed with the help of gliptins. GLP-1 and GIP dual effect on islet hormones. GLP insulin secretion is increased, glucagon secretion is suppressed in high glucose. In low glucose, glucagon level is going high with the help of GIP. Vildagliptin inhibits glucagon at high glucose but increases the glucagon at low glucose. When compared to placebo, the glucagon level is suppressed in high glucose. In low glucose, the glucagon level is going high, so that only they don't develop hypoglycemia, they don't develop gross glycemic variability if you put them on the gliptins. So similarly, sitagliptin and metformin, they improve the pro-insulin to insulin ratio, HOMA beta and HOMA IR also. So from 0.38 to 0.2, 0.39 to 0.6. Similarly, HOMA beta function also getting improved. HOMA IR is also getting reduced in all the three components. So metformin also increases the plasma GLP-1. Metformin promotes synthesis of GLP-1 in addition to your gliptin also. So that there is combination of metformin plus DP4 inhibitor. Both are acting on the beta cells and reduce the hyperglycemia. And by combining metformin plus gliptin, vildagliptin alone 10 picomole of GLP-1, vildagliptin plus metformin almost double, so that only all the companies are coming out with a combination of gliptin and metformin. Not only your metformin and gliptin, acarbose also increase the GLP-1. When compared to control arm, your acarbose arm increases GLP-1 because the undigested disaccharide stimulate the L cells in the colon and jejunum. They release the GLP, and the GLP quantity is going high in the acarbose use. Not acarbose plus metformin also. Metformin, acarbose arm, baseline, 24 weeks and 48 weeks of metformin as well as acarbose, both are increasing the GLP-1 in the similar manner. And voglibose also increase the GLP-1 because same AGI effect. Not only your metformin, GLP, your acarbose and gliptin, PIO and GIP also. Incretin hormone dysregulation contributes to reduced insulin secretion and hyperglycemia in patient type 2 diabetes mellitus. Resistance to glucose-dependent insulinotropic polypeptide action may occur through desensitization or downregulation of beta cell GIP receptors. Studies in rodent cell lines show GIP receptor expression can be regulated through peroxisome proliferation activator receptor gamma. And we hypothesize that treatment with the TZD pioglitazone would improve GIP resistance and increase the insulinotropic GIP and beta cells. We also hypothesize TZD treatment would increase GIP or receptor expression in the human adipose cells. Not only your pioglitazone, fiber-rich diet also, when compared to no meal, oats meal, and diabetes-specific nutrition which are rich in fiber or even vegetable fiber, they also raise the GLP-1. Otherwise, you can increase the quantity of GLP-1, endogenous GLP-1 by various mechanisms, primarily from gliptins, secondary from your metformin, AGI, plus pioglitazone, and your recently fiber diet. Acute GLP-1 effect on beta cell improves the insulin secretion. Chronic GLP-1 effect on beta cells, insulin production and beta cell survival is improved. Glucagon is getting suppressed. Not only 2003 reference, 2013 reference also saying the same. Sulfonylurea, unlike glucose, inhibit the potassium ATP channel, directly causing depolarization of calcium influx, resulting in glucose-independent insulin secretion. What do you mean by glucose-independent insulin secretion? Even the blood sugar goes to 30, 40, sulfonylurea will continue to stimulate beta cells, whereas GLP-1 will not stimulate like that. This differentiates sulfonylurea from our therapies, GLP-1 analog or DP4 inhibitor that work in a glucose-dependent manner. Even though both are acting on the beta cells, the action is different. Restoring or retaining the remaining beta cells, islet cell functions. How to restore the beta cell function by this mechanism? This is one of my patients, year of birth 1979, developed diabetes at 2002. Young age patient, at the age of 23, she developed diabetes. Initially, she was on diet plus exercise plus metformin. Then metformin and Rosi from 2010. 2016, metformin, Pio and Vogli. And from 2020 up to 2024, metformin, pioglitazone, voglibose, vildagliptin. No sulfonylurea, no insulin from the beginning, hence no hypoglycemia. Otherwise, you can retain the remaining beta cell and prolong the beta cell function without causing hypoglycemia. Without using sulfonylurea and insulin, you could be able to control diabetes. That is young patient. This is 1965 year of birth, developed diabetes in 2006. Sulfonylurea 4 milligram already patient was using along with the metformin. We stopped sulfonylurea in 2009. Metformin, voglibose, vildagliptin since 2009. Then metformin, voglibose, vilda plus remo from 2019. Again, no insulin from the beginning. We de-prescribed sulfonylurea. So we are in a better position to de-prescribe sulfonylurea after the arrival of gliptins, after the arrival of AGI, recently SGLT inhibitor, and we could be able to persistently monitor blood sugar and maintain blood sugar. The so-called progressive nature of beta cell failure is not there. It was up to the year 2000 only. So after the year 2000, the available molecule, available understanding, monitoring system, making us to maintain A1C throughout their life in normal range without hypoglycemia.
5 more minutes, sir. 5 more minutes.
Yeah. Type 2 diabetes from 2000. This patient is having type 2 diabetes from 1979, almost 46 years of diabetes duration. He had glibenclamide. Glibenclamide stopped in 2007. 2007 to 2010, metformin plus Rosi acarbose. Then subsequently metformin, acarbose, vildagliptin, not on insulin, not on sulfonylurea, no hypoglycemia. He had a COVID infection. At that time, his blood sugar went high. Subsequently, the blood sugar is persistently normal. Even though his age is now 83 or 84 years, even though he has diabetes for 46 years of duration, there is no insulin requiring phase. After 10 to 14 years of diagnosis, all patients will land up with the insulin requiring phase. They lose all beta cell function. Those informations are correct up to the year 2000, 2003 only. But it is getting corrected or reverted now, even though the duration is 46 years, we are in a better position to control diabetes with the help of non-sulfonylurea molecules and non-insulin molecules. This patient had insulin, 35 units 2 times, year of birth 1934, now 91 years. She developed diabetes at 89. While she came to me, premix insulin, which was on premix insulin, 30 units morning, 30 units night. We withdrew insulin and put her on metformin, voglibose, vildagliptin. Insulin requiring type 2 diabetes become insulin independent type 2 diabetics. So to that level, the modern understanding of molecules, modern use of molecules and monitoring system have improved. Vildagliptin for effective glycemic durability. These outcomes propose DP4 inhibitor confers better durability of glycemic response than sulfonylurea in patients type 2 diabetes. DP4 inhibitors have better islet cell preservation function compared to sulfonylurea. DP4 inhibitors such as sitagliptin, which prevent the rapid degradation of endogenous GLP-1 for the treatment of type 2 diabetes. Of course, your pancreatic beta cell GLP-1 acts to enhance glucose-stimulated insulin secretion, and it has also been shown in the beta cell mass via increased proliferation and decreased apoptosis. Recent studies have implicated role of GLP-1 in the regulation of cell survival via alteration in the autophagic signaling in the both pancreatic cells. The last line is DP4 inhibitor demonstrated durable effect on the pancreatic islet cell mass or insulin content, while this effect was not seen in sulfonylurea. Furthermore, combination treatment of DP4 inhibitor with either thiazolidinedione, alpha-glucosidase inhibitors resulted in increased pancreatic insulin content compared to either agent. Of course, this reference only in 2011, but we are using this combination from 2005 or 2007. Long-term improvement in the beta cell insulin secretion, same mechanism here. So the management of type 2 diabetes, before UKPDS, after UKPDS, Incretin deficiency was not appreciated. Incretin deficiency now appreciated and corrected. Incidence of hypoglycemia and complications were more. Both of them are very much low. Achieving A1C less than 7 was difficult job. So if you upwardly titrate sulfonylurea or insulin, 20 to 30% will face hypoglycemia. They stop treatment. We also fear to treat patients. But now we are better positioned to achieve A1C less than 7 always, without hypoglycemia. So let us shift the management of type 2 diabetes from control of the disease and treatment of its complication to prevention of the disease and arresting the further progressive loss of beta cells. Retain the remaining beta cell, give relief to the remaining beta cells, save the remaining beta cells, or restore the beta cell, allow the individual to live with the remaining beta cells. The medication used to treat type 2 diabetics should preserve or improve beta cell function, or it should not spoil the remaining beta cells. If you treat them with sulfonylurea, they spoil. If you allow chronic hyperglycemia, intermittent hyperglycemia, they spoil the beta cells. The combination approach focusing correct insulin resistance, beta cell security defect, and hyperglycogonemia seems to be superior and safer than sequential therapy with metformin, sulfonylurea, insulin, which was yesterday's therapy. Even though diabetes is a progressive disease, there are a lot of evidences to prevent, revert, retard, and keep it always under control. By doing so, we could avoid complications of diabetes. So summary, durability of glycemic control is an important parameter that needs to be considered in diabetes management. Endogenous incretins are showing better durability in clinical practice. Of course, exogenous incretin, we have 5 years of experience, that too Western experience. If you use exogenous incretins, invariably many of them are developing nausea, vomiting, etc. More and more studies are needed to understand durability of various anti-diabetic medications in the clinical setting. Options available to clinicians today for management of hyperglycemia have changed dramatically in the last 2 decades. The selection of best medication or combination of medication for effective glycemic control, while based on science, remains largely in the realm of art. The artist here is being the clinician, especially physicians who are handling the hyperglycemia. So thank you very much for your patient listening, and thanks for giving me this topic. Thank you.
Thank you very much for the excellent lecture.
Right.
You enlightened the maximum utilization of endogenous incretin by using gliptins, metformin, and garbos.
Yes, sir.
Thank you, sir.
Thank you, sir.
Now, may I request the speakers to come on stage for questions, please. Now it's open to the audience, please.
I think one comment for each. You mentioned about the clothalidone. I think 6.25, when you talk about the treatment of hypertension, one should try to prevent the target organ damage. If you take the chronology of hypertension treatment, only 2 drugs, ARBS and clothalidone, are the best drugs to prevent left ventricular hypertrophy. I think we are underusing the small dose clothalidone, which is so excellent, doesn't produce, as you rightly said, the hyponatremia or hypokalemia with that dose. So I think the starting drug should be important. In Indians, we should use a drug which really proves to prevent left ventricular hypertrophy. And the next speaker is the one, you are talking about drug-induced hyperglycemia versus drug-induced diabetes. The terminology is different. Suppose you use a steroid-induced hyperglycemia, steroid-induced diabetes. Steroid-induced hyperglycemia is in a patient who had already a diabetes, the sugar level goes up. It's called steroid-induced hyperglycemia. When you say steroid-induced diabetes, some of the potent steroids like your methylprednisolone, dexamethasone, they can sometimes cause even diabetes. I think that's the difference. I think the endocrine causes all come on type 3 diabetes. They're not called non-diabetic, I don't know. I think there was a mixing up of the terminologies. How can you compare exogenous GLP with endogenous? It's only 0.5. DPP4 potency is only 0.5 or 0.4. Whereas the exogenous twin creatine is excellent. I tell you, some of the patients were on now the liraglutide is so cheaper. So So much put in and
That
then...
is purely theoretical.
No.
Article writers view, not the clinician view.
No. I'm just telling you. I don't know. You mentioned the 12.5 A1C comes to 7
Not
with
only
the,
reducing, sir, maintaining is more important.
No.
That is the more important. That we
because
also
when you
understand.
add a therapy to a patient, the guidelines are there. Whenever there is a patient who's got a A1C more than 9.5,
No, subsequently we are pulling down the molecule.
you have to definitely bring down the glucotoxicity, then add the OHS. That's how the drug acts. Thank you, sir.
Sir, I do feel that we Indians respond much better than Caucasians to DPP-4 and GLP analogs.
Thank you, sir. In view of time, I think we'll time to honor.
Thank you very much.
Yes, sir. Otherwise, the message for youngsters, not only correcting the blood sugar at that time, by whatever molecule you use, whatever pathophysiology, but persistently it should be monitored and maintained. That is more important. Without causing hypoglycemia, now the mechanism is available, drugs are available, that every, at least physician should understand.
We rightly agree with you, sir.
Sir?
We rightly agree with you.
Thank you, sir. Yeah, glycoside is comparatively better, sir, even when compared to glimepiride. As you said, I use only 20 milligram of glycoside to maximum 40 milligram of glycoside and use 0.5 milligram of glimepiride only, not more than that. If somebody use 4 milligram BD or 2 milligram BD, I criticize them.
You are more worried about hypo, sir.
Not hypo. They spoil the remaining beta cells.
Exactly, I agree with Paneer, sir. So smaller the dose, durability is more.
Thank you, sir. Thank you for the excellent discussion, sir. Now it's time to honor the speakers. I request Dr. Jawar, sir, to honor Dr. Binu, sir. I would expect Dr. Charan MM to honor Dr. K. Raghupati, sir. Chairperson. I request Dr. Balakrishnan, sir, to honor Dr. Paneerselvam, sir. I request Dr. Binu, sir, to honor Jawar, sir. I request Dr. Raghupati, sir, to honor Charanyam. And Dr. Paneerselvam, sir, to honor Dr. Balakrishnan, sir. Thank you, sir. We'll move on to the next session, infectious disease and sepsis. I invite Dr. Joseph Rajan, sir, from Ramnath, sir, to chair the session, and Dr. K. Shanmugam, sir, from Chennai, and Dr. K. E. Sampath, sir, from Vellore, to chair the session. First topic, I invite Dr. D. Suresh Kumar, sir, from Chennai, to speak on the topic prudent use of antibiotics in clinical practice.
Good morning to everyone. This is one of the very important topics of API. I think the hall should have been full. Unfortunately, it's not so. But I think to kickstart, Vignesh has already started out very nicely from Vellore about how do we classify sepsis and what are the criteria where the sepsis will do well or do not do well in the ICU setup. I think that with that one, I think that we can take that as a note of address, and then we'll follow with Suresh. And it's going to be very interesting. That is very vital also for all young physicians. Prudent use of antibiotics in clinical practice. Over to you, Dr. Suresh.
Good morning. I sincerely thank Tamil Nadu API as well as API Vellore for giving this wonderful opportunity, and I thank my chairpersons for also introducing me there. Thank you. So thank you. So I'm going to talk next 15 minutes what we are going to do with how to use the antibiotics prudently there. Before that, my disclosures, we are ID docs. I don't have any shares in any of the antibiotic company or other companies there. Okay, so this is a case here, 73-year-old female, known case of CA ovary, treated 2 years back. Now fever of 3 days durations, body pain of 3 days durations. Weakness, loss of appetite, sore throat is present, no dysuria, no urgency. Past medical history, she has completed the surgery as well as chemo in 2023. Last couple of years on regular follow-up. Recent follow-up happened 5 days back that showed normal. Now she presented with a 3-day history of fever and body pain. On examinations, febrile, soft, rest of system examination was normal. WBC count was ordered, that was normal. And urine cultures growing, 1 lakh colony counts of E. coli, sensitive to nitrofurantoin and meropenem, but unfortunately resistant to ceftriaxone and piptazo. What will you do now? How many says, I want to start antibiotic? Patient is growing 1 lakh colony count of E. coli. Because want of time, I just want to lift of hands there. So no, it is asymptomatic bacteria. Nobody? Maybe. Yes, a lot of maybe. I need to assess the patients. Your assessment is not good. Okay, I don't know. Okay, good. This is a second case here. 60-year-old male, type 2 diabetes mellitus, systemic hypertension, admitted for CVA. Subsequently, the person was intubated for low GCS. Finally, the person went tracheostomy because not able to wean off. Then finally, now is weaning off from the TPs with 1 to 2 liters of O2. The patient has got central line and arterial line, Foley catheters on day 10, fever 1 episode of 99.8. Immediately, the WBC count was ordered, WBC count was elevated. Patient has got pan culture, they send ET cultures growing candida. Urine is growing Acinetobacter carbapenem resistance. Blood cultures, 1 out of 4 bottles is growing coagulase negative staph. How many say, does this patient definitely need antibiotic? This is an hospitalized patient, I want to start. Okay, no, this is only coagulase negative staph. We treated a lot of staph, coagulase negative is not bad. Maybe, okay, I need to assess. Nobody this one to not assess this case there, I don't want. Fine. So my objective is, what do you mean by prudent use of antibiotics in your practice? Why the prudent use of antibiotics and how to use is easy to say, but how to use prudent use of antibiotics and what is the way forward, I'll come back and explain in the next couple of minutes there. So Google one says, I tried ChatGPT. ChatGPT is also not answering appropriately as far as antibiotic decision is concerned. But compared to Google, ChatGPT answers are slightly better. So what do you mean by prudent? First, English definitions. What is prudent? We need to be careful. We need to be careful in selection of something. That's called English dictionary, Cambridge dictionary says. But what our group says, the REACT groups is one of the antibiotic groups. What it shows, avoid inappropriate use of antibiotics. You need to be judicious, you need to be careful. You need to avoid inappropriate use of antibiotics. That's the point they made. So you try to avoid inappropriate use of antibiotics. That is called prudent use of antibiotics. When people ask what is inappropriate, what is appropriate, the right patient should get the right antibiotics, right time, right dose, and right durations, we can put it. So right patients, right antibiotic, right dose, and right durations. That is called prudent use of antibiotics. But the problem is, it's finding out the right patient is the most difficult and most challenging there. In particular, in a BC practice, it's a bit difficult. So why we need to use antibiotics? This is what my practice has started in 2003 when I started my ID practice. That point of time, carbapenem, so if you see the last column, this is a BC slide. If you see the carbapenem, meropenem, 99% sensitive. So any patients come sick to you, if you start carbapenem like meropenem, the person will improve. What happened in 2013? I'm not talking about 2025. I'm talking about 2013, a decade old. What happened to the meropenem? Meropenem is 50% sensitive. What it means, you need to toss a coin. When the person has got head, meropenem will work. Tail, the meropenem will not work. So this is the situation in 2013. In 2025, the situation is even worse than now. That's the problem we are facing. People will ask, what is a big deal? When the meropenem is not working, what is a big deal? People are asking. This is a big deal. Again, this is a busy slide. What will you see? The last column. When a person develops resistant organisms, what happened? Despite the person in one of the best tertiary care hospitals, almost all the facilities are available to him. What happened to the patients once he got a carbapenem resistance or colistin resistance bacteria? Expired, lost to follow-up. Lost to follow-up, does not have money to sustain. So once you got a resistant bacteria, despite all the facility, we can't make the person alive. So this is a real killer. This is a pandemic we are living in now. That is why we need to use prudent use of antibiotics. Otherwise, you can have PCIs, you can a lot of interventions, a lot of new molecule come into place. But unfortunately, the patient will not alive once the person got resistant infections. So coming back to this case, people said, I want to start antibiotic. What antibiotic you want to start now? How many say I will start nitrofurantoin, keep simple? Okay. I'll start meropenem. Slightly better, but even though meropenem resistance is going up, fortunately she is sensitive meropenem. Okay. Do CT ultrasound abdomen to decide. Any imaging? No, I need to do SARS-CoV-2 test. Again, coming back to the corona now. All of the above. None of the above. My route is different. All are stuck. Okay. So the first thing before we're deciding prudent use of antibiotic in infectious diseases is assess the sickness of the patients. This is the most important thing failed to teach in medical schools. First thing, when you come across the patients, leave the history, leave the physical examinations, assess the stability of the patients. When the person is stable, you can take a proper history and do examinations. If the person is unstable, stabilize the patients. Unfortunately, this is not taught most of the time. We talk about history, physical examinations, investigations. Assess. How to assess a severity? Simple vital parameters. Check the conscious level, check the BP, check the respiratory rate. That's called QSOFA, quick sequential organ failure assessment. Out of 3 parameters, 2 parameters is high. The person needs stabilizations or assessment. That's more important rather than going for investigations or treatment. So first thing is the stability of the patients. Second thing, for a prudent use of antibiotic, write the diagnosis. What do you think? That's more important. What do you think this patient has? Unless you write the diagnosis, never think about antibiotics. Always think this is called the 4 moments of antibiotics. First thing, I need to write the diagnosis, send the appropriate sample, whether the antibiotic needed or not, cut down the durations of antibiotics, short is sweet, do not irritate the bacteria. These are all the things essential in your practice now. So how to make a diagnosis? Diagnosis is most of the time is difficult. That's why I said right patient is the most difficult thing. We need to behave like a STD physicians. They never say syphilis, they never say herpes, they never say gonorrhea. What they used to say, genital ulcer, genital discharge, genital syndrome. That's what they put, genital swelling. That's what they put it. That's called syndromic approach. That's what we need to do in our clinical practice. Person has got fever, cough, sore throat, put URI. That's more important, or pharyngitis or pharyngotonsillitis. Person has got fever, dysuria, urgency, UTI. So put the syndrome. That's more important. If you think syndrome, we need to know what bacteria to think. Any infections above the diaphragm, always I need to cover gram positive. Any infections below the diaphragm, I need to cover gram negative. For example, urinary tract infections, I need to cover gram negative. Infections of pneumonia, endocarditis, gram positive is needed. So we need to think about the syndrome. That is more important for you. Coming back to this case, what will you do now? So the person has got fever. So what syndrome you put it here right now? So a lot of clues I given here. So these are all the clues. Absolutely no urinary symptoms. Don't treat urine cultures. Don't treat the paper. We need to treat the patients. We use one score called bladder score. Urinary bladder means bladder is a mnemonic. What is a bladder score? B stands for blood in the urine. L stands for loss of continence. A stands for abdominal pain. D stands for dysuria. There are 2D bladder, BLADD. So D scores for 2 scores, 2 points. B 1 point, L 1 point, A 1 point, D got 2 points. E stands for elevated temperature. R stands for recurrent of urine or frequency of urinations. Out of score of 7, at least a person should score 4, then I can think about it. I not make the diagnosis of it. So this is called bladder score in a community acquired patients. If the score is 0, 1, 2, don't treat the patients. Don't treat the urine cultures. That's what I say. So this person has got no urinary symptoms. Recent hospital visit, that person now SARS-CoV-2 is seen last couple of months there. Acute fever, weakness and sore throat and loss of appetite, all pointing towards viral fever. So that's what it may be. WBC count is also normal. I need to check the urine routine if the doubt is there. Urine routine shows no pus cells, rules out UTI. That's what we need to do. So this is an algorithm we need to follow. Assess the stability. Try to localize by means of syndrome. If you are able to localize, because based upon your localizations, here my localization is acute upper respiratory tract infections, not UTI. That's what I need to do. So when to use prudent use of antibiotics in OPD settings? When a person has got acute undifferentiated fever, more than 7 days, yes. Some syndromes like UTI, meningitis, yes. Pneumonia is always catchy. Whether viral pneumonia, bacterial pneumonia is difficult. AG, acute gastroenteritis, more than 6 episodes of stool, presence of fever, blood in the stools or mucus in the stool, yes. When the person has got very elderly, young persons, for example, newborn or neutropenic, that point of time, yes, I need to think about it. Otherwise, it's a bit difficult for me. When you should not start antibiotics, when a person is a healthy patient, stable patients, vitals are stable, make a diagnosis rather than starting on antibiotics. This is a simple rule. I'll come back and explain later part also. So this is the second case I shown here. So what will you do? What's your diagnosis now? The person has got fever here and person has got ET candida. How many want to treat ET candida here? In your practice, remember people are practicing in ICU, ET cultures, BAL cultures, candida is growing, never treat. Candida will never cause pneumonia in a healthy person, ICU person, don't think about it. Candida will cause pneumonia only in 2 situations that you cannot encounter, either lung transplant patients or post-hem transplants with graft versus host disease, that point of time. Otherwise, for practical ICU patients, ET cultures growing candida, just throw it. Only we can consider as a risk factor, but not as a pneumonia. These things you should remember. So here, what is the diagnosis here? We need to think. So not only the prudent use of antibiotics, what happened when you send pan cultures, ET is growing acido, put on antibiotic. ET is growing candida, treat on antibiotics. This is what happened. 12 cultures happened. When I went and saw the patient has got only thrombophlebitis. Only the person has got thrombophlebitis. I said, stop antibiotics. They exhausted all the things. They called me at the end of 12. What do you want to do? I said, stop antibiotics. So usually diagnostics also need some stewardship, prudent usage. You don't rush your diagnostics. The fever panel people usually send for community acquired. Use your mind. We are against panel. Don't send the panel. If you don't have brain, you can use a panel. If you got brain, use the sensitivity. What is your diagnosis? Sends it. So how to make a prudent diagnosis? For example, if you think the meningitis, the ideal test is CSF. If you are not able to send the CSF, do the blood cultures. Urine UTI suspect, urine routine along with culture. Urine routine is very vital. If you think the person has got pneumonia, usually if the person improves, there's no need for it. Otherwise, at least you can go for sputum staining and cultures is required. So this is what we need to do. So coming back to this case, what will happen? The person has got diabetic, coronary artery disease, fever, altered mental status. Past medical history, recent THR 10 days back, catheterized. Confused, hypotensive, tachypneic, WBC count elevated, creatinine 2.6, urine cultures, 1,000 colonies of Klebsiella pneumoniae, sensitive to tigecycline, chloramphenicol, polymyxin B is intermediate, ceftazidime is resistant, ceftazidime avibactam and aztreonam resistance. What will you do now? I just spent 30 seconds. How many say absorb antibiotics? I told threshold to start antibiotic when the person is elderly, when the person is sick, shocky, my threshold should be low. I can't say antibiotic is not required all the situations. Depending upon individual situations, this person might require because encephalopathic, person is hypotensive, elderly. Supportive care, I don't think so. Okay, what's the choice? How many say tigecycline or chloramphenicol? How many say chloramphenicol? How many are using chloramphenicol? Recent last 5 years, anybody use chloramphenicol? I use chloramphenicol a lot there. Fine. So 75 years, multiple comorbid situations, recent THR, Foley, sick, confusions, hypotensive, he needs antibiotic, definitely he needs antibiotic there. So in the sepsis, don't write sepsis alone. When you write sepsis, what is the individual? This person is a diabetic, person has got multiple comorbid, recent THR, catheterizations. As a result, the person has got fever, confusions, altered mental status is going on. Even when the person's symptomatic UTI, 10 colonies of bacteria is very important. 10 to the power of 2 is important. Not think 10 to the power of 5. 10 to the power of 5 only for asymptomatic bacteria. For other persons, 10 to the power of 2 is enough. Right antibiotic depends upon the spectrum. For example, tigecycline will not go into the urine. Tigecycline go into the liver. Chloramphenicol is a good drug, I told, for meningitis, not for UTI. Because chloramphenicol also not go to the urine. That's more important. Second thing, this is called the PKPD, whether the antibiotic will reach. Ampi and amoxicillin both are same. Ampicillin go to the brain, amoxicillin will not go to the brain. That is more important. Use a maximum dose. For example, what is the dose of cefotaxime you are using? 1 gram BD. Who invented the dose of 1 gram BD? 100 milligram per kilogram per dose. That means minimum 6 grams to 8 grams per day is required. Unfortunately, all people are using 1 gram BD. So 100 dosing is problem there. So we need to use a maximum dose, but minimum durations. Pneumonia needs 3 days treatment. UTI needs 5 to 7 days treatment. Bacteremia needs 5 to 7 days. Do not irritate the bacteria. Do not irritate. Think that a bacteria is a cheap thing. No. Bacteria is most intelligent creatures, living more number of years compared to you and I lived in this world. Number of cells is more. So don't underestimate the bacteria. Do not irritate. That's most important thing. So why you need to be prudent of use of antibiotics? Definitely your patient need to walk back vertically. You should not go horizontally, your patients. And you need to go by what mode of communications used to come to the hospitals. A lot of lawsuits are available right now. So better to go with whatever car or whatever modality you come to the hospitals, you need to go to avoid lawsuits. So that's why we need to learn it. And that's the indications I told when to start and when not to start. Those who are not attended these type of books, we are writing it. We can follow it up and get these books and follow it up. Simple algorithms written there. And those who want to follow daily basis of infectious disease, coming to Tapicon is a bit difficult, and organizing Tapicon every year is a bit difficult. Yes, come learn this through the QR code, you scan it, fill the details, we can get the newsletters. Short certificate course is right now is going on. Today 7:30 also the session is there on HIV. So you can have all in your mobile itself there. You can learn the infectious diseases from your mobile and you are ready for your certificate course also there. Thanks for the wonderful opportunity and thank you for the opportunity. Thank you.
Thank you very much, Suresh. I think that I felt as if I am in a Mayo Clinic where they talk for two minutes a talk. I think that you have condensed everything. I think the hall is full now. I think we will be back here and I thought Vicky can also join if he is there because he started off with a good sounding note about how do we manage sepsis. Thank you very much, sir.
I invite Dr. M. Nataraj from Thiruvarur to talk about update on current sepsis guidelines.
This is a slide change, huh? Okay. Good morning to everybody present here, and I thank the organizers for giving me this opportunity and thank the chairpersons for their introduction. And today the talk is going to be on update on current sepsis guidelines. So the sepsis guidelines has evolved over a period of time continuum. From 2000 they are framing it. And my objective of the talk is Surviving Sepsis Campaign 2021 Guidelines, which is the last guidelines which has been released. And what is a new definition of sepsis and septic shock? And I'm going to speak on the topic of screening and early treatment. What is the recommendations followed? Infection and source control, hemodynamic management, the ventilation strategies, additional therapies to be followed, long-term outcomes and the goals of care which has been introduced new into the SSC 2021 guidelines, and what are the recent advances in the management. So this SSC 2021 guidelines have been framed for the management of sepsis and septic shock, and they have given nearly 93 recommendations, both strong, weak and best practice statements, and only very few I'm going to discuss about this here. So this is a timeline. In 2002, in Barcelona Declaration, they started this SSC campaign, in which 2004 they formed this adult guidelines, and every 4 years, based on the evidence-based large multi-center trials, They are updating these guidelines, 2008, 2012, 2016 and 2021 as the last guideline. Most probably they have given us 2025, it should be the next guideline based on the latest updates. So this sepsis guidelines goes from strong recommendations to weak recommendations and no recommendations and best practice statements also. And here they have highlighted 6 sections, already I have said about them. The long-term outcomes and goals of care is a new highlighted section in this 2021 guidelines. What is the new definition of sepsis? Previously, it was the sepsis continuum, sepsis 1 definition, sepsis 2 and sepsis 3. But SIRS and severe sepsis have been removed from this. It is obsolete now. What they say is sepsis itself is severe sepsis. So it is a life-threatening organ dysfunction caused by a dysregulated patient response to an infection. In lay terms, it is when the body's response to infection causes injury to the own cell and its organs. So what is septic shock? Is seen in patients with sepsis. It is a subset of sepsis which develop with an circulatory and metabolic abnormalities resulting in hypotension, which require the use of vasopressors to maintain a MAP of 65 millimeters of mercury and a serum lactate level of 2 millimoles per liter, even after adequate volume resuscitation. That is very important. So this is a new definition. It is a life-threatening organ dysfunction caused by a dysregulated host response to an infection. So infection with an increase of 2 or more SOFA points. As Sir said, Q SOFA score is used for screening. But to diagnose, we need a SOFA score. A subset of sepsis with particularly profound circulatory, cellular and metabolic abnormalities associated with an increased mortality than sepsis alone. Infection with hypotension requiring vasopressors, as I said, to maintain a mean arterial pressure of greater than 65 plus a lactate level. Nowadays, measuring lactate is a part of this sepsis protocol. Again, in the absence of hypovolemia, if the patient is suspected to have sepsis plus need a vasopressor or the lactate level is greater than 2 millimoles, we call it as septic shock. Screening, what is a newer recommendation? They have recommended against using Q SOFA score alone as a single screening tool for sepsis or septic shock compared with SIRS, NEWS and MUSE score. That is the main thing. They have gone for with Q SOFA score as the initial screening method. I am coming to it. The quick sequential organ failure assessment score is HAT. We have to remember it. Hypotension, altered mental status and tachypnea. 2 greater than 3 score is indicative of screening. We have to suspect sepsis, but it has to be confirmed with SOFA scoring. This is a SOFA score. All the 6 organ system will be involved. Respiratory system, coagulation, liver, cardiovascular, central nervous system and renal. They grade from 1 to 4 and total 24 scoring is there. If this is describe and quantifies the organ failure SOFA score, it predicts the outcome. It is used to triage strategies. So initially a SOFA score is 9. The mortality is predicted to be 33. But if just a 2 increase in SOFA score, the mortality goes to 95%, nearly 100% mortality. That is very grave. When you are treating a patient in ICU, if you see an increase in SOFA score, the mortality is increasing great. So the main thing in this recommendation, what they have given, if a patient is seen in ICU, if the patient is having an infection, you have to use only SOFA scoring. 2 or more SOFA points above the baseline indicates sepsis. But if it is outside ICU, in a ward or OP setup, if there is an infection and 2 or more Q SOFA points is enough to identify a sepsis. So this is a diagnostic algorithm of sepsis. Any patient with suspected infection, Q SOFA score you have to see. If it is greater than 2, then you have to go for evidence of organ dysfunction in the form of SOFA scoring. If it is greater than 2, you have to suspect sepsis. And despite the adequate fluid resuscitation, if the patient requires vasopressors and the lactate is more than 2, we have to say it is a septic shock. What is the early treatment? Sepsis bundles have been framed over time to time. Initially in 2005, they framed 6 hours and 24 hours resuscitation bundle, sepsis, and 2013, 3 hours and 6 hours. Now everything is obsolete. What they say in 2018 is sepsis 1 hour bundle. This is very much important. What you are going to do in 1 hour bundle? This is like a golden hour. What we feel in MI, script program and trauma. Now for sepsis also the golden hour has come. For initially when you see a patient, you suspect the sepsis, that is called as a 0 time. And you have to measure the lactate level immediately. In ABG, most of the hospitals have a lactate level. If it is greater than 2 millimoles, we have to obtain blood cultures and start antibiotic, broad spectrum antibiotics immediately. We have to, if the patient is hypotensive, we have to give 30 ml per kg of crystalloid fluids. What balanced crystalloids they say, for over 1 to 3 hours to resuscitate. If the BP is not maintaining and still the patient is in hypotension, we have to go for vasoactive agents, plus you have to maintain the mean arterial pressure of 65 millimeters of mercury. So what is the recommendation? Difference recommendation. In 2021 recommendation, they say 30 ml of kg of IV crystalloid should be given for the first 3 hours. And simple bedside tests like capillary refill time should be tested. If it is greater than 2 to 3 seconds, our fluid resuscitation is not enough, so you have to continue it. If the BP is not maintaining, we have to go for vasoactive agents. Later will come. Infection, as sir said, we have to find out which source of infection is there. Appropriate microbiological culture should be taken and it should be sent for testing. So source control, we have to identify whether it is an abscess, it has to be drained. Necrotic tissue, it has to be removed, and any intravascular devices, it has to be removed if we suspect it as a source of infection. So antibiotic timing is very important. Irrespective of definite sepsis is present or it is a possible sepsis, if the patient is in shock, you have to administer antibiotic, broad spectrum antibiotic within the first hour. If you suspect sepsis is possible and there is no shock, we have to assess for an infectious, otherwise a non-infectious cause of illness, which could have caused this sepsis-like picture. So anyway, we can re-evaluate within 3 hours, and you have a high suspicion of sepsis, you have to give an antibiotic now. So sepsis is like a medical emergency, golden hour, first hour. So this graph shows each and every hour delay in administering an antibiotic will cause an increased mortality. Even after 36 hours, the mortality goes up to 100%. So what is the 2021 recommendation? Septic shock, high risk for MRSA organism, we have to give an antimicrobial with MRSA coverage. Low risk for MRSA, they suggest against using an antimicrobials with MRSA coverage like vancomycin and linezolid. And if you suspect high risk for multi-drug resistant organisms, you have to give 2 empirical antibiotics with gram-negative coverage. 2 antibiotics they are asking. If there is low risk for multi-drug resistant organisms, only 1 antibiotic with gram-negative coverage is enough. And if there is high risk for fungal therapy, there is fungal infections, what they recommend is empiric antifungal therapy is required. Low risk, do not go for antifungal therapy. So these are the risk factors for fungal infections like neutropenic patients, immunosuppressive patients, a long stay in ICU patients, and patients on total parenteral nutrition. If you feel they are at risk of fungal infections, you have to give antifungal therapy. Antiviral therapy, no recommendation has been given. So main thing is, do not use biomarkers like procalcitonin to start an antibiotic. That is very important, they said. To start an antibiotic, do not require an procalcitonin. Only clinical judgment is enough. What is the duration? Antimicrobial treatment duration of 7 to 10 days is adequate for most serious infections associated with sepsis and septic shock. Procalcitonin, we need not required to start an antibiotic, but for de-escalation of our antibiotic and for stopping the antibiotics and deciding the duration of antibiotics, procalcitonin is definitely useful. That is what is given. To discontinue an antibiotic or to decide the duration of antibiotics, this procalcitonin marker is very much useful, not for starting an antibiotic. For hemodynamic, so as we suggest, immediately if the patient is found to be hypotensive, we have to give 30 ml of balanced crystalloids like RL or ringer acetate, then plasmalate solution. No need to give particularly this normal saline because it can produce hyperchloremic acidosis. And they suggest using dynamic measures like passive leg rising for monitoring instead of CVP monitoring, because if this passive leg rising, the patient's cardiac output improves, stroke volume improves, and the pulse pressure variation improves, then still the patient needs some amount of volume to be replenished, you can go for it. So there's a simple test what they have to guide whether the patient is fluid responsive or not. Then resuscitation fluid type, ringer lactate, ringer acetate, and plasmalate better. NS is associated with hyperchloremic acidosis. These are called as balanced crystalloids, which has been given in this SSC 2021 guidelines. Albumin, if a large amount of crystalloids have been given, you can go for colloids. It's the best colloid, what they say, but you have to be very cautious in using albumin. What is a vasoactive agent? In spite of adequate fluid resuscitation, also the BP is not picking up. Then we can go for norepinephrine is the first choice given in a sepsis guidelines. That to achieve a target of mean arterial pressure of 65 millimeters of mercury. Okay, how to monitor it? We have to go for an invasive monitoring of arterial blood pressure. In an ICU setup, that is much better. Okay, if norepinephrine, if an adequate dosage has been given, the BP is not picking up, you have to add vasopressin. And peripheral line is itself enough to start a vasoactive agent. We need not wait for a central line. And if the patient is having myocardial dysfunction, you have to go for dobutamine, add dobutamine instead of vasopressin. So ventilation strategies, what are the new thing in ventilation? High flow nasal cannula, which have been using in COVID-19 patients. This is recommended for all sepsis patients, then even non-invasive ventilation, to avoid invasive ventilation to the last resort, Both therapies, that is both high flow nasal oxygen therapy and non-invasive ventilation is better to avoid the complication. But much better is this high flow nasal oxygen therapy, because the work of breathing is good, it improves, FiO2 is improved, and the patient can avoid NAV complications. So it is better to use high flow nasal cannula. What are the other recommendations they give regarding ventilation strategies? We have to use a low tidal volume in the ventilator, 6 ml per kg. The plateau pressure should be below 30 centimeters of water to avoid ventilator associated lung injury we have to avoid. Then high PEEP should be kept, and we have to go for prone ventilation for more than 12 hours per day on ventilators. The patient is ARDS on ventilator, like what we have done for COVID patients. So this is the main thing given regarding the ventilation strategies. Regarding the neuromuscular blocking agents, which has to be given in bolus, not as a continuous infusion. And finally, if the patient is not able to be maintained on the conventional ventilator therapy, you have to go for veno-venous ECMO, if the facilities are available to support the lung. What are the additional therapies which is used? See, the recommendation suggests that IV corticosteroids will be useful, particularly hydrocortisone, 200 mg per day, 50 mg IV QAD, if the patient has been adequately resuscitated with volume, proper volume resuscitation has been done, and in spite of vasoactive agents for 3 hours, the patient is not able to maintain a mean arterial pressure, you have to give IV corticosteroid. It is found to be much useful, and it has produced a decrease in mortality in most of the sepsis patients. Red blood cell transfusion targets. Actually, liberal versus restrictive strategy is said, but the newer guidelines have said restrictive strategy. That is, if the hemoglobin has fallen below 7 gram per deciliter, then go for packed RBC transfusion. Otherwise, do not go for packed RBC transfusion. See, for adult with sepsis shock, we suggest against using intravenous immunoglobulin. Previous recommendations they have given intravenous immunoglobulins, but it is obsolete now. And stress ulcer prophylaxis with PPAs can be used. And the venous thromboembolism prophylaxis is there. It is mainly pharmacological VTE prophylaxis, particularly with low molecular weight heparin over unfractionated heparin, and don't go for any mechanical VTE prophylaxis like pneumatic compression stockings. Bicarbonate therapy for lactic acidemia, do not use bicarbonate therapy because it can even kill a patient. For other acidemias, severe metabolic acidemia, with an AKA, you can use bicarbonate therapy. What is glucose control? If it is greater than 180 milligram per deciliter, start an insulin infusion. Try to maintain in between 140 to 180. And vitamin C, previously it was recommended, but now they say against it. They don't give it IV vitamin C. And if possible, start on enteral nutrition within 3 days of the septic shock. The patient gone for septic shock. So this is a very important long-term outcomes. This is a new addition. Not only treating a patient in ICU setup is very much important. We have to take care of them. We have to discuss the goals of care and prognosis of the patient and the attendant for their long-term outcomes, as well as if the patient has been a longer period in the ICU, we have to discuss with them the palliative care, which is essential, as we discuss with the long-term terminal cancer patients, we have to do appropriately. And we have to also screen them for their economic, we have to support them economically, social support, including financial, we have to support them. And not only that, after the patient gets discharged from the ICU, you have to follow them up. It is not the physician's job to only just treat the patient, but after a protracted, a long stay in the ICU, you have to follow them. Post-discharge follow-up should be there. Patients who survive a protracted period of ICU care for sepsis typically face a long and complicated road to recovery, and as a physician, we should be along with them in their road to recovery. So what is the recent advances? From earlier, the guideline says early goal-directed therapy. The goals have been set, there is a directed therapy. Now biomarker-driven approaches is there. Procalcitonin, as everybody knows, it is not useful to start an antibiotic, but when to stop an antibiotic and how long to do it. Procalcitonin is used. C-reactive protein is still useful, but very difficult to differentiate between inflammation and infection. Lactate level. Lactate clearance is very much important. You have to remeasure lactate after adequate fluid therapy to find out whether the lactate has come down. If the lactate is increasing, the mortality is more. What are the newer developments in sepsis biomarkers? So pre-sepsin, it's a novel biomarker which has been introduced in foreign, and still it is under trials and many trials. It offers advantages over procalcitonin in certain clinical scenarios. And the next biomarker is cell-free deoxyribonucleic acid. There is an emerging evidence suggesting that circulating cell-free DNA levels correlate with the early sepsis. So potential applications in early sepsis detection and risk stratification, these are all in the pipeline, future pipeline. In future guidelines, it may get incorporated. But whatever being said, sepsis is the most common cause of mortality in worldwide, and particularly in developing nations. In all specialties, it is getting involved. So whatever guidelines they frame, it is up to the physician's choice to treat the patient. And finally, the individualization of targets based on all the other comorbidities and incorporating these guidelines into your daily protocols so that to reduce the mortality of septic patients. Thank you. Thank you.
Thank you, Professor Natarajan. It was excellent. I request Dr. Natarajan and Suresh to be on the dais, please. I think please, sir, please. The forum is open for discussion. I would like to request the postgraduates to come down with get their cobwebs cleared. If not, it is my prerogative to have more questions with Suresh and Nataraj. Please be seated, sir. So we would like to take it a point that we would like to have 10 points for the youngsters to tell. When we approach a patient in the critical care situation, we would like to have 10 points. What do we do? How do you go ahead? Both. Because you have been talking about GDT. So 10 points, what do we do? What fluids we use? How do you immediately do what right now? He has got a sepsis, necrotizing fasciitis. This man has got a pneumonitis. We did not wait for all the investigations to come, and everything is in a milieu. So we just want to say, right, look at the patient, observe all these things, and kindly make it out. Start the antibiotic immediately. Which fluid to be started? He is in a septic shock, 70-40. And are you going to intubate the patient immediately?
Sir, if you suspect infection in an ICU setup, immediately you have to go for SOFA scoring, not Q SOFA scoring, because it is used only for screening, for confirmation SOFA scoring. All the six organ dysfunction you have to calculate. If at all, depending on the SOFA scoring, the mortality increases. Then once you see the patient, you suspect an infection along with the SOFA score increase, you have to immediately start on, if the patient is in septic shock, 30 ml per kg of balanced crystalloids you have to give for 1 to 3 hours. If at all the patient is not responding, you have to go for vasopressors like norepinephrine and vasopressin. And as well as you have to measure lactate, because lactate clearance is a sign of tissue perfusion. That is very much important. As well as we have to start a broad spectrum antibiotic within the first hours based on which site of infection, as Sarah has put many sites, Sarah said. And do not give all the antibiotics. Whenever you suspect a high MRSA organism, you have to go for MRSA coverage. If at all it is a gram negative, you have to give multi-drug resistance. If you suspect 2 gram negative coverage, you have to give. Similar things you have to follow. And you have to recurrently, you have to evaluate such patients. So you should not leave it just like that. Every hours you have to evaluate. You have to look for the lactate clearance, whether the patient is improving and whether the patient is having all the BPs improving, everything you have to follow up. And if the patient is going for worsening from one organ to another, it is very difficult. What the antibiotics we are giving is very much wrong. So we cannot wait for the culture, sir, because culture is, takes a lot of time. So only empirical, broad spectrum according to the source, and we have to eradicate the source. Without eradicating the source, nothing is going to happen, sir. If we are not able to identify the source, it is very difficult. Many cases we have felt the source identification is much difficult. Which source is the main origin of this infection? But if at all we get an idea that infection is due to this source, easily we can eradicate and we may be successful in the treatment, sir.
Thank you. Suresh, it is your turn now.
Yes.
So you say that ceftriaxone is 1 gram is useless. Yes. It's just, and you want to have 6 grams per day.
Well, I put my steps as the first thing, when you encounter a patient, the first step is whether the patient is stable. I don't want to make a use of diagnosis of Q SOFA or SOFA to make septic patients. Whether the patient is stable or unstable, I can use it, because at the bedside, that is a marker available to you. You read the conscious level, check the BP, check the pulse rate or respiratory rate. It's more important for an assessment of the stability. Don't make a diagnosis of it. The next step is always think, does this patient has got infected or does this patient has septic? We take a lot of pinch of this 2021 guidelines, lot of we don't follow it back. In fact, 100 years back, how they define sepsis, for me sepsis is bad infection. Any organ, if you think the person has got infections, it's some organ dysfunction, you can call the person has got sepsis. How to define the dysregulated response is not clear. And second thing people say about, they didn't give about any specific to the organisms. Dengue can cause sepsis, your malaria can cause sepsis, but these are all organisms missing in the sepsis 2021 guidelines. So similarly, what happened, they mentioned about the SOFA score. For example, the person has got dengue, admitted in ICU, and the platelet drops from 1,50,000 to the next day 40,000, 2 points gone up. So I can say the person is septic, so always guidelines is give some clue, some idea, but Sir clearly told individual clinician should decide what is going around there. Guidelines are just going to help out. The sepsis 2021 guidelines has got a lot of issues around there, so I'm not going to elaborate. So does this patient stable? Does this patient infected or septic? Next questions. Use your clinical judgment. Now take proper history, do proper physical examination. That is still gold standard. Then do use your investigation judiciously. Don't read the paper. Sir clearly told procalcitonin. Most of the people start procalcitonin, 20 septic. Procalcitonin is not a diagnosis of sepsis. Procalcitonin help in stopping the antibiotics. He clearly mentioned about it. So don't think procalcitonin, you want to start the antibiotic. Only for stopping antibiotic, procal will help. So use your investigation judiciously. Similarly, coagulase negative staph, elevated ESR. Don't give a lot of things importance there. We need to go with clinical pictures. And if you want to start antibiotics, when the person is really shocky, I told 5 conditions. When the person has got hypotensive, when the person is elderly, when the person is a newborn, when the person is neutropenic, when the infection is meningitis, or the person is really necrotizing fasciitis or something, that point of time, yes, you can use antibiotic judiciously, immediately, yes, after taking appropriate cultures. So don't rush to antibiotic. The Kumar paper Sir has told, it paper pushed a lot of antibiotic abuse to me there. So we need to assess whether the person really requires antibiotic. These are all the subgroup of antibiotic. I can start antibiotic. When the person is stable, hemodynamically monitoring, make a diagnosis, take appropriate sample. Don't wait for the culture results. I agree with this, sir. You can stop antibiotic after sending cultures out there. If you start antibiotic, daily reassess whether the patient needs antibiotic or not. If the person is not requiring antibiotic, stop the antibiotic. Short is sweet. And third thing, previously people consider IV is the best antibiotic. Now the concept is emerging. That's why I said I'm using chloramphenicol for all my meningitis cases. When the person is not affordable for carbapenem, chloramphenicol still gold standard there. I can use chloramphenicol, oral chloramphenicol. I'm using oral minocycline. I'm using cotrimoxazole. These are oral is equal to IV. Bacteria does not know how the antibiotic reaches the bacteria. You just need antibiotic, whether oral or IV. Only the oral bioavailability is good, use oral antibiotics. Then, as he rightly pointed out, source control. When the line is not required, remove. When the Foley catheter is not required, remove. These things, if the person has got abscess or necrotizing fasciitis, drain. Unless you drain the abscess, unless you debride it, whatever of antibiotic, nothing will happen. So these are all the steps we usually follow in our septic patients.
Thank you, sir. I think thank you for the excellent narration, sir. Now I request Dr. Joseph Rajan, sir, to honor Dr. Suresh Kumar, sir.
Tiruvarur has started ruling the country, everyone knows that.
I request Dr. K. Sampath, sir, to honor Dr. M. Nataraj, sir. Next, I request Dr. S.S. Lakshmanan, sir, from Chennai to speak on an interesting case of Mr. 5.
No, I think already he has called. Please, Dr. Lakshmanan, I think he will be talking about, I think I will request him to be short so that, we can go in according to the time. The topic he has put it as interesting case of missing 5. I think yesterday for the postgraduates he did the same case. The people who are already listened to him, please don't raise questions or your own answers. With this, I will hand over the mic to Dr. Lakshmanan. And the previous speakers, whatever diagnosis, myocardial infarction, you can have a easy diagnosis and treat the patient, but not the fever and the sepsis.
Thank you, Chairman. Yesterday I had the privilege of talking my own clinical cases to the postgraduates. I think they were interested. The session for 1 hour, but it went on to 2 hours. I keep presenting my case records from the whatever I had. It's a very interesting case of diabetes. I purposely coined as MIST 5.
Should follow the order of the clinical history, the clinical examination, and what test we should do. I think we can learn from the learned speaker.
He's actually a vegetarian boy, almost 13 to 14 years old. He was admitted into the hospital during this year for a high fever, abdominal pain, continuous vomiting of 3 days duration. He is a known case of type 1 diabetes on basal bolus insulin for the past 2 years. In fact, he has been evaluated for abdominal pain 2 years before, 2023, and found to have a hydronephrosis left with the elevated blood sugar of more than 600 milligrams in a corporate hospital. So from there, they wanted to control the blood sugar, so they referred the patient to a diabetic specialty hospital for sugar control before surgery. There, the patient was treated with IV insulin therapy, and he was investigated, and they made a diagnosis of type 1 diabetes. That's a previous hospital record. In the year 2023, 15/7, the A1C was 17.5 at the hospital where he was admitted. His fasting C-peptide was negligible, and the stimulated one postprandial is again not very high. It's only a 0.2, almost negligible. The GAD antibodies were negative. However, the final diagnosis arrived was diabetic ketoacidosis with the type 1 diabetes on 17/7/23. That's the regimen the patient has received. He has received the short-acting insulin, the Xulin. He was given 15 units 3 times a day before food, and the biosimilar Glargine at bedtime of 25 units, the basal bolus insulin. After 2 days, it was not sufficient, so the insulin was stepped up to 18 units of short-acting insulin and the Glargine of 25. Then he underwent the pyeloplasty, the Anderson-Hines operation for the congenital hydronephrosis. Then he was with the basal bolus insulin, then stented. The stent came down after 3 months' time, so again the repeat stenting was done in the same hospital 3 months later. Now, after 16 months, he presented at the Priya nursing home with a diabetic ketoacidosis with the urosepsis. He was very toxic, febrile, pulse rate was 132, and the respiratory rate was 30. He's a very lean boy, emaciated. The BMI was less than 18. Weight was 36 kg. Abdomen showed a severe tenderness in the left loin. No markers of insulin resistance. No acanthosis nigricans or any markers like what you see in the type 2 children, obese children. The history is only that I told you the operator for left congenital hydronephrosis. There's no family history of diabetes. Both parents, grandfather, grandmother, everybody has no diabetes. The random sugar in the hospital was 650, A1C was 16.8. Urine, the ketones were 4+, plenty of pus cells in the urine, and the USCR was positive, 100 milligrams. Urea was 56 milligrams, creatinine was 1.4, potassium was slightly high, 5.5. Sodium was slightly less, 128. LFT and the thyroid functions were normal. The total count was enormously raised, almost 32,000. Chest was normal. X-ray, ECG showed a sinus tachycardia. Echo was no LV dysfunction. The scan abdomen showed a residual hydronephrosis left with a very severe perinephric fat flare. Almost, I think the ultrasound gives a very good image to the pyelonephritis diagnosis. You can make a bedside diagnosis put the patient to the ultrasound machine. Rapidly you can make a diagnosis, and then the patient, we know that the patient's got acute pyelonephritis, and the serum hydroxybutyrate was positive. The initial diagnosis was diabetic ketosis, UTI, sepsis with the pyelonephritis left. Shifted to ICCU. He was on IV insulin therapy. Imagine he needed 9 to 10 units every hour. 9 to 10 units of insulin every hour. Almost 240 units per day to keep the blood sugar less than 180. He was on IV meropenem, IV saline. We had the standard care for diabetic ketosis in the ICU. The RFT came to normal in 3 days' time. After shifting to the ward, the patient was put on the best insulin, the Fiasp, 24 units 3 times a day before food, and the co-formula, the second generation basal insulin, Tresiba, 38 units. That is to keep the blood sugar between 180 to 240. Such an amount of high insulin required, despite that the sugar is not coming down. So the parents were so poor, they asked me what exactly to be done, sir. The boy has given so much of insulin, it's not coming down. I said we can go for insulin pump. But patients not very rich enough to get a pump and things like that. And we found a very difficulty in bringing down the sugar below 180. Somehow I got some samples of insulin for him. Now the problem in hand is that he had 4 times sugar more than 600, diabetic ketosis more than 4 times, pylophosphate more than, once, degestenting twice, recurrent UTI, almost needed 120 units of insulin every day. Still the sugar is not on control. Pump is the only solution. Can anyone could help me now, or shall I proceed with the next slide? Okay, now in the metro train, both right and left seats look similar. So the possible diagnosis, after 1 month, this boy, he came and I repeated the GAD antibodies and C-peptides, both fasting and stimulated. The GAD antibodies are still negative. That was one irking my mind, a diagnosis of type 1 diabetes, but how is that the GAD antibody is still negative? I asked for zinc transporter antibodies, not available. So I was still wondering, is a type 1 diabetes. When I checked the C-peptide, there's some gray hope that there was a 0.6 nanogram rise of the C-peptide. When you stimulated it, it went up to double, 1.2 nanogram. So indicating that there is some beta cells. I thought it's the honeymoon phase of type 1 diabetes. Sometimes when you give insulin, sometimes they don't require insulin after some time. Some beta cells function and things like that. So I'm not too sure if puzzled. The attenders on one side, how many times, boy going to 7th standard on 4 times insulin, still he's not doing well. He's emaciated, going down and down. So I went back to the type 1 diabetes, given type 1 diabetes, type 2 diabetes, the specific types of diabetes, endocrine causes, all other causes, drug-induced and things like that. We have gestation, and we have the type 5 diabetes. Now, this was the term coined in the Bangkok IDF, International Diabetic Forum. That's a malnutrition-related diabetes now has been officially recognized as type 5 diabetes on April 8, 2025 at Bangkok. First case was reported in Jamaica. A lot of cases are in India. We are not reported, but they have reported. BMI is less than 19, very high glucose, need always insulin, but there's no ketonuria. But our boy had almost 4 times ketonuria. So is it really a type 5 diabetes, or still I don't know. This is the case of type 5. So I caught it as a missed 5. Send the blood sample of the boy and the parents, both, for a precision diagnosis, and I waited for 8 weeks. What could be the investigation? The results came. Any guess? I think somebody knows the answer, postgraduates. So on Thursday, March, the letter came from Dr. Mohan. Congratulations for picking up a patient with the HNF beta Modi 5. But he also told me, Lakshmanan, Modi 5 is exactly like type 1 diabetes. They also need insulin. I think you have to convince the parents for insulin because they exactly behave like type 1 diabetes. So Modi 5 is quite a rare condition where we see the presentation like a type 1 diabetes. Actually, if you see the Tattersall and Bajan's criteria, I think Mohan has gone this time to ADA. This time must be given Bajan's oration. They are the people who got this criteria to make a diagnosis of monogenic diabetes. Previously it's called Modi, now it's called monogenic diabetes. The criteria is early onset of diabetes before the age of 25, a family history of diabetes at least for 2 to 3 generations. We never had these generations here in my patient. Non-insulin dependence, but our patient required insulin, absence of obesity, absence of ketoacidosis. That's mentioned as monogenic diabetes. But this boy has, but Mohan told me that all the exceptions are there for the Modi 5. You know, the monogenic diabetes is a single gene defect. Actually, Modi 5, if you could see that, it's called the RCAD syndrome. RCAD syndrome, renal cyst and diabetes. So somebody has got diabetes with the renal congenital malformations, please think in your mind of Modi 5. So Modi 5 is a defect in the HNF1 beta, and the gene is 17q. Probably in a deletion of a chromosome could do it in a fetus in the amniotic fluid. When we could detect this, probably we could prevent the Modi 5. So Modi 5 or the mature onset thing, type 1 is a monogenic form of diabetes caused by the mutations in the HNF1 beta gene and the chromosome 17q leading to early onset diabetes. Sometimes I believe Modi 5 can be sporadic, like in our case. It need not be always given. Both the father, both the mother were negative for the Modi 5. The first case of Modi 5 was reported only in 1997 in a Japanese family. Probably we have also some few reports from India, and the Modi 5 is one of the least of the among all the Modi. We have the 15 Modi available now. I think Modi 15 was the one last 3 months back was founded by Dr. Mohan. The type 1 diabetes and the Modi 5, they exactly behave the same way. Both of them require insulin. So sometimes what happens is similarities of the early onset potential for misdiagnosis with the type 1 diabetes, ability to cause similar diabetes complications. Modi 5 also requires insulin. RCAD syndrome. This is the one which really attracted me, the slide and the text. I went into the depth of the Modi 5 treatment aspect of it. They say the pancreatic hypoplasia or the beta cell hypoplasia results in the decreased insulin secretion and release and the increased hepatic insulin resistance. Whatever insulin available, the liver has got a resistance which play a major role in the development of diabetes. And the severity of the diabetes depends on how much is the beta cell hypoplasia. So this case was in my mind, and we decided what to do. This is the report from an Indian report on the IJEM on the Modi 5. Yeah, missed more than often missed than made. Now this case report I am writing it for AP Journal. So despite being a rare disease, Modi 5 is underdiagnosed and often treated as type 1 diabetes. Suppose a patient who requires family history, suppose a patient got a very early nephropathy, unilateral kidney involvement. Sometimes they can have also the involvement of other organs, liver, and sometimes you can also get the involvement of the other tissues. And with regards to treatment, the sulfonylureas is used as a first choice in Modi 5. Its efficacy is comparatively less in Modi 5 because we know there's a beta cell hyperplasia and patients often require insulin therapy. What I did in this patient, I started this guy, admitted the guy, boy, and then started on a glycotroside 60 milligrams twice daily. I started on a hepatic insulin resistance, pioglitazone 15 milligrams once daily. I also gave him metformin 500 milligrams twice daily. Convinced the patients to continue the Degludec insulin at bedtime, 15 units. Imagine the weight has gained by 10 kg in 2 months' time. 2 months' time. The A1C reduced from 6.8 to 16.8. All his shirts, pants, his father said every 2 weeks I had to buy new shirts and new pants. The fasting sugar came to 104 and the PP sugar came to 164 and perfectly urine, no pus cells. There was a patient on the discharge time. Immensely happy, the patient, but I don't know how long the drugs is going to act for him. Possibly, I think now it's almost now more than 6 months. He's doing extremely well. I think last time when he came, the OP he was 6.1, the A1C. Father said, can I stop insulin? I think again, going to tell us that medicine is a big surprises, temple of surprises. You have to keep using the mind. Here the clue to me why this case cannot be a type 2 diabetes was persistent absence of GAD antibodies. I think GAD antibodies will be always negative positive. So not all cases belong to it. So please go through the classification of diabetes. It should be one of the fit-in cases in that classification. Thank you for the patient listening. I'm here to answer any questions.
Thank you, Dr. Lakshmanan. I think the message, what he told, if you got a diabetes, CAD-BOD antibody is negative, and if you do the ultrasound, there is some renal abnormality, think of this condition. I think over to Dr. Pandit, sir.
So thank you, sir. You have completely evaluated. Of course, Modi 5, how the drugs are helping, you have mentioned there is hepatic insulin resistance, and GAD antibody negative will be there because in type 1, we have type 1A and type 1B. Type 1A will have GAD antibody, type 1B will not have. That is idiopathic cause. We do not know the exact cause for type 1 diabetes, but here this is coming under the idiopathic cause. Of course, Modi 5, metformin and pioglitazone is improving the hepatic insulin resistance. Hence only the blood sugar is coming down. But there is hypopancreatic beta cells, your glycoside is not going to help. Gliptins will definitely help for such patients. Whenever the blood sugar goes high, it suppresses the glucagon. So by which hyperglycemia will get controlled. Remove glycoside from this patient, add gliptin. After adding gliptin, metformin and pioglitazone, the quantum of insulin still will come down.
I think I'll try to add the DPP4 probably.
Gliptin is the ideal agent and the sulfonylurea. Sulfonylurea will further exhaust the remaining beta cell function.
Thank you, sir. Ketones disappeared. We admitted the patient, sepsis corrected, the ketones disappeared with insulin. Sepsis. Diabetic ketoacidosis.
So in want of time, I think we'll close the discussion, and now I request Dr. Shanmugam sir to honor our speaker, Dr. Lakshmanan sir.
I should thank Dr. Lakshmanan for still being active and throwing light on it, and I really appreciate Paneer because I had the same thing. Why glycoside again put into these shoes? It is better you get up with the gliptins, probably that's one, it gives a good answer.
I request Dr. Shanmugam sir to honor Dr. Joseph Rajan sir. I request Lakshmanan sir to honor Dr. Shanmugam sir. I request Dr. Shanmugam sir to honor, Lakshmanan sir to honor Sampath sir. Okay. அடுத்து இப்போ குணசேகரன் முடிச்சுட்டு அப்புறம் பண்ணிக்கலாம். Now I request Dr. Vetrivel sir to honor Dr. Guest speaker Dr. Pannisalvam sir. Now coming to the session, part Pori, chairperson.
We are going to witness the fourth session. We invite Dr. P. Vijayanand from Perambalur and Dr. M. Nadarajan Madurai and Dr. L. Raghupati to occupy the chair. The first lecture will be on managing newly detected type 2 DM, the practical essentials to be deliberated by our friend Dr. Palanivel Rajan from Pattukkottai. I also request Dr. Muthamani to chair the session and Dr. Palanivel Rajan sir.
அனைவருக்கும் வணக்கம். I thank the organizing committee of this prestigious Tapicon 2025 in Vellore for giving me this opportunity, and also I congratulate them for the excellent way of conducting the conference. The topic today is the managing newly detected type 2 DM practice essentials. So I am not going to talk about any individual drug, any injections, nothing, no dosage, nothing. It's only about the practice essentials, how to deal with the patient when you diagnose him or her with the type 2 diabetes. So previously, no TB, no medicine. Now it's no diabetes, no medicine. That's why everybody is a diabetologist and most of them are diabetes specialists. So who is a diabetologist? All allopathic doctors who have completed MBBS till MCH surgeons from MBBS. Everybody is a diabetologist or diabetes specialist. So when you want to practice medicine, you should know diabetes. So that's the trend now. So no diabetes, no medicine. So even MCH surgeons are practicing diabetes and they are a diabetologist. So this is a slide to diagnose. So we are diagnosed, we have did the blood test and we came to a conclusion that the patient is a type 2 diabetes. Nowadays, why I am putting this is, most of the patients themselves come with the blood test. I wonder how, இல்லை சார் எனக்கு பக்கத்துலாம் சொன்னாங்க, நான் நானே செக் பண்ணி பார்க்கலான்னு இருந்தேன் அப்படின்னு, they themselves come with the fasting postprandial test alone. That's why I put this slide. They simply come with only sugar values so that we will diagnose them as a type 2 diabetes. So your job starts after that. The first question, only two things. When you are diagnosing a diabetes, one is diet, second is drugs. The patient wants that only, and most of the diabetologists also interested in those two parts. But there are many other things we will discuss. So one is diet, another is drugs. So what is the best diabetic plan? I think this question has not been answered so far, or I have not got that answer so far, but it has been simply answered by most of the diabetic centers by giving a diet chart. But invariably, I don't think how many of us are going home and take that chart and taking that 1 cup with spoon, measuring everything and all. So practically that's not a possible thing, at least in my area, in our India. So the best diabetic plan is, any diet without sugar will be the best plan, probably. Second thing is, reduce the calories. That's the two things best advice. We cannot give a chart. The simplest way of advice we can give is, any food, when you put into your mouth, is sweeter, avoid it. So I used to tell that way, because there is a lot of foods available. India is a country where we have so many food items. We cannot name it. We cannot single out each and every food to say that this is harmless, this causes increased blood sugar levels. So any food, when you put into your mouth, it tastes sweeter, just avoid it. Second thing is, how to reduce the calories. That thing, it is a simple calculation. See, what I am telling is not about the guidelines, purely the practical essentials, or how can you practice simply. If you are taking 5 idlis, reduce 1 idli, 2 idli. If you are taking 2 cups of rice, reduce it by half cup. 3 dosas, reduce by half. This is the best way you can do. You cannot give a measurement and all. Don't reduce it to half. It is a lifelong time disease, and you are going to live with it till you are 100 years or 120 years. We cannot, இன்னைக்கு 5 இட்லி சாப்பிட்றாலே, நாளிலேருந்து நான் சுகரை குறைச்சி கொண்டாங்க சார், 2 இட்லி சாப்பிட்டு 1 மாதம் கழிச்சு 2 இட்லியோட சாப்பிட முடியாது. சுகரை குறைச்சிட்டு சந்தோஷம் கிடைக்குமே தவிர, அடுத்து திரும்ப again you will increase it to 3 idlis, 4 idlis, and back again to high blood sugar levels. So probably this could be the best way I can say is, avoid anything which is sweeter, reduce your whatever you are consuming already by at least 20 to 30%. So now come to the drugs. So having the lab test with the sugar values, now we have to set the goals. He himself will, patient will say, sugar koda kattide. So what is your target? Now we are having a target of glycemic goals. These are fasting levels, 80 to 130. Now there is a catch in this fasting blood sugar, 80 to 130. A single value of fasting blood sugar more than 126 itself, we are going to brand him as a diabetes. But here, as per the ADA latest guidelines also says that your fasting blood sugar can be kept between 80 to 130 when you are treating the patient. Postprandial should be less than 180 and the HbA1c less than 7. So it indicates, don't titrate to the lab reference values as less than 100, less than 80. Don't strictly adhere to the lab values. So to mention, these are the drugs, various drugs and various group of agents available to treat diabetes apart from insulins. And this is the ADA classification 2025 for the management of type 2 diabetes. So just to show that this is available. Everybody is available in the books and everybody is having it in their table. So what are the goals of the treatment? I already told it's a diet and drugs, but those are all treating values. So the patient is bothered about the numbers, and most of the time we are also bothered about the numbers, but unfortunately it's not the number. It's like I used to say, நம்ம 10வது பரீட்சை சில சமயம் 70 years lady passed out 10th standard in colors and paperல photo publish ஆகும். But what is the use in it? She cannot apply for further, she can study further. So அந்த மாதிரி sugar is just a number. You can reduce it any stage of your life. 50 வயசுல கூட sugar control பண்ணலாம், 10 வருஷம் கழிச்சு control பண்ணலாம். Reducing the sugar values or number alone is not the goal of treatment. So it is a goal is to prevent or delay the complications and to optimize the quality of life. It is not about the numbers, it's not about the sugar values. It's about prevent or delay the complications and optimize the quality of life. So the management of newly detected type 2 diabetes starts with comprehensive medical evaluation and the assessment of the comorbidities. So the treatment starts from here. It's not the drugs. So how to do the comprehensive medical evaluation? So you start with the history taking, past medical history. Most of the time, already எனக்கு சுகர் இருந்துச்சு சார் ஒரு வருஷமா அப்புறம் குறைஞ்சிச்சு நான் ஸ்டாப் பண்ணிட்டேன். Again he will come with a newly fresh 1 year gap கழிச்சு வருவார். So we should know whether it is a newly detected really or it is a discontinued treatment. Family history of diabetes. நிறைய பேர் எனக்கு ஃபேமிலி எதுவும் இல்லவே இல்லைமாங்க ஃபேமிலி. ஸோ ஃபேமிலி இஸ் இம்பார்ட்டன்ட். எவ்ரி திங் இஸ் இம்பார்ட்டன்ட் பிகாஸ் டு நோ த பேஷண்ட் கம்ஸ் அப் ஒன்லி வித் blood sugar values. We know whether it is a type 2, familial, genetically inherited, everything. So it can be attained easily by the family history. Personal history is food intake. We cannot ask நம்ம ஊரில் பழக்கிற மாதிரி சொல்கிற மாதிரி இருக்குது இட்லிக்கு சாப்பிட்டோம் சப்பாத்தி சாப்பிட்டா வேறு ஏதாவது சாப்பிடணும். தட்ஸ் நாட் த கேஸ். ஃபுட்டை சேஞ்ச் பண்ணால் உடனே சுகர் சரியாயிரும். தட்ஸ் நாட் த வே. So physical activity. So everything is a part of a management plan. So you should encourage all these things. What is the type of food he is taking? What is the physical activity he or she is having? What about his sleep disorders? So everything is going to play a part in the sugar management and his quality of life on complications. And the medications. Usually the patient may be having some medication, psychiatric drugs or some other drugs which can produce new or induce a new diabetes. And the patient's knowledge about using the technology. For example, self-monitoring of the blood sugar and other accessing the complications. Then come to the physical examination. The BMI coating is more important. BP, blood pressure in the first and sitting and the standing posture. So to know already there is any autonomic involvement or complication of the diabetes. Fundus examination, thyroid examination, usually hypothyroid may coexist. Skin, look for insulin resistance like acanthosis nigricans. Look for the foot deformity, ulcers, and most importantly, measure ABI to know the involvement or presence of peripheral arterial diseases and also the presence of neuropathy by monofilament testing. Then what are all the lab investigations you have to do whenever you are diagnosing a patient with the diabetes? HbA1c will tell you what is the current status of the blood sugar level. Lipid profile is more important because more than 40 years, as you know, simply a presence of diabetes alone is a indication to start statins. LFT, smart albumin creatinine ratio, renal function test, urea creatinine and uric acid, TSH, complete blood count, urine complete, vitamin B12, vitamin D, calcium and phosphorus if you think so. And the assessment of risk of diabetes complications. Here, after doing all these blood investigations, now you should assess the risk. What is the risk of atherosclerotic cardiovascular disease in this patient? What is the 10 years risk? And what is the level of staging of CKD? Well, mild urea creatinine impairment, stage 1 CKD. Maybe he may be having already stage 1 CKD at the time of diagnosis of type 2 diabetes. What is the risk of hypoglycemia this patient is having? Whether the patient is already having, you know that as per the guidelines, right at the time of diagnosis of type 2 DM, you have to evaluate for retinopathy, neuropathy, and also look for other metabolic liver diseases. So having assessed comprehensive medical evaluation and assessment, now you are going to set your goals for the treatment. What is your blood glucose level? What is your target? What is your goal? Whether it is 80 or 100 or 110 or 120, depends upon the associated comorbid conditions. What is your lipid level target? What is your blood pressure target? Suppose it is going to be a CKD and CAD is going to be reduced to 120/80. Otherwise, you can increase to 130/80. So what is the weight management? So aim for at least 7 to 10% of the weight loss in the patient after diagnosing a type 2 diabetes. That will help a lot in the treatment. Then physical activity. Make sure that he is doing at least 30 minutes of physical activity every day. So having all these things are practice essentials. What are the practice essentials? So you are in a confusion. You have to decide the guidelines, based on the guidelines, whether you are going to start with the orally acting drugs or you are going to start the patient on injectables, whether you are going to select a drug in such a way it's an insulin dependent action or a non-insulin dependent action, high efficacy drug is a low efficacy drug, affordability of the patient, availability of the drug. For example, I cannot dream of writing a semaglutide in my town. It's a small municipal town, Arandangi in Pudukkottai district. I cannot dream of writing even though patient is ill, I have to order and get it back. So semaglutide, liraglutide, so that's not a possible thing. Then availability, affordability, then the religious customs. So based on the religious customs, we have to write the prescription. So the most important is age. If it's less than 40, 40 to 75, and more than 70, you have to decide accordingly as per the age. At that HbA1c at the time of diagnosis, if it's more than 10 or less than 10. So it's more than 10, it is a necessity. Always it's better to admit the patient in our center where the patients will obey you, or you start for insulin, convince the patient to start on insulin. Whether the patient is insulin accepting or not, the patient is not accepting, we cannot force him. So the presence of atherosclerotic factors, the presence of CKD. Why all these things are important is, guidelines are guidelines, but one size doesn't fit all. As per the guideline says that more than HbA1c, start on insulin, more than 10. Or a random blood sugar at the time of diagnosis more than 300, start on insulin. But the patient won't accept. So you cannot insert your line of management to the patient. He has to accept. So the best thing is to educate him. Sit with the patient, spend some time on comprehensive medical evaluation, this assessment of the comorbid illnesses. The spending time with the patient will make him to accept your decisions. So only two things I want to mention about having diagnosed, comprehensive medical evaluation done, and assessment of risk done, and goals of the setting done. So only two things you have to be aware of now. One is the complication of the treatment, hypoglycemia, or the complication of under treatment, hyperglycemia. These two things are the most worrisome from the patient aspect and our aspect. So always, whatever you say, you don't say any clear ideas about the drugs or not, about the diet or not, but you have to educate the patient about hypoglycemia before the patient leaves your room after prescribing treatment for the first time diagnosis of type 2 diabetes. Because once hypoglycemia sets in, the patient will be very reluctant to treatment, very reluctant to start again. So the hypoglycemia assessment, prevention and treatment is the most important thing you have to tell a patient once you start, before, along with the starting of the treatment. So this hypoglycemia in treatment, so blood glucose 3 levels, 55 to 69, less than 54, altered mental status. This is a rule, 15-15 rule, you know. The very simple thing. Actually in my clinic, whenever the patient presents with the low blood sugar less than 70 means, there is a standing instruction that 5 tablespoon of sugar in 1 cup of milk has to be given immediately. They have to reassess after 15 minutes. If it is again less than 70, you have to repeat it again. Very simple. The practically available one, 5 spoons of sugar in our spoon, tablespoon, that don't take those things and all. Simple, 5 spoons of sugar in a cup of milk taken immediately. Reassess after 15 minutes. If it is still less than 70, give it again, provided the patient is conscious enough to take it. Again, hyperglycemia, I know. So, patient may present first time as the diagnosis itself with a hyperglycemic crisis. So, you have to check for the urine ketone. The patient may not be in a condition to tell that I am sick enough to get admitted. He may be having with 400, 500 blood sugar. It is your responsibility to see whether the patient is going for ketoacidosis, whether the patient is having ketonuria, patient is having a mild altered impulse status. So, whether he is going for hyperglycemic, hyperosmolar crisis, etc. and all. So, you have to utilize all these things. So, this is the DKA or hyperglycemic hyperosmolar state. You have to change in the cognition, nausea, vomiting, simply nausea, vomiting, pain, abdomen. So, these are the glycemic goals we aim for, ranging from 6.5% or less than 7% to no HbA1c goal. Actually, the Accord and this UKPDS, all these studies have showed that you can read in the latest American Diabetes Standard Protocol guidelines. All these studies have shown that the intensive management control of the group patients have no significant advantage over the relaxed management. So, in fact, they have told clearly that sugar alone is not is a weak factor, risk factor for cardiovascular disease than hypertension, hypercholesterolemia. So, you should not be too much bother about a very strict glycemic control. So, that's why in old age there is no HbA1c goal. So, to conclude, lifestyle management and behavioral health care are the cornerstones of diabetes management. Assessment of the risk of acute and chronic complications of diabetes and treatment planning are the key components. The patient and their family members to acknowledge multiple factors impact glycemic management. இதுக்கு சிம்பிளாக சொல்லணும்னா, நான் கரெக்டாக தான் மாத்திரை சாப்பிட்றேன், ஏன் வீட்டுக்கு சுகர் கண்ட்ரோல் ஆக மாட்டேங்குது. ஸோ தெர் ஆர் சோ மெனி ஃபேக்டர்ஸ். நான் சப்பாத்தி தான் சாப்பிட்றேன், அப்புறம் ஏன் வீட்டு குறைய மாட்டேங்குது. ஸோ தீஸ் ஆர் த திங்ஸ் யூஸ்வலி த பேஷண்ட் கம்ப்ளைண்ட்ஸ். ஸோ தெர் ஆர் சோ மெனி ஃபேக்டர்ஸ். அண்ட் நாட் டு பிளேம் த பேஷண்ட் ஃபார் நான் கம்ப்ளைண்ட்ஸ். நம்ம வந்து இல்லை நீ ஏதோ மாத்திரை விட்டுருக்க, அதனால தான் உனக்கு சுகர் குறையல. ஸோ நாட் டு பிளேம் த பேஷண்ட் ஃபார் நான் கம்ப்ளைண்ட்ஸ் அண்ட் யூஸிங் எ நான் ஜட்மெண்டல் அப்ரோச் வில் ஹெல்ப் யூ இன் ட்ரீட்டிங் த பேஷண்ட் சக்ஸஸ்ஃபுல்லி. So, some takeaways: avoid high efficacy or hypoglycemic prone drugs in the old age. avoid thiazolidinones or pioglitazones in heart failure, avoid DPP-4 inhibitors in a patient with pancreatitis. I have seen some of patients, alcoholics, present with repeated abdominal pain. Sometimes pancreas may be inflamed, otherwise. So I stopped DPP-4 inhibitors, they stopped getting the pain abdomen. Avoid metformin and sulfonylureas in stage 3 and 4 CKD. Always the first line drug in CAD and CKD is SGLT2 inhibitors. And beware of using it in females. I have seen females presenting with severe urosepsis, admitted in ICU and recovered. So you have to always use with caution in females with SGLT2 inhibitors. So India being a poor country, so the patient's affordability is a concern. So always better usage of these combination drugs will help you a lot in better compliance. So sulfonylurea, metformin, pioglitazone combination. And if not controlled, before pressuring the patient for insulin, those who are not for it, add alpha glucose inhibitors and try it, and then you can go for insulin. Prefer short-acting drugs in frail patients or those living alone, because I used to say, insulin போடுறதுக்கு அட்வைஸ் பார் இன்சுலின் போட்டியன்னா சுகர் குறைஞ்சா நீயாவே முழிச்சு வந்துடலாம், நீ ஓஹெச்ஏ போட்டு சுகர் குறைஞ்சா பக்கத்து வைக்கிறேன் கதவை உடச்சு உன்னை தூக்கி அந்த ஆஸ்பத்திரியில் சேர்த்தா தான் முழிப்பேன். Because you know that insulin action ends in 12 hours maximum, short acting in 6 hours. Suppose you are taking his glibenclamide, it will take 2 days. A patient presenting with hypoglycemia after taking glibenclamide, definitely if you are treating the hypoglycemia at that time and send you them back home, he will again tomorrow present with again hypoglycemia. So it will take minimum of 48 hours sometimes. So it's better to treat those patients living alone or frail patients with the short acting drugs. Whenever you are starting the insulin, those patients who are not for insulin, always start with once daily dosage. It doesn't matter. You are starting the 5 units or as per the guidelines 10 units to start with. Even you can start with 5 units because to prevent hypoglycemia. But start, at least convince them to start once, and then you can later convince them to twice or thrice, and you can modify, etc. In another way also, whenever you are diagnosing, I always say, prefer using the term insulin. What is the diabetes? Tell them. Let them have that, know the word insulin in their ears, because it is either insulin resistance or insulin deficiency that makes the patient diabetic. So it is insulin and insulin that is related to diabetes. So they can hear in their ears that insulin and diabetes are related. So insulin, they think that some other antibiotic like injection. So insulin and diabetes are related. So you have to use the term insulin right from the word diagnosis. Then only they will be accepting the insulin injection. Avoid therapeutic inertia and reassess and modify the treatment regularly, because patient நீங்கள் 3 மாதமாக பார்க்குறோம் 250 இருக்குது 250 கண்ட்ரோல்னா இந்த ஒரு மாதம் கொடுங்க சார் நான் குறைச்சிட்டு வந்துடுறேன். Then again he will come up with the next month. இந்த ஒரே ஒரு மாதம் சார் இன்சுலின் ஆக முன்னாடி. Then I will come up next month with the lower blood sugar levels. So avoid patient aspect from your aspect, avoid therapeutic inertia, reassess and modify the treatment regularly. And this is one picture that shows the entire topic. It is a decision cycle for person-centered glycemic management in type 2 diabetes, with the goals of care being prevention of the complications and optimizing the quality of life. Thank you for the patient hearing.
Thank you, Dr. Balni Rajan. So as you said, everyone is a diabetologist. We were wondering what you are going to say in the practice essentials, but you went to the root level, starting from the history-taking examination, and you concluded with the comprehensive management, and the goal should not be chasing the numbers. And it shows your ample experience in the clinical practice. Thank you, sir.
Thank you, sir.
Question. So I request the Honorary Secretary of the Tamil Nadu API, Dr. Gunasekharan sir, to deliver the next lecture on the menopause.
Full slide. ரெண்டு ஸ்லைடு ஃபுல் ஸ்க்ரீன் இல்லை இங்கே டிஸ்பிளேயில் உங்களுக்கு தெரியாது. இப்போ க்ளோஸ் பண்ணுங்கள் சொல்கிறேன். display setting. Duplicate slide. Good afternoon, one and all. And my topic is menopause mastery. When the scientific schedule was prepared, Anand called me immediately, Vetrivel Anand, scientific committee chairman. Ladies topic illa? Then I said, yes sir. நீங்கள் எதுவும் கைனகாலஜி ப்ராக்டிஸ் பண்ணுறீங்களா? No sir, I am a physician. Then I said, this topic is going to be interesting as well as to create awareness among our physicians. That way I selected the topic. Okay. So in the next couple of 15 to 20 minutes, you all going to know why menopause therapy is important for physicians and what is menopause and what all the hormone therapies are available and what about the barriers, and I am going to conclude my carry home message. Look at the slide on the right side. This is one of the longitudinal study. Those who has vasomotor symptoms and those who doesn't have vasomotor symptoms. Those who have vasomotor symptoms, the fatal cardiovascular events are very, very high. Look at the slide on the left side. Those who have early onset menopause and those who have high vasomotor symptoms, their carotid intima media thickness is very, very high. So, the next one is more and more studies are coming out between association of vasomotor symptoms as well as cardiovascular risk factors. And more studies very well correlated with the standard risk factor of hypertension, insulin resistance and dyslipidemia, and which lead on to subclinical as well as clinical cardiovascular events. And this one slide tells about once the onset of menopause, the metabolic syndrome is dramatically increases 2 to 3-fold. Hypertriglyceridemia, obesity, high blood pressure, pre-diabetes as well as impaired glucose tolerance, everything is very high once the woman started the period of menopause. Not only cardiovascular disease, look at the bone mineral density on the right side lumbar spine as well as hip and the left side femoral neck. Every year a woman after attaining menopause, the bone mineral density is drastically reduced. And the menopause symptoms impact, it affects the woman mental health, woman physical health, as well as the woman quality of life, as well as it going to give economical burden of woman life. And these data, for most of the menopausal symptoms, they actually reaches physicians, not a gynecologist. Only for vaginal symptoms, they reach the gynecologist. For all other symptoms of vasomotor, problem with sleep, mood depression, they immediately reach the physician. So the lesson is, menopause is a normal natural event in woman's life, and association between menopause and CV risk is a proved one. And as a physician, we need holistic and individualized approach to treatment and care. A woman value should not be defined by the end of her fertility. Now, what is menopause? This is a fertile woman should undergo all the stages, that is reproductive, menopause transition as well as post-menopause. And menopause diagnosis is principally a clinical diagnosis. But as a physician, you can get a biochemical evidence of menopause by measuring follicle stimulating hormones. And the vasomotor symptoms which usually occurs during menopause transition as well as the early menopause periods. So the definition is cessation of menstrual cycle.
It is retrospectively defined as 12 months of amenorrhea, average age 50 years, and early menopause means between 40 and 45. And this is data from India. Nearly 1,80,000 women were analyzed and enrolled for the study, which shows that the premature menopause, even before the 50 years in Andhra, Telangana, is very high. It is about 60%. So more and more women in India are going to have menopause. So earlier the onset, they will have the symptoms for long duration. So Indian women between 40 and 45 going to have vasomotor symptoms as well as menopause symptoms about 8.57 years. What is VMS? We all know that is hot flashes as well as night sweats, increased body temperature due to vasodilatation, then vasoconstriction which causes silts as well as swearing, and it occurs in 60 to 80% of women, and the prevalence is about 40% in the perimenopause as well as postmenopause period. And the duration, as I already said, young onset menopause will have long duration, and mostly the African women are mostly affected like our Indian women. And other thing is sleep disturbance. It will affect the quality of life, mood, cognitive function as well as productivity of women, and it will increase the risk of cardiovascular disease as well as the weight. And menopause related sleep disturbance, sleep disruption and sleep disorders, and which is related to VMS as well as hormonal changes. And cognitive function, this is very, very important. If you know menopause, there will be no fight between the husband as well as the wife. During menopause transition, they will have brain fog, that is inability to focus and concentrate and distractibility. Actually, a woman need more care from family as well as children during this period than any other period. And what are the factors which are all hormonal related changes in the woman, and mood changes, which is also important. During that time, they will have low mood, decreased motivation, and irritability, which is very, very important. If a woman of menopausal age group is irritable, please think of a menopause and give care to woman. And all the symptoms are complicated, that is vasomotor symptoms, sleep as well as mood. If you correct one symptoms, automatically the other symptoms will decrease. That's it. That's why it's called as a domino model. And other symptoms apart from these are sexual, genitourinary as well as muscle and joint pains. If a woman comes with muscle and joint pain, middle-aged woman, we ask for the menopausal history in Indian woman, they won't tell. Just measure follicle stimulating hormone. If it is more than 25, they are in menopause transition. If it is more than 40, they have menopause. That is very easy. As a physician, we can easily understand. The four core menopausal symptoms, VMS, mood anxiety, poor sleep, and vaginal symptoms. If any one is present, look for the others and try to correlate with hormone level changes. So what we can do in the empowerment in the management of menopause? First one is awareness ourselves as well as to the patients, and clinician and patients, we can develop a broader knowledge as equal partner, and we need more training tools. Are you rethinking your approach to menopause? Say yes or no. And now this data shows that VMS, vasomotor symptoms, is undertreated. 30 to 40% of women saw a physician for vasomotor symptoms, were never prescribed any treatment at all. And the treatment non-pharmacological, this also research is more needed. And pharmacological, one is hormone replacement therapy. Once the Women Health Initiative study published, the hormone replacement therapy actually drastically coming down because of the risk of breast cancer. The criticism with the Women Health Initiative is only one type of drugs was used, and most participants are aged more than 55 years with 79 years. What is going to have when you enroll a patient of 79 years to a menopause study, actually we have to enroll 40 to 55 years for the study. And data were published without reviewed by the main investigators. And this is from the press. Actually, the women who need hormone replacement therapy was between 40 to 50 years. But hormone replacement therapy was high among 50 to 65 years. This is also very wrong at present. So what are the hormone therapies we have? Estrogen, estradiol, as well as conjugated estrogen and besodoxepine. The hormonal therapy basic one is estrogen therapy or estrogen progesterone therapy. As a physician, know only two things, estrogen as well as estrogen and progesterone combinations. Estrogen alone for those without a uterus. Suppose if the woman have uterus, you can give estrogen as well as progesterone to prevent the endometrial cancer. And most of the Indian women also have surgical menopause, that is hysterectomy with bilateral salpingo-oophorectomy. So for those patients, you can give only estrogen alone. Some of the estrogen preparation which is available in the market. So before prescribing the dose, you can consult your gynecologist, which is the best possible lower doses. And some of the progesterone preparations are available. And the advantage is levo, orgestrel preparations. Just like a copper T device, you can give it to your gynecologist for continuous release of progesterone. And combination drugs are estrogen as well as progesterone. Always use a lower doses and assess the risk about adverse effect. Indications for hormone, genitourinary symptoms, VMS, and prevention of osteoporosis. And who is the best candidate for Indian women less than 50 years? Those who have mood and sleep symptoms and osteoporosis risk. And if the woman wants personal preference to use hormone therapy, please use it. And what are the contraindications? Unexplained bleeding and prior estrogen sensitive cancer and history of stroke, MI or VTE risk as well as severe active liver disease. So before prescribing hormone therapy, we have to assess the risk benefit profile and CVD risk, and age is very, very important. Please prescribe in a young woman for a 5 to 6 years. Their risk of developing breast cancer is very, very less. And look at the slide. When we prescribe that is only estrogen, actually the risk of breast cancer is very, very less. But when we use estrogen as well as progesterone, the risk of breast cancer is very, very high. Look at the deep vein thrombosis risk also. For 10,000 women in a year, the risk is only 10. So the risk is very, very, very low. And what are the non-hormonal therapies? One is FDA approved therapy, paroxetine as well as fesolintan. And if you want to prescribe a serotonin reuptake inhibitors in a woman, please prescribe fluoxetine, pregabalin and sertraline. Don't prescribe pregabalin, sertraline as well as fluoxetine in a menopausal woman because it is not recommended. Use a citalopram as well as venlafaxine or carbamazepine for their symptoms. And now new drugs is available. Fesolintan, a oral neurokinin receptor antagonist. Actually, it will blocks the action of neurokinin, and it is available in India now. Only the cost is very high, nearly 10,000 rupees for 300 tablets. Before prescribing fesolintan new drug, we got to assess the liver function test as well as renal function test. This is like statin. When I prescribe statin 25 years ago, I call patient every month to check for liver function test. Now without liver function test, we all prescribe statin. So this is a new drug, non-hormonal therapy, you can use it. And the barrier, even with gynecologists, only 20% said they were given lecture on menopause. They are not sufficiently prepared to treat menopause. And as a physician, we have to assess the middle life woman for menopause symptoms and conduct a physical examination. most importantly, screen for depression in anxiety in a middle-aged woman. And as a physician, we got to provide clear, accurate information about the vasomotor symptoms and treatment options to our patients. So shared decision making is the key. We have to consider the patient values and preferences and explain the importance of using an effective dose to get the relief and explain the risk as well as benefits. To conclude, menopause is a chance to implement preventive and screening strategies to reduce the cardiometabolic disease. And keep in mind, menopause is a clinical diagnosis, and hormone replacement therapy are underused in India for the needy, and new non-hormonal therapy are available. So the carry home message, clinicians who feel anxious about discussing menopause with patients, you arm yourself with knowledge and treatment about menopause and initiate conversation with your patient. Don't hesitate. Ask about menopause history in your patients, and now you have your information and try to use it in your patients. And more celebrities now coming forward. I am 40 years, I am menopausal celebrity, like that they are also breaking. So as a physician, we have to break ourselves for the woman care. Thank you.
Thanks, Doctor, who for the first time, as you said, talked about the women problem, menopause. Really, we congratulate. These kind of different talks must come in APA. And one practical issue is the patient at that age, they come with already established diseases, diabetes, hypertension, dyslipidemia, and when they give the symptoms, they themselves do not know that they attain menopause. So when we ask the question, so awareness is very important, and really thank you, sir.
In that case, we can measure follicle stimulating hormone. As per the guidelines, if it is more than 25, they are in menopause transition, and more than 40, menopause occurred. That is, we can easily, indirectly, nowadays, even in Pattukotai, more and more that fertility centers are available. Everybody is doing hormone therapy. So we can, as a physician, we can recommend it to do it.
It is not flattering, Dr. Gunasekar sir. I have been taught by many teachers. In my age, today, I have been taught by another teacher. So far, I have been thinking it is a problem related to ladies. But today, you have broken the myth. We have to learn that menopause is a medical condition by our eminent speaker, Dr. Gunasekar sir. Thank you, sir.
And it was like an undergraduate theory class, sir. Very slow and clear. Thank you, sir. So we call upon Professor Dr. Gopalakrishnan, sir, a former professor of medicine, Keelpark Medical College and Government Rayapeta Hospital, to talk about sarcopenia.
Either so good morning or a good afternoon, always in between area. Everybody is hungry for your lunch. So anyhow, I proceed with my topic. Sarcopenia. Next. Sarcopenia. So one of the neglected condition in our clinical practice, because it is present in the age group, elderly population, usually they are present. In practically, it's not like that. Always not like that. There are so many conditions in our clinical practice, they are having sarcopenia. Let us know what are they and how to counter, how to manage this condition of sarcopenia within 10 or 15 minutes of time. So aging is a biological process characterized by the gradual decline in physical and functional capabilities. Aging is usually associated with the loss of muscle mass and bone density reduction, and usually they are present with the decreased metabolic rate, and ultimately they are prone for vulnerability for the most of the diseases. By definition, sarcopenia, it is a age-related progressive loss of skeletal muscles, strength and function. Progressive loss of skeletal muscle mass, one. Second thing is the strength, and the third thing is the function. It is commonly a geriatric syndrome. Prevalence of sarcopenia is approximately 10 to 27% in the older population globally, but more prevalent in the hospitalized patients and those having a nursing home residence when compared to the community dwelling elderly. That is why it is not in the elderly group. Consider that is most of the chronic hospitality patients, post-operative patients, and the chronic illnesses, even chronic illnesses in the younger age group, they are also presenting with the sarcopenia. Generally commonly in men when compared to women. There is a regional prevalence is there worldwide. Coming to the frequently affected the sarcopenia, which part of the muscles is usually affect the lower limbs? If you go through this muscle group, the front of the thigh, the quadriceps is affected commonly, yes. We can easily see the area in clinical practice, but we never do it. The problem seen is hard to stand, climb stairs and with thin legs when quadriceps affected. When glute is affected, the patient usually present with the poor balance and flat saggy appearance. Calf muscles loss, usually they are having a slow walking and cannot stand on their toes. Back of that is hamstrings, there usually the smooth walking is not possible. Core, back and belly, they are usually present with the poor posture and weak tongue support. Arms and shoulder, usually they are present with the poor hand grip. So these are the common muscles in the lower limbs, quadriceps, glutes, and the calf muscles. Diagnostic criteria. So the European guidelines are defining the sarcopenia with three main criteria: low muscle strength, low muscle quality and quantity, and low physical performance, as mentioned already. In coming to the ASEAN working groups, they added, in spite of the above the three criteria, they added genetic factor, nutritional factor, and lifestyle factors. Causes. The primary causes, usually as age advances, there is a muscle fiber atrophy, which ultimately causes the decreased muscle mass, and the common factor will be the reduced physical activity that accelerates muscle atrophy and weakness. The muscle disuse as a sedentary life decreases the protein synthesis and mitochondrial density and neuromuscular efficiency. Hormonal imbalances. Commonly, the testosterone is the key metabolic hormone for muscle growth. So as age advances, there is a decline about 1 to 2% per year, leading to the muscle wasting by reducing the testosterone level, by declining the testosterone level. Another thing, growth hormone and IGF-1, insulin-like growth factor 1. In fact, the growth hormone stimulates the IGF-1 production, which promotes the muscle growth and repair. Aging, usually as age advances, there is a reduction in the growth hormone and the insulin growth-like factor, and impairing the muscle regeneration and increase the fat deposition in the muscle group. Other thing, the secondary causes, commonly the cancer, all type of cancer, where there is a severe muscle wasting because of the chronicity of the disease, chronic inflammation, increased breakdown, and loss of appetite, reduced appetite is the important factor. Heart failure, ultimately there is a reduction in the peripheral perfusion of the blood to the muscles, leading on to the less oxygen supply and muscle atrophy. COPD, where again hypoxia is the culprit, and where there is a which lead on to the reduction in muscle function and volume. Malnutrition and other nutritional deficiencies, inadequate protein intake, malabsorption syndromes, and deficiency of all other vitamins, calciums and minerals, omega-3 fatty acids. So these are all the causes, secondary causes. CKD, one of the important cause for the sarcopenia is CKD. As the CKD advances, especially the stage 3 and 4, they are more presently with the severe type of sarcopenia. The accumulation of the uremic toxins and metabolic acidosis directly damage the muscle protein. Other contributing factors, chronic inflammation. So whatever it is, the aging itself, they are prone for inflammation, which releases the cytokine factors. Not only in the aging, all type of infection, chronic sepsis, which releases these factors, these inflammatory factors, and ultimately they inhibit the muscle protein synthesis. So among the other important factors is the insulin resistance. In our practice, the insulin plays a key role in muscle protein synthesis. The insulin resistance reduces the glucose uptake in muscles and impairing the energy productions and the protein synthesis, where the muscle is replaced by the fat. So this particularly significant in the metabolic syndrome, where the insulin resistance and obesity and also in type 2 diabetes. Other contributing factors, the neuromuscular degeneration as the age advances, where there is a reduced neuromuscular signaling and decrease in muscle activation and function, leading on to the fiber degeneration and atrophy. Oxidative stress are again an important factor, which increases the ROS, that is a reactive oxygen species production, leading to the damage to the muscle protein, lipid and DNA. Sarcopenia in obesity and diabetes, otherwise called the sarcopenic obesity, which is prevalent up to 40% in diabetic population. And again here, whenever there is sarcopenia, there is a loss of muscle mass. This is an important point. Loss of muscle mass, there is a less insulin response to the target tissue because the available muscle mass is less. So there is no, the insulin is not acting effectively. This combination again leading to the insulin resistance and associated with the other comorbid, landing onto the metabolic syndrome. So coming to this picture, so whenever there is a lack of exercise, this leading on to the obesity and insulin resistance, and loss of muscle mass, and later lead on to the loss of motivation to exercise, and this vicious cycle is continuous. So in practice, our aim is to break this vicious cycle, to succeed or overcome or successfully manage the problem of the sarcopenia. Sarcopenia and osteoporosis. Whenever age advances, not only the sarcopenia, it usually accompanies the reduction in the bone density, that is a bone mineral mass. That is weak muscles always associated with the fragile bones in aging population. It is high, again, both combination of both the things leading out to the high risk of falls and fractures and reduced mobility and independence. So this area pictures shows the separate sarcopenia one area and osteoporosis one area. This central area is most of them, when combined both, that area is that is present, most of the elderly people present with osteosarcopenia. Early signs and symptoms. Early signs and muscle weakness and reduced endurance, decreased balance and coordination, and fatigue and exhaustion. Functional decline. Usually there is a difficulty in climbing stairs, standing up from the chair and lifting an object. And the psychological impact, usually the loss of confidence and reduced social interactions and increased fear of falling. These are the risk factor, modifiable risk factor and non-modifiable risk factor. These are physical activity, hormonal imbalances, chronic conditions, poverty, these are all modifiable. Unmodifiable is the age, genetic factor and gender. So how to assess the sarcopenia clinically? So bedside we can assess the sarcopenia by doing a can grip strength using dynamometer. The early sign of sarcopenia, cutoff value is 27 kg less in men and 16 less in women population. So other test is a leg press test and isometric strength test. This usually there is a reduced lower limb strength, often leads to the increased risk of falls. Gait speed test, another physical performance test, a simple test ask the patient to walk for some period, some walk speed over in a ground. If the patient shows a reduced physical function, the cutoff value is 0.8 meter per second is diagnostic. So other three things are in clinical bedside testing is a balancing test, gauge speed test and chair stand test. So all the three categories you will have a 4 points, totally 12. If the patient is having less than 8 score, you indicates a poor performance. Other time it up and go test. So it's a simple test. Ask the patient, stand up from your chair, walk for 3 meters and turns and return to your chair. If it takes, the time duration is more than 12 seconds, it indicates the patient will have a high risk of falls. And a functional reach test, it measures how far they can reach the forward without stepping and losing balance. If the area is that the distance is less than 15 centimeters, there is a possibility of the loss of balance and indicates the high risk. So good diagnostic test in commonly practiced, the DEXA scan. So one of the gold standard one to find out the sarcopenia for measuring the muscle mass measurement. It shows a reduced appendicular skeletal muscle mass, ASM. So the ASM is low, ASM is a hallmark of sarcopenia. The cutoff value is 7 kg meter square in men and for women 5.5 kg per meter square in women. So this DEXA scan not only for sarcopenia is also very clearly discovered the bone mineral density. Indicates an idea about the bone mineral density, whether the patient is having osteopenia or osteoporosis. Most of the time in elderly, both the combination will occur. Now another is bioelectrical impedance. It is less reliable than DEXA, but indicates possibly for identifying increasing fat mass is useful. That is this test. So MRI and CT scan, usually we are not advising in practice, but sometimes to find out the muscle atrophy and the fat infiltration, it is useful, but for research purpose, usually we are doing these tests. Coming to the management, so modification, there is a behavioral changes and significantly impact the musculoskeletal strength. So simple measures like quitting smoking and managing chronic diseases. That is managing the secondary causes, all secondary causes, sepsis, including your cancers and all these things, and reducing the sedentary time. Always better advise the patient to reduce the sedentary time. It promotes everyday functional activity and essential to preventing the further decline. Nutritional support, feeling the muscle maintenance. So advise the patient to take high protein diet. It provides amino acids and which build up the muscles. Omega-3 fatty acids again have anti-inflammatory effects and that may support the muscle growth. Vitamin D and calcium is essential for muscle contraction and bone health. Leucine is another one, supplements, which is triggering muscle protein synthesis. That is taking by whey protein. Exercise programs. So age is not a contraindication for exercise program. We can perform the exercise program, we advise the program, motivate this program for all the people, irrespective of the age, unless otherwise there is a strict contraindication. Though this is in the form of resistance training usually promotes the muscle protein synthesis. Aerobic exercise will improve the cardiovascular and reduce the individuals with sarcopenia and other thing, balancing and flexibility training. This reduces the falls common consequence of muscle weakness. So pharmacological therapy, drug therapy, so far there is no single drug approved for sarcopenia. So under trial, these are the drugs, testosterone, the selective androgen receptor modulators, insulin-like growth factors, growth hormone, myostatin inhibitors, vitamin D and AC inhibitors. So some of the literature informations, the sarcopenia in elderly people with HIV during the pandemic COVID, they are very prone for sarcopenia. And sarcopenia, especially with the HIV patients, with chronic HIV with the ART, taking multiple drugs and the loss of appetite, they are usually presenting with sarcopenia. And post-COVID syndrome, the literature says most of them, they noticed even post-operative syndrome, the sarcopenia present by detecting with the loss of reduction in the weight. And yet more, another thing, in CKD, stage 3 and 4 usually present with sarcopenia. Those who are on long-term chemodialysis with renal failure, most of patients, they are presenting with sarcopenia. These are all some references. So sarcopenia, practically it's a whispers at first. Until your body shouts for help, start moving before you stop moving. Today is International Yoga Day. Nowadays, Yoga Day is a part of all exercise program. It is a part of all lifestyle modification program. Motivate some of our patients with sarcopenia for this type of lifestyle modifications program. Thank you for your patient hearing.
Thank you very much, Professor. You brought the very important feature of nobody should keep quiet, even in young, even if the physical body looks fit. Sarcopenia advances silently. Of all the measures, all of us, we should move at least 8,000 to 10,000 steps per day, whatever you are doing. Even our patients, pagalla time illana kuda night 8 manikku mela nada paravala. That is very, very important. Mobility prevents sarcopenia, and all the diseases must be addressed, very important. These kind of talks, we appreciate. Difference in APA. Thanks for the organizers.
Definitely, I congratulate the speaker for wonderful narration on this topic is emerging in recent arena. See, 1 year back I witnessed, which I repeated in API, annual meet at Chennai, sarcopenic obesity. When I visited RSDI, one leading speaker, I think he is the Mangesh Divaskar, he has spoken on diabetic sarcopenia. Very nicely, see these type of topics, when the speaker, Dr. Gopalakrishnan, approached me, I was very glad to accommodate this type of topic, because they're learning to people. See, when the patient becomes elderly, not only elderly, he has to give importance to exercise. There is a chemical substance known as irisin, which is secreted when you do regular exercise. This irisin imparts the benefit of not adding fat to the muscle, and also it makes the muscular degeneration, it ameliorates the muscular degeneration. Because as you said, sarcopenia is not only the decrease in bulk, mass, performance and power, but this irisin keeps muscle mass, strength and power. So it's a very good narration, and I think some of the anabolic steroids, vitamin D is another agent which will be very useful for this type of sarcopenia. So we have to differentiate between sarcopenia and cachexia. So that is very important. I congratulate honestly the speaker, Dr. Gopalakrishnan sir.
Thank you, sir. Thank you for you.
We'll go to the...
I want to tell a simple practical point. We want to reduce the fat, increase the muscle bulk. For a simple practical tip, stop your food for one meal. Take only two meals. Give fasting. Give importance to fasting. When your body is fasting for more than 14 hours, growth hormone secretes. We all know growth hormone is secreted when there is fasting. Growth hormone promotes muscle mass. So because of fasting, you can increase your muscle mass, and you can decrease your fat. And you have to give care to the quantity of food and the quality of food you take in the 2 meals. Thank you.
Yes. Vitamins, especially the benfotiothiamine another vitamin which works at the mitochondrial level, the Krista. So vitamin C, benfotiamine, and vitamin D is helpful to prevent this type of deterioration in the muscle mass and power. Thank you, sir. We'll go to formalities with the permission of chair. And it is time to honor the speaker first. We honor Dr. Gopalakrishnan through Dr. L. Raghupati, sir. இல்ல ஃபர்ஸ்ட் அப்படி போட்டோம் குணசேகரன் லாஸ்ட் வாங்க அடுத்த ஸ்பீக்கர் I'll we will honor first Dr. Palnivel Rajan sir. Dr. Muthumani will honor Palnivel Rajan with this memento. சரி அப்புறம் இவருக்கு குணசேகருக்கு வந்துச்சா? So the other two speakers will get the like to invite our friend from Krishnagiri, Dr. Raghupati, to honor our secretary, Dr. Gunasekharan, with this memento. Like to invite Dr. Ravichandran sir to honor Gopalakrishnan sir. I like to invite Dr. Muthumani sir to honor L. Raghupati sir with the memento. I like to invite Dr. Gunasekhar sir to honor Dr. Muthumani sir. I like to invite Dr. Panniselvam sir and Dr. Ravichandran sir to the dais to honor my secretary, our secretary, Dr. Gunasekharan. See, all along I have been left alone in the preparation of scientific agenda. He is from our secretary, daily used to call me and help me remotely to have this scientific agenda which you are undergoing this. What a beautiful advice. Appanraj sir, please come. What a beautiful advice. So, myself takes honor to honor. I like to We are proud to present this memento to Dr. Gunasekhar sir, who is the pillar of this Tapicon 2025. Without any hurdles, as a father, he has advised the Vellore district branch to conduct this show. Today it is happening smoothly. That is because of my brother, Dr. Gunasekharan. And the lip on லிப்பான்ல மாத்திக்கலாம் அங்க கொடுத்துட்டு
Thank you. Thank you. You can go for lunch. Please come back after 2 o'clock. Please come back at 1:55.
Good afternoon. Welcome to the evening session. Session 5, Special Therapeutics. I request the chairperson to occupy the dais, Dr. Ponmudi sir, Dr. Appandaraj sir, and Dr. K. Lavanya ma'am. I call upon the first speaker, Dr. Aditya KNV from Chennai to speak on mitochondrial dysfunction in diabetes, special reference to imiglamin. Over to you, sir.
Good afternoon, everyone. Welcome everyone to post-lunch session in Davidson Hall. Today's topic is from imiglamin.
Mitochondrial dysfunction in diabetes.
Mitochondrial dysfunction in diabetes, special reference to imiglamin by none other than Dr. Aditya, who is a consultant physician from Panimalar Medical College. Over to you, sir.
Thank you, respected chairmen. And I want to thank Tapicon organizers and everyone for giving me this opportunity to present in the presence of esteemed dignitaries. I have seen here my teacher's teacher. So I am really blessed to have this opportunity. So coming to the mitochondrial dysfunction in diabetes. So this was very interesting talk which was given to me. So when I went to it since 1 month, I have seen around 730 articles and everything. Please remember, this will be the future in coming decade. In coming decade, you can see the more cases and you can have the precision diabetes. Like in New Harrison, we have a chapter that is precision medicine. So each and every person is important. My own suit might not be useful for the other person. And each thing the patient requires a precision thing. So this is the place where I work. And coming to the diabetes global burden. In case of diabetes global burden, everyone must know that global diabetes is increasing. And coming to the India reference, we have around each now recent categories, like we have a pre-diabetes alone 131 million people, and in this hollow leaf can take around 4 people. We can have around 1% also. So slides are not moving. It's okay. If slides are not moving, also not a problem. So till then, we can have the business. Now I'm going to speak about the imiglamin. This imiglamin, we can have this thing from first we should know about the mitochondrial perspective. In coming to the mitochondrial perspective, okay. So I will just take us to the +1 and +2 thing where we are dealing with the mitochondria. When we are dealing with the mitochondria, the most important thing is the mitochondrial membrane potential. We should remember that whenever we are treating a diabetes patient, we should maintain the mitochondrial membrane potential. Here we have outer membrane, intermembranous space, inner membrane, and matrix. So this is the most important slide. This I want to concentrate more. Please remember, whenever you are dealing with the mitochondrial matrix, mitochondrial bioenergetic matrix, all of you would have heard that metformin causes the lactic acidosis. Why it causes lactic acidosis? It causes lactic acidosis because metformin adds at the complex 1. Here we are dealing with the electron transport chain. Complex 1, complex 2, complex 3, and complex 4. When we are dealing with the complex 1, it will causes the increase in the reactive oxygen species, and it causes the accumulation of lactate. And in case of imiglamin, it acts at the complex 3 and complex 2, and it prevents the reverse electron transport chain. So what is the relationship between the mitochondrial dysfunction and diabetes? Please remember, the most important thing we should remember is 3 things whenever you are dealing with the mitochondrial dysfunction. One is beta cell dysfunction, another is insulin resistance, and please remember muscle uptake. These 3 things you remember regarding the mitochondrial dysfunction. The most important thing in diabetes treatment is preservation of beta cell mass. And the excellent thing regarding the mitochondrial bioenergetics is imiglamin deals with the beta cell mass preservation. So this is the thing where you can see here GLUT2. You just concentrate at the level of the GLUT2 and please remember the concentration of IP3R. Why I am telling these things? GLUT2 is important in the uptake and IP3 to 3R will help in the mitochondrial matrix regulation. Please remember this sentence, mitochondrial matrix regulation. This will help you in the mitochondrial membrane potential. And why these things are important? Once the takeover main important point is whenever there is mitochondrial membrane potential dysregulation, it will inhibit the glucose sensitivity inhibited insulin secretion. The most important thing in type 2 diabetes treatment is beta cell preservation and glucose sensitive stimulated insulin secretion. So that will be get inhibited when there is a mitochondrial dysfunction. Now let's go into the imiglamin. Imiglamin is the first in imiglamin class. And why imiglamin action is there means it has action in the, please remember whoever postgraduates are there, this slide is very important. Imiglamin acts at the bioenergetics level. It will have action at the liver. It will have action at the pancreas. And it will also have the action at the muscle. The most important thing regarding the imiglamin is it can have the preservation of beta cell mass. And imiglamin also the important thing is it will help in you in the one line which you should sell is the, it increases the flux to the complex 2 to complex 3. I have shown the before slide where metformin acts at the complex 1. Imiglamin will act at the, increases the flux to the complex 2 and complex 3 and it will help in the reverse electron transfer. It will help in the reverse electron transfer to be decreased, which results in the decrease in the reactive oxygen production, species production. So this imiglamin will act at the please complex 2 and complex 3 and it will prevent the reverse electron transfer channel. Through this, the reactive oxygen species is reduced. And what is the dosage? There had been studies. I think till now around 750 studies are there, but I will present only the meta-analysis. Postgraduates, please remember, whenever you are presenting on anything, you should have studies which are meta-analysis or which have the double-blind RCTs or which have the cohort study. These are the studies you should always quote. And the dosage of imiglamin is 1000 mg BD. And regarding the pharmacokinetics, please remember, whenever you are dealing with imiglamin, the excretion is to the renal and its half-life is 13 hours. And adverse effects like hypoglycemia, gastrointestinal disorder, and constipation can occur in 1 to 5%. And I should deal in with the special population, renal dysfunction. The studies have quoted that GFR less than 45. Till then, you can give the imiglamin, but you should not give the 1000 mg. You should give 500 mg. And hepatic dysfunction, always remember, whenever you are dealing with hepatic dysfunction, always put it as a childhood criteria, and it is contraindicated in the pregnancy and breastfeeding because the studies are not there, and it is elderly tissues. Clinical studies. So the studies I am going to quote is the ×1, ×2, and ×3 studies. Here, why I am quoting these 3 studies is, ×1, they have done on the imiglamin monotherapy. And ×2, they have done on the imiglamin plus additional the OHS. And ×3 on the insulin. And I want to little rush and want to tell you that ×1 has told that monotherapy is useful. It is reduced in the HbA1c. And coming to the times 2. Times 2, here they have seen with the as an additional therapy. And here also they have seen that there is a reduction in the HbA1c. And coming to the times 3. Times 3, they have connected with the insulin. So anytime you are telling regarding the immiglin, please tell the studies you should quote is times 1, times 2, and times 3. Now we have dealt with the, this are lot Japanese study. I want the Indian study because I am treating the Indian patients. So what studies I can quote for Indian study? I should quote the study which is Indi time study. Indi time study is our own Indian study which was done on the 8,301 adults, and they have used all the drugs, and they found out that immiglin, when it is given with the DPP4 inhibitor, has better HbA1c reduction compared to the other drugs. And this is the latest Indian article, which is a Delphi consensus, which our key opinion individuals like Mohan sir and all this Krishna Seshadri sir, all article has came, which they have gave the consensus on immiglin. They were telling that in Indian population we can have 500 mg BD. And place in therapy, initiation, interchange, and intensification I can place. So this is my summary slide. The thing I want to say whenever you deal with immiglin is, first thing, you should use immiglin as a adjuvant therapy. Till now, the monotherapy, we have Japanese study, but Indian studies are less. And second thing, please remember, whenever you are given immiglin in Indian population, always look whether in elderly or whether the patient is having any pregnancy. In pregnancy, you should not give immiglin. In elderly, you should monitor the dose. And whenever you are given in the case of the CKD, GFR less than 45, please restrict the immiglin. With this, I conclude my talk. Thank you.
So wonderful talk, Aditya.
Thank you,
It's very good. Actually, questions are invited from audience. So my question is, so the study that is done in India has been done before prior approval only. So now monotherapy study is going on.
Yes, sir.
So it will be helpful. So like we previously used, we can use it. So how much HbA1c reduction you can expect in monotherapy in times?
Sir, in monotherapy, they have clearly found out that HbA1c reduction was more than 2.5 to 2.8, sir. But the problem is that it is differs with the variability. They have seen that subset elderly people had more reduction in the HbA1c compared to the younger adults. So that is where in the future targets, they were looking for the precision diabetes. Why in elderly? Because in elderly, we have this reactive oxygen species are more, because mitochondrial dysfunction will be more in elderly compared to the young individuals.
And similarly, we can use up to 30 eGFR.
Yes, sir. GFR 30 they were telling, sir, but GFR 45 the studies which were done more, so that's why GFR 45 was preferred. And the only constraint is that FDA approval is still awaited, sir. Post-market surveillance is going on, but Japanese and Indian approval is there, sir.
So are you using this drug?
Still, I have given very limited, sir. I want to know from the esteemed audience their experience regarding this thing, sir.
It's very, very wonderful drug.
Metformin intolerance.
Yes, sir. So many of the patients who are having gastric upset with metformin, they are better tolerating this drug. I have never seen any patient having any problem with this drug. And most of the time we are adding as a third drug or fourth drug.
Exactly.
But as a monotherapy, only as Sir told, only if the patient is not tolerating on metformin. Definitely changing this is very good. And in India, again, we are doing almost 500 milligram BD only we are giving
Yes,
for the
sir,
patients,
500
not
milligram.
1000 milligram. See, the studies, most of the things has been done in foreign countries. That
Foreign,
is
so
on their
in, yes, sir.
body mass area, that is very high when compared to India. So, thank you. Any?
Our next topic is the most important topic.
Thank you.
Where how to select antibiotics in intensive care unit by Dr. C. Dharmaraj Trichy.
Slide move பண்றது. Slide move பண்றது. இது forward இருப்பா. Respected chairpersons, senior professors and postgraduates, first of all thank the organizing committee Vellore give the opportunities. Still there is a problem in when, how, what is the duration to select the antibiotics ICU. Because of the ICU setup is different. And epidemiologically and depending on the ICU in various places, the organisms also and pathogenesis also, antibiogram also entirely different. Some places, some antibiotics useful because of particular pathogens will be present. It not fit for all ICU because of so many times, even is a higher centers. In higher centers, you not imaginally expected where the common organism present. It's a rare organism also possible into present even in the higher centers also. So that's why so this is the objectives. Whether it's a selection of antibiotics is very important for in the critically in the patients. Whether it's affecting the antibiotic size, then how to learn the stepwise approach to the patients. Whether it's the therapy will be present at the end of the target is, if the target achievement is present or not. So many times we will wrongly selected the antibiotics or sometimes with the pitfalls also present. So what are the important things for the selection of the antibiotics in the ICU setup? So first of all, know about what is the severity of infection. That is very important. Whether it is a very sick like a sepsis, or it is a multi-organ failure, or only is a limited infection is present. So first you know about the severity of infection. So when the delay of the antibiotics, because in the ICU, very critical patients, early selection and early administration and proper dose of antibiotics is very important. Otherwise, you will be increase the mortality. So delay the starting of the antibiotics. Empirically, we can start the high. Usually, the antibiotics is very important. So whether it's a multi-drug resistant bacteria is present or not. Whether it's the tricks can be altered the urea creatinine or any other problem is present. These are the usual things will be minded. Depending on the source, suppose whether it's a bloodstream infection or the source from the abdominal problem or source from the catheter or source from the any other like stable. So it's a different type of organism present with the different site of the bodies is present. Any special factors like diabetic patients or renal failure patients or patient on any treatment taken for any malignancies or not. That is very important to take for the selection of the antibiotics. Then mainly individual institutional antibiogram, that is very important. Periodically selection or monitoring of the antibiogram for institutional is very important. That is also very important for the selection of the antibiotics. first we can start for the, before the culture result, empirical broad spectrum antibodies must with the maximum dose with the periodically checking the any side effect is present or not. That is very important. Once the culture is will be arrived, unnecessary antibodies will be discontinued. Then the proper antibodies will be, we will start for the any infection in the ICUs. Depending on the culture, we can change the antibiotics, proper doses, proper duration, then monitor the side effects very, very, very easily. So de-escalate means withdrawal of the drug, if necessary. So this is the site. So when suppose VAP or hospital acquired pneumonia. So what is the commonest organisms usually present? So VAP or is a hospital acquired pneumonia, the commonest organisms Pseudomonas. Or is a multi-drug Staphylococcus aureus will be present, or Acinetobacter. Suppose catheter-induced infection, E. coli and Klebsiella enterococcus the commonest organism. Likewise, the abdominal is a bacteria and enterobacteria. Bloodstream usually Staphylococcus aureus, Candidiasis and gram-negative organism. And CNS infection usually Streptococcus the commonest problem, and Listeria and Pseudomonas. So main is the any allergy to the any antibiotics, especially by the beta-lactam. So we should monitor any allergy is present or not. Then dose adjustment for the any coexistent factors like any hepatic failure or renal failure or multi-organ failure, dose adjustment is very important. Then any CRT, ECMO, alter the clearance will be present or not. Then immunological status is very important. Any immunosuppression is present, we can alter the dose of the within person. Then any possible, any methicillin resistant Staphylococcus aureus or estimated beta-lactam organism can be present, where the colonization history is very important. Then recent antibiotics, suppose there are so many times, even home antibiotics can be usually we can advisable. So within 3 months of duration, what is the antibiotics usually we can use? So the recent antibiotics history is very important before starting of the any broad spectrum antibiotics, because of so many times we broad spectrum antibiotics given in the home itself also. So same antibiotics in ICU we continue it, sometimes with the patient will not improve. So that is a history is very important. So antibiotic uses for the first 3 months. Then any diabetic patients in the treatment history is very important. Past 1 month duration, any is proper treatment or maintenance of the diabetes is personal. This history is very important before starting antibiotics in ICU patients. Then I already mentioned about the individual institutions. So separate institutional antibiogram periodically monitor, regularly we will take for the culture, and you can proper antibiotic biogram can be selected for it. So many times with more than 20% Pseudomonas infection resistant to cefepime. So then we can possible to take for the any meropenem is present or better than the meropenem, what are the antibiotics available, you can use. So that is very important. So antibiogram is regularly we can follow it. So when the patient will select it. So before starting any treatment or sepsis, procalcitration is important biomarker for to selection of the antibiotics to selection of the sepsis. The procalcitration usually after 3rd day of the life. First 3 days the procalcitration never increased. Even the newborn patient also. Newborn patients usually after 72 hours only procalcitration can be elevated. So procalcitration can be taken for the biomarker for the whether is a patient is improved or not. That is we can start the antibiotics whether is a patient is improved or not. That is very important monitoring for the given the antibiotics in ICU. So importance of the patient improvement, then it's very important, and biomarkers also very important to start antibiotics any patient with sepsis. So early maximum doses of antibiotics compulsory for any septic patients. Then usually we can start for the broad spectrum antibiotics. Then we can withdraw the antibiotics whenever the culture positive or proven pathogens present or not. Selection of the antibiotics is very important. This is the usual antibiotics like sepsis, or usually start by the meropenem or vancomycin, or VAP infection, anti-pseudomonal beta-lactam, vancomycin or linezolid, or intra-abdominal metronidazole combination with the carbapenem or PLPL. These are the usual routine examples of antibiotics for the various sites of the organism. This is the other classes, beta-lactams, aminoglycans, glycopeptides, linoleucid. These are the antibiotics, what are the organism can be useful or not. So usually the culture is very important. So as soon as possible, you can possible to collection the culture. Before culture, sending of the culture sample, you can send the one sample enough for, either is you can select for whether it's blood culture or urine culture or is an infection site, that is very important. So multiple samples you can send, multiple result or multiple culture will be positive. So very difficult to selection of the antibiotics. Some urine culture given some antibiotics, blood culture given some antibiotics. So there is a confusion for selection of this. So which is important, you can select of them. And the sample of blood culture for minimum 50 to 100 ml is need for to positive culture will be present. Otherwise with the ICU patients, 2 to 3 ml culture never will shows any positive cultures. So minimum you can give for the at least 100 ml of samples will be given for the blood culture. This is a basic idea. So this is the selection of the antibiotics. Then the source of infection, where there is an abscess present, you can treat it. That is very important. Any stress is present, you can treat it. Then coincidentally factors, you can treat not only the antibiotics, coincidental factor also can be controlled. Suppose diabetes person, strictly diabetic control is very important. So when the de-escalation presents, so once you selected the cultures based antibiotics, you can reduce the dose or is it depending on the resistance and toxicity, you can alter the doses of the antibiotics. What is the duration? Minimum 10 to 10 days or maximum 40 days. You can must watch the improvement. That is very, very, very important. So empirically we can give the treatment or it's a culture-based treatment. So without the improvement of the patient, there is no use of continuous of the antibiotics. So very important, you monitor the daily basis of the patient, general condition of the patient. It is very important. So uncommon UTI only 3-5 days. So common UTI we cannot possible to treat. So many times the UTI simply you can leave it. With the sepsis definitely it can be possible to treat. So this is the dose adjustment, renal transplant therapy, ECMO therapy or pregnancy. These are the antibiotics we should avoid, either tetracycline or everybody knows about. So fungal infection definitely for the antifungals, either fluconazole or mimicazole. That's it. So when pitfalls will be present. So delayed treatment, wrong antibiotics, wrong dose, wrongly monitoring. That is very important. So delayed initiation of the antibiotics is septic shock. So immediately you can start the antibiotics for any patient with the septic shock, very important. So overuse of combination, multiple resistance will be expected. So combination therapy you can select, this is very important for them. Then you can adjust the dose with any renal failure patient or hepatic failure, that is also. So then empiric therapy can be continued even if a culture is negative, but if the patient is improved or not, that is very important. So I already mentioned daily review of the antibiotics, that is very important, whether it's a properly given or not, that is very important. Then patient improvement, side effects, monitoring all the vitals, everything. Then everything will be monitoring. So prompt action, main is what is the commonest site, already mentioned about the pathogens from the either abdomen or bloodstream or CNS, everything. Then regularly reassessment of the patients. Then is a rational use of outcomes, and that is very important. So selection of the antibiotics depending on the patient condition, resistance of the problem is present. So this is the guidelines for the selection of the antibiotics. Remember, antibiotics not like a antipyretics, that is very important. In OP patients also, or is a mild infection. So it's initially we can start at the broad spectrum antibiotics, definitely we will face in severe condition also. So antibiotics selection is very, very important. Depending on the base of the patient and culture sensitive only, we can give the antibiotics. This is the case scenario. So 60-year-old male, history of diabetes or CKD, present with fever, hypotension, tachypnea. So source of infection usually suspected is a lungs. There is a history of cough and bilateral infiltrates. X-ray also shows. Then vitals BP, according to this problem, is a typically see sepsis is present. So we can possibly do selection of the antibodies is piperacillin dosapide or management with vancomycin. Then adjust the dose for renal function, obtain cultures before antibodies. If the patient is not improved, you can possible to say whether we can start the antifungal or any other possible after prove the fungal culture is present. This is the next case scenario, 70% female, ICU with stroke and Holy catheter 5 days. Now with the fever with rigor, leukocytes, suprapubic tenderness percent. Urine analysis shows pyuria, nitrates positive. So again is empiric therapy with piptas and until the culture will be result. Then if the culture is possible, the ESPL or Mirapon can be possible. Then the infected source from the catheter, please rechange the catheter is very important. This is the commonest organism I already mentioned about. Thank you.
Thank you very much, sir, for your excellent lecture on the selection of the antibiotics in the intensive care unit. As you said very clearly, proper clinical examination will lead to your very good diagnosis. Even you have to see the unexposed parts very clearly. Sometimes the patient may be admitted where you may fail to see a sharp. Those patients, because of the rickettsial infections, may land up in ARDS, where even before the other reports comes or the scruff antigen antibody comes, we can start the patient on doxycycline by IV. They will have very good, excellent results. Only one question to you, sir. Yes, you are a very much experienced man. Just tell when we are starting an antibiotic, after 48 to 72 hours, we are getting the results of the cultures. The patient is improving, but in the culture report, the antibiotic which we are using is not responding to the organism. This is for the postgraduates and the youngsters to know. And vice versa also can occur.
So usually, sir, already I mentioned about, we selection of the culture very important. We multiple culture samples will send. So many times with the multiple culture will be positive with the various sites only. So selection of the site is very important, whether it's a blood or urine. So many times postgraduate, what will say? Usually taken for blood culture also, urine culture also. So there is a lot of confusion will be present. We will sort of instruct where is the source of infection. Suppose any history of aspiration present, we can possible to take from the source of culture from there only. Suppose you suspected a case of sepsis, you can select for the blood culture enough. Suppose in case of UTI, urine culture enough. So culture is only a single one, that is very important. Multiple site culture will be confused other results. So many times with the selection of the culture also, contaminated will be possible. So that is also the one problem, pitfall is present. So the patient is improved with antibiotics, but the culture never negative, sometimes it is possible. With some organism also possible to. That is my opinion about that. Any clarification, seniors, sir?
Anybody just want to add?
Whenever this cultures, regarding culture, 69 to 90%, if it is positive also it may not, it will act. 60%, if it is negative also it will act. That's a problem. In vitro and in vivo there is a lot of difference. So when patient is improving, it's better to continue. Thank you.
Thank you, sir. Thank you for the wonderful lecture, sir. Now may I invite Dr. Shivakumar, sir, from Trichy, to talk about the role of calcium channel blockers in clinical practice.
குட் ஆஃப்டர்நூன். ஹாலில் இருக்கிற ஒரு 33 பேர், சேர்பர்சன் ஒரு 3 பேர், 36 பேருக்கு தேங்க்ஸ். போஸ்ட் லஞ்ச் செஷன், நல்ல சாப்பாடு. ஆமாம், இப்போ வரப்போ எண்ணித்தான் அந்த. At the outset, I would like to thank the organizing team of Tapicon, Vellore. As of now, we have a lot of molecules in the calcium channel blocker in the market. We don't know which one is the best, which one we have to use our patient for the better outcome of the patient in day-to-day practice. There are a lot of confusion among these calcium channel blocker, which one is going to use. I hope I will clear your confusion at the end of this talk. It's a basic classification, as all of you well known. It's a non-dihydropyridine and dihydropyridine. Non-dihydropyridine, verapamil and diltiazem. Predominantly, it acts over the cardiac side. It decreases the contractility, decreases the heart rate, and decreases the conduction velocity. On vascular side, some smooth muscle relaxation, verapamil and diltiazem. Our field of interest today is dihydropyridine, predominantly on the vascular side. The first generation is nifedipine and now amlodipine and nimodipine, and the second generation is isradipine, nicardipine and felodipine. Third generation is amlo, silni and benadipine. The fourth generation is acylnidipine. I am going to cover only these drugs only, the nifedipine, amlodipine, cilnidipine, benadipine and acylnidipine for the want of time. The basic cardiac versus vascular selectivity is non-dihydropyridine, predominantly verapamil and diltiazem, predominantly acts for the SA node, AV node, and muscle contraction. So, because it acts for the SA node, it used in the treatment of some atrial arrhythmias and atrial fibrillation and so on. Since it increases the refractory period of the AV node, it used in the treatment of AV nodal certain reentral arrhythmias like AVNRT, AVRT, and so on. Since it reduces the contractility of the heart, it is very predominantly used in coronary artery disease. So, non-dihydropyridine predominantly in CAD and arrhythmias. Whereas, your dihydropyridine like nifedipine, amlodipine, benadipine, and other highly selective DHPs are predominantly used for the use of hypertension. Very important point note, these non-dihydropyridine should not be used in the presence of LV dysfunction. Then 3 types of calcium channels and blockers. The first one is L channel. It's a long-acting channel situated in the vascular smooth muscles, and in the kidney it's situated in the afferent arteriole of the glomerulus, only in the afferent arteriole. Whereas next one is an N-type channel. It's a neuronal channel situated in the sympathetic nerve endings. It releases when the calcium enters through this channel, it releases an norepinephrine, so it produces a lot of deleterious effect. I will tell you later. Then the T channel, it's a transient channel. It's a very important channel. It's a newer channel. It's situated in the pacemaking sensor of the heart, as well as in the adrenal medulla, as well as in the microvasculatures. Now we are going to see what are the drugs going to block in each and every channel. The L channel blocker is our amlodipine and nifedipine. Your N is cilnidipine. L and T is ephonidipine and acylnidipine. L, N and T is your benadipine. Very simple. We are going to cover one by one. As we know, CCBs are the mainstay of hypertension treatment. It's an isolated systolic hypertension, hypertension in block, angina pectoris, post-myocardial infarction, cardiac and coronary atherosclerosis, and prevention of stroke, especially in some certain social areas like COPD, asthma, patient on NSAIDs, patient on non-salt compliant patients. என்ன உப்பு எடுத்துக்காமல் இருக்க முடியாது, நான் ஊறுகாய் இல்லாமல் சாப்பிடவே மாட்டேன் அப்படிங்கிறவங்களும் அவனோட பின் போடலாம். Then gestational hypertension. Very importantly, vasoreactive pulmonary artery hypertension. Then coming to the amlodipine, amlodipine is a prototype L channel blocker, one of the gold standard drug in the management of hypertension. Some limitation with amlodipine is amlodipine increases the sympathetic activity, so it increases the heart rate, that is reflex tachycardia. Then amlodipine does not decrease the aldosterone, so it increases the proteinuria. In the patients with moderate to severe heart failure, amlodipine does not prolong the survival or reduce the risk for the hospitalization. Of course, we know the side effects are edema and palpitation. Once the drug cilnidipine came, the people are very happy, very excited. They jumped from amlodipine to cilnidipine because the cilnidipine is going to address L channel as well as the N channel. Because all the notorious effects produced by the N channel, that is norepinephrine release produces vasoconstriction, increase the cardiac contraction, increase the heart rate, decrease the renal blood flow, and decrease the renin secretion. All the ill effects, notorious effect produced by the calcium enters through this N channel. This cilnidipine will address both L and N channel, so people are expected more excited and jump from amlodipine to cilnidipine. But they expect, when you block this, they expect this vasodilatation and decrease the cardiac contraction and heart rate, and increase the renal blood flow and increase the relaxation. But these are only theoretical. So people compare this cilnidipine and amlodipine. The number of studies in the PubMed is more than 4,000 studies for amlodipine, only less than 200 for cilnidipine, 20 times more data available on amlodipine. Number of clinical trials, more than 1,300 for amlodipine, only 60 for the cilnidipine. The patient studies in clinical trials, each major trial has more than 10,000 patients, more effective data analysis due to more number of patients. It's well documented. It is recommended by the global guidelines. Beneficial in patients with comorbid conditions like CAD, amlodipine say yes. Amlodipine reduces the CV mortality and CV events and stroke. It was introduced in 1986, almost 39 years back. Cilnidipine introduced was 1995, in 30 years back. Amlodipine is a problem with the pedal edema, but with the good BP control. Whereas cilnidipine is less edema because less BP control. The effect is less. So when you convert this all data into the real world evidence, RWE means real world evidence, the poor BP control with cilnidipine requires at least 20 milligram per day, where the side effects are same with amlodipine. There is no clinical event reduction studies so far. So the amlodipine has achieved a notable recognition in the treatment of arterial hypertension due to high selectivity for the vascular smooth muscle. A slight impact on the heart rate. It has certain pleiotropic effects, inhibits the vascular smooth muscle proliferation and free radicals, and exhibit anti-atherosclerotic effect and nitric oxide donor. It provides better protection against the fatal and non-fatal stroke than the older drugs like the beta blockers, diuretics, and AC. It's a guideline recommended drug for the vasoreactive pulmonary artery hypertension. It's recommended by all major hypertension management guidelines. Most often cannot be used due to side effects. You know very well, edema, palpitation, constipation, and gum hypertrophy. It does not reduce the albuminuria. Then coming to the cilnidipine, it blocks both L and T type channel, produce vasodilatation and heart rate. 17 folds higher lipophilicity than the amlodipine. That is the main point favor this cilnidipine. Because of the tissue penetration is more with cilnidipine, that was they introduced. It has some negative chronotropic effect. It inhibits aldosterone synthesis and secretions. Dilates the efferent arteriole. But these effects produced only in the preclinical studies. All are animal studies, not proved in the human studies. Don't be panic about this slide in the afternoon hours. What this is, it reduces daytime and nighttime BP reduction. Cilnidipine reduces daytime, nighttime BP reduction. It decreases heart rate, decreases the urine albumin, decreases the surrogate markers. It proved some anti-atherosclerotic effect, the effect proved by an intravascular ultrasound. They say non-inferior to amlodipine. It is a decent way of saying inferior. It is not a superior or equal. It is a decent way of saying inferior, which is non-inferior. The pitfall in these studies are, there is a low sample volume, only 50 to 100 patients. All are Chinese studies, no trials on clinical event reduction, only for pure BP reduction with no clinical benefits. The dosage, 16 milligram. Certain specific population like severe renal impairment, severe hepatic impairment, pediatric usage, pregnancy, these are all the things the efficacy have not been established. The elderly, you can use a low dose. However, in non-diabetic nephropathy and diabetic nephropathy, proteinuria and microalbuminuria, in these situations, CCB are no value. They are not recommended in the use of nephropathy patients. So it proven this documented CV mortality benefit. The long-term outcome trials involving more than 87,000 patients proved significant reduction in the total mortality by 10%. Once again, a gold standard drug for the treatment of hypertension. It reduces the total and CV mortality, combined major CV events, myocardial infarction, especially more importantly, stroke. Whereas cilnidipine, eflornithine, there is no human evidence in reducing morbidity and mortality. Then coming to the benadipine, which is a latest drug, it has associated with the high affinity for the cell membrane. As a result, it binds the dihydropyridine site, that is alpha-1 subunit of the dihydropyridine site, by entering through the cell membrane. Because of the enters through the cell membrane, that is grade binding, is more effective. Because the binding is very slow, so there is no abrupt fall in BP. The dissociation is also very slow, so there is no, it is long acting. Then high lipophilicity because it is better tissue penetration. Certain renal benefits of the benadipine, it is a reduction of glomerular pressure after dilatation of the afferent as well as the efferent arteriole due to inhibition of T-channel blockade. Marked increase in a renal plasma flow rate, microvascular dilatation, natriuretic effect, and increased nitric acid formation, and reduction of aldosterone. Aldosterone, it will, because of the T-channel blockade. They compare the benadipine with amlodipine. In the renal vessels, amlodipine dilates only afferent arteriole, whereas benadipine dilates both afferent as well as efferent arteriole. EGFR, significant increase. Urinary albumin creatinine ratio, serum aldosterone is decreased with benadipine. Serum sodium and potassium, there is no change between the baseline to end in both drugs, both amlodipine as well as the benadipine. So without any investigation, you can start this calcium channel blocker. Suppose if you want to start on a beta blocker or ACE inhibitor, you have to check the creatinine or potassium. But whereas when you start the calcium channel blocker, there is no need to investigate anything. Straight away you can start. The maze-free interval in vasospastic angina is better outcome, amlodipine with less outcome. Then another common pitfall we are seeing in the day-to-day practice, calcium channel blocker induced edema, people are prescribing diuretics. But basic pathology in this edema in CCBs, because the L-type channel only dilates the arteriole. There is no impact on the venules. It dilates only in an arteriole side. So since it increases the precapillary resistance and the extravasation of fluid and pedal edema. This is pertaining to amlodipine. Whereas your benadipine, it dilates arteriole as well as venule, because it's a T-channel blockade also. Because of this dilatation, there is decrease the capillary pressure and decrease the pedal edema. So just stop the drug, the edema will settle on its own within 3 to 4 days. No need to add on diuretics, especially patient present with a CCB-induced edema. Then benefits of aldosterone reduction is very useful in the resistant hypertension, cardiovascular protection, renal protection, safer combination with the AC and ARB without hyperkalemia, safer in heart failure. Benadipine has had some clinical event reduction evidence. These advantages are only with the T-channel blockade. Cardiac benefits, apart from the clinical BP control of benadipine, it's a 24-hour BP control, no reflex tachycardia, higher coronary vascular selectivity, nitric oxide donor, aldosterone reduction, and microvascular dilatation. I am going to give some kind of clear image which drug, which drug, with arterial drugs we are going to use in the future. Nifedipine is only long-acting, best BP-reducing drug of all, only long-acting preparation, no short-acting, no sublingual administration at all. In the olden days, we are giving sublingual nitrates for hypertension urgency. Nowadays, they are not at all recommended. It is very useful in gestational hypertension, resistant hypertension. Quick BP reduction can be used in hypertension urgency, not to be used in CAD without beta blockers. Usually, long-acting preparation given twice a day is a potent drug, so avoid in elderly. Dose is 20 to 60 milligram per day. Then amlodipine is the first choice in calcium channel blocker in systemic and pulmonary hypertension. Well proven, evidence-based CCB, guidelines recommended, good BP control, long-acting, once a day. Many pleiotropic effect other than BP control, significant reduction in clinical endpoint, especially stroke. To be changed to other CCB only when not tolerated due to the side effects. Best add-on with the beta blockers, AC and ARB. First drug you can start without any investigations. Cost effective, easily available everywhere, not an initial isolated drug in the CAD and heart failure. Benadipine, the next best alternative to the amlodipine, less edema, less palpitation. Recently introduced some clinical edema, clinical outcome data available. Benefit of aldosterone reduction without hyperkalemia. Best combined with AC, ARB in proteinuria. Can be used in CKD and proteinuria if AC, ARB cannot be used. Mortality benefit in vasospastic angina. Can be used in microvascular angina, especially in ANCA syndrome. Expensive. Availability is limited. Introduced from Japan, but no guidelines recommended so far. I'm using Benadryl for the past 3 years, especially in patients with hypertension, with CKD patients. The effect was so good. It's only experience. Then cilnidipine and lecanidipine only when amlodipine is not tolerated. Only when Benadryl is not affordable, not available. Only when Benadryl cannot be combined with AC or ARB due to the reasons mentioned. Only when you are able to achieve BP control and not for reducing edema without BP control. Only as an add-on drug in the above situation. Then acylindipine and ephonidipine, no clinical outcome data so far. Most are animal data, very small human trials with the surrogate endpoints, non-inferior to amlodipine BP reduction. They are not equal or superior, expensive, limited availability. Only indication is the pressure, not the blood pressure. Do you know? I hope you know what the pressure is by the representatives. The ephonidipine dose is 40 to 80 milligram once a day, and acylindipine is 18 to 16 milligram once a day. Then a combination is very important. So amlodipine with the beta blocker in CAD, amlodipine with AC or ARB, the initial best combination in the management of hypertension. Benadryl with AC and ARB in proteinuria to prevent the progression of CKD. Benadryl plus clonidine or alpha blockers in the presence with the CKD or in aldosterone inhibitor intolerance. Then Benadryl with the nitrates, vasospastic angina. Of course, don't forget about the side effects, gum hypertrophy, constipation, reflux tachycardia, flushing, and so on. Then summary and takeaways, this is purely experience-based. The amlodipine is the best, but the problem is side effects. The next one is Benadryl, less side effects, but renal advantage. Cilnidipine and lecanidipine, was BP, not edema. Acylindipine and ephonidipine, not now. Nifedipine long-acting, gestational hypertension, resistant hypertension, and hypertension urgency. The takeaway, safest amlodipine, fastest nifedipine, weakest, not weakest, it's a weak cilnidipine, latest and good Benadryl, but not in recommendation, least studied acylindipine, ephonidipine. With this, I hope I clear our conclusion. I hope you have the clarity. Thank you, sir.
Thank you, Sukumar sir, for a wonderful talk. You added your practical experiences also. It's really eye-opener for everyone. Any questions from the audience?
Ten years after taking CCB.
Can edema come for the first time after 10 years? If the patient has been there for 10 years, till then she didn't.
Ma'am, like an AC inhibitor and cough, you have to live with the cough. That because the beneficial effect is more than that of the side effects. It's very important. You can live with the cough instead of giving die with heart failure. Like that, you can live with a mild edema, don't bother.
But can it present first time, sir, after 10 years of the drug is what I'm asking.
Any drug, madam, I'm not depending anywhere it will produce because it not dilates the venule. It only dilates the arteriole, so precordial hypertension is there. Even after telmisartan combination, still amlodipine will dominate over the telmisartan, the edema will be there. So don't bother about edema. Yes, just accept it. Yes. Pulmonary hypertension. I'm not dependent. Yes. Safest.
After 10 years also it can cause, ma'am. So it is not needed that it has to cause immediately. So it can happen even after 5 years, 10 years also. But when it coming after some time, so we have to rule out other causes. That is the main thing we have to do. So we have seen many patients who are on amlodipine for a longer period of time coming with the pedal edema, and if the patient is accepting, we will allow them to continue with the edema. Thank you.
But practice la வந்து மேடம் நீங்க வந்து amlodipine கொடுக்கறப்பே கால்ல வீக்க வரும்னு சொல்லிட்டே கொடுங்க. அவன் மென்டலாக அவனை டியூன் பண்ணிடுங்க. கான்ஸ்டிபேஷன் கம் ஹைப்பர்ட்ரோஃபிலாம் சொல்லாதீங்க. வந்தானா நீங்கள் நான் வாங்க சரி பண்ணுறேன்னு சரி பண்ணிடுங்க. திஸ் ஆர் ப்ராக்டிக்கல் எக்ஸ்பீரியன்ஸ். பட் இது வரும்னு சொல்லியே கொடுங்க. அது வந்தால் தான் உன் ட்ரக் நல்லா எஃபெக்டிவாக வேலை செய்யுதுன்னு அர்த்தம். வீக்க வந்தால் என்கிட்ட சொல்லு அப்படின்னு சொல்லுது. Yes, sir. But theoretical is only, sir. They are proved. Vasoreactive pulmonary hypertension, even amlodipine is proved, sir, when compared with cilnidipine. One trial, I don't know the exact name of the trial. Thank you, sir.
Thank you, sir. I request all the speakers to come onto the stage. I request Dr. Ponmudi, sir, to honor Dr. Aditya. Followed by Dr. Apandaraj to honor Dr. Dharmaraj. Dharmaraj, sir. Dr. Lavanya ma'am to honor Dr. Sivakumar, sir. I request Dr. Aditya to give the memento to the chairperson, Dr. Ponmudi, sir. I request Dr. Dharmaraj, sir, to honor Dr. Apandaraj, sir. And I request Dr. Sivakumar, sir, to honor Dr. Lavanya, ma'am. Thank you, sir, and thank you, ma'am. And next session, clinical medicine, I request Dr. Namashwar, sir, from Trichy to chair the session. First topic is non-alcoholic fatty pancreatitis by Dr. Manoj Kumar, sir, from Vizag.
Good afternoon, everybody. First of all, I thank the organizers for giving this opportunity to talk about one of the upcoming topic of non-alcoholic fatty pancreatic disease. So, we all know about NAFLD, non-alcoholic fatty liver disease. NAFLD and how it turned to be MASLD, metabolic associated dysfunction associated steatotic liver disease. So this is one of the upcoming non-alcoholic fatty pancreatic disease. So when you take about fat and pancreas, we are supposed to know some of the terminologies. They look like very similar, but they are different. Fatty infiltration of pancreas, FIP, IPFD, fatty pancreatic, intrapancreatic fat deposit, fatty pancreas, FP, fatty replacement of pancreas, FRP, PS pancreatic steatosis, NAFPD non-alcoholic fatty pancreatic disease, NASP non-alcoholic steatopancreatitis, lipomatosis, pseudopancreatitis, and pancreatic lipoma. All these things are related to pancreas and fat. Today we are bothered about NAFLD, non-alcoholic fatty pancreatic disease. So we all know that in the worldwide there are more people suffering from obesity, more than 1 billion, and of that 2.8 million are deaths related to overweight and obesity. And whenever there is increased fat, it is deposited in pancreas is like liver, pancreas and skeletal muscle, which is called steatosis. And NAFPD is an emerging disease, and obesity is a significant risk factor for NAFPD, and pancreatic fat content is positively correlated with your obesity. So NAFPD is defined as any fat in the pancreas accumulation with absent or minimal consumption of alcohol. When you take NAFLD, it is 20 grams of alcohol per day. Then it is more than that, you can tell non-alcoholic fatty pancreatic disease. Here it is 14 grams per day alcohol consumption. Less than 14 grams, if it is having, still you get fatty pancreas. So NAFPD is defined as a pancreatic steatosis phenotype in absence of alcohol consumption, viral infection, toxin and congenital metabolic syndromes, but associated with insulin resistance, malnutrition, obesity, metabolic syndrome, increasing age, pancreatic fibrosis and pancreatic cancer. So here NAFPD is still in infancy. That is recently they are studying more. It is strongly associated with your metabolic risk factors like metabolic syndrome and obesity. So Schaffer first reported that excessive accumulation of pancreas fat is correlated with the body fat. And Ogley reported 17% of higher pancreatic fat in obese patients when compared to lean patients. Olsen observed a significant increase in pancreatic fat with advancing age in both sexes. Whereas Tamman reported 25% increase in the pancreatic fat will cause your type 2 diabetes mellitus and atherosclerosis. So the obesity is a significant risk factor for NAFPD, and pancreatic fat content is positively correlated to BMI. Increasing BMI, you get more chances. So maternal obesity and a high fat postpartum diet also increase the risk of NAFPD. So in a study of, one of the study of Chinese study showed NAFPD prevalence of 11% and more with age. And meta-analysis pooled data, they yielded a 33% of NAFPD. And in general population in Asian study, it showed 16 to 35%. And in one of the Chinese study, 2016, it is strongly associated with the metabolic syndrome. NAFPD and metabolic syndrome is associated. So what are the risk factors to get NAFPD? Age, men, male sex, hypertension, low serum lipase activity, hyperferritinemia, and other risk factors. All these things increases NAFPD. So here, whenever in NAFLD, whenever we are telling NAFLD, fatty liver disease, there is accumulation of triglycerides in the fatty liver cell. Here it is two types. Here the mechanism of NAFPD is two. One is infiltration of fat. The other one is whenever the pancreatic cell dies, it is replaced by adipocytes. So here both will increase your pancreatic fat. Not only fat accumulation, replacement of cells, dead cells by the adipocyte also increases the fatty pancreas. So whenever there is a large amount of fat accumulated anywhere, it causes inflammation. So pro-inflammatory cytokines like TNF, IL-beta and IL-6, all these things will cause inflammation, fibrosis and insulin resistance. So a study of pancreatic fat in ultrasound in 184 study subjects, there is a 67% patient with both fatty pancreas and fatty liver. And this can be early sign of fatty pancreas is early to get deposited than fatty liver. So by the time you have a fatty liver, there is already the fatty pancreas. Fatty pancreas and fatty liver are interconnected and mutually reinforcing. And liver steatosis is mainly caused by increasing level of triglyceride, whereas here it is accumulation of the adipocyte, not only fat, adipocyte also increase also. So how to see this NAFPD? That is histological biopsy, it is not routinely done, only in autopsies. Ultrasonography is not a good modality because the window is not clear. Endoscopic ultrasound is one best to see the study of the NAFPD. CT scan and MRI, this magnetic resonance proton dense fat fraction, MR-PDFF. This is the best modality to study the pancreatic fat. Magnetic resonance spectroscopy is still in the, for only studies purpose, clinical studies. So when you have a NAFPD, what are the consequences you will get is acute pancreatitis, metabolic syndrome, endocrine dysfunction of the pancreas, exocrine dysfunction of the pancreas, pancreatic fistula, and pancreatic cancer. These are the consequences of NAFPD. So metabolic syndrome, there are several reports relation coexist between NAFPD and metabolic syndrome. And some suggest, even studies are suggested that it should be a part of metabolic syndrome. And acute pancreatitis is one of the side effects of NAFPD. The cytokines, especially IL-beta and TNF-alpha produced by adipocytes in combination of free radicals, will cause acute pancreatitis. Endocrine dysfunction, NAFPD is strongly associated with type 2 diabetes mellitus in humans, and pancreatic fat content of type 2 diabetes mellitus is significantly higher in fatty people or obese people. So in a study, 52% of the NAFPD people had either diabetes or pre-diabetes, total dysglycemia. NAFPD is independently related to pre-diabetes and diabetes. When the studies like in NAFPD and insulin resistance, this is a little controversial. One study showed there is a relation between diabetes and NAFPD, but other studies showed there is no much, especially in pediatric studies, they showed there is no much association between NAFPD and obesity and diabetes. So exocrine dysfunction, NAFPD is a potential factor for exocrine dysfunction, leading cause of pediatric pancreatic insufficiency, and coexisted with exocrine dysfunction, frequently presented childhood syndromes, especially Johansson-Billiard syndrome. This is autosomal recessive disease where exocrine pancreatic insufficiency, hypoplastic LNSA, and cutis alopecia, and other features also are there. And Schwarzman-Diamond syndrome, it is a triad of exocrine pancreatic dysfunction, skeletal abnormalities, and bone marrow dysfunction. So here also we will see most of the NAFPDs. So pancreatic fistula, NAFPD significantly increases the risk of developing a post-operative pancreatic fistulas. And pancreatic cancer is one more thing. Pancreatic intraepithelial neoplasia, PIN, is a precursor lesion of pancreatic ductal adenocarcinoma, which is associated with NAFPD. Obesity is risk factor for pancreatic cancer. So when we see what are the current therapies available for this NAFPD, currently there is no standard therapy for NAFPD. Dietary intervention and intensive exercise for like non-alcoholic fatty liver disease, same thing applies. Troglodyone tried, orlistat is tried, liraglutide is tried. These are the drugs which are tried in fatty pancreatic disease, various trials, preclinical, non-RCTs, RCTs, from biguanide, sulfonylureas, thiazolidines, GLP receptor agonists, and your DPP4, statin, fibrate, pancreatic lipase inhibitors, ARBs, stomatostatin receptor agonists, antioxidants. Only drug which is showed in all three is your GLP receptor agonist, which showed improvement of NAFPD in preclinical and non-RCT, RCT. So rest of the things are not much established in treating the NAFPD. So this pancreatic disease originating from intrapancreatic fat disease, Pandora hypothesis. This one is, they are studying more on this to alter the course of your diabetes, pancreatitis, and pancreatic cancer. So all these things, when we study, when we can alter all these things, we can prevent your diabetes, pancreatitis, and pancreatic cancers. So when you compare fatty liver and fatty pancreas, so like your NAFLD, it is NAFPD here. Like non-alcoholic steatohepatitis here, non-alcoholic steatopancreatitis. Liver cancer is more common there, pancreatic cancer is more common here. There is increase in hepatocyte, the fat, here increase in the pancreatic fat, as well as pancreatic fat cell also increases. Diabetes is more common in fatty liver, it is less common in fatty pancreas. Exocrine deficiency is more common in NAFPD, less common in NAFLD. Metabolic syndrome is well established in NAFLD, but still it is not much correlated in NAFPD. Just like our FIP4 score, for NAFLD we have a FIP4 score, like that there is a FIP score. FIP score is like obesity, dyslipidemia, fatty liver. All three, any one, more than three, any one is there, of the other one or two, each one get 1 point. If any of the three is there, you can look for NAFPD. So NAFPD needs more study because it is emerging problem, and NAFLD and NAFPD both are causing metabolic syndrome and CV mortality. Metabolic syndrome, either it is a cause or consequence, is still not well established. There are no treatment guidelines as of present. Thank you. Only thing is, we are seeing more of the patients like in nowadays, we have to screen for diabetic patients. All diabetic patients we should look for NAFLD. All NAFLD patients we look for diabetes like that. Maybe soon we may have to even see NAFPD also. Thank you.
Thank you, sir, for a wonderful presentation on the new insight in the non-alcoholic pancreatic disease. So I just want to know what is the incidence of endocrine exocrine dysfunction in this non-alcoholic fatty pancreatic disease?
Exocrine.
How common you have encountered? So endocrine and exocrine dysfunction.
That's what. Exocrine dysfunction, endocrine dysfunction, actually diabetes is established, sir.
Oh.
But exocrine dysfunction, most of the time, we are just seeing exocrine dysfunction as a separate entity till now. We are not related to fatty pancreas, NAFPD. Okay. Now they are studying and they are trying to correlate NAFPD as a cause of exocrine dysfunction. Because previously, in diabetes, we see exocrine dysfunction. Separately, we see, now they are studying NAFPD as one of the cause of metabolic syndrome causing exocrine dysfunction. Now, because this entity came up recently, because exocrine deficiency exists since a long time. We have studied a lot. There are a lot of syndromes also associated. But whether this association, NAFPD, to your obesity, metabolic syndrome, and exocrine dysfunction, that's been studied recently.
What is the best drug to tackle all these problems together? So diabetes on one side and pancreatic disease on one side. What do you think will be the best
only
drug?
GLP receptor is the only thing approved, all clinical, prior clinical and all the studies, but most of them, all the drugs are in trials. First of all, the concept is not clear till now, whether really to treat it or not. Only thing is, whenever you have NAFLD, you can have NAFPD. If you get NAFPD, look for NAFLD. But anyhow, whatever you are treating for NAFLD may also act for NAFPD.
Okay, so thank you. So any question from the audience? If there's no more question, I think we'll close the session. We go for the next session.
Thank you.
Thank you. Thank you, sir.
Thank you.
So the speaker for the next session will be Dr. Jayasudha. The topic will be easy ways to tackle resistant hypertension. Over to the speaker now.
Thank you so much, sir, for the introduction. Good afternoon. It's an absolute honor for me to stand in front of you for the presentation in Tapicon 2025. And I'm so thankful to the organizing committee, their chairperson, and you for your time and patient listening. So today, let us move on to my topic. So my topic for today is resistant hypertension and what are the easy ways to tackle this. So before saying about the resistant hypertension, I just wanted to share with you the 4 clinical scenarios which makes you understand what is true resistant hypertension. So case scenario 1, here 58 years old female, Anita, who is on losartan 50 milligrams. Her clinic BP is 160/90. So, but she denies that whenever she monitors BP at home, it is normal. So I thought of adding a ABPM to her. So on ABPM, the average blood pressure is 130/80. So what is the diagnosis? This is called white coat hypertension. So we have to rule out white coat hypertension. So which our guidelines says, mainly the AHA, ESC and CCGM recognize this pseudo hypertension, including that white coat hypertension, as a key differential in before diagnosing a person with a resistant hypertension. So the difference between the white coat and the true hypertension is that, so there will be elevated office as well as the 24-hour ambulatory blood pressure monitoring. The BP is elevated in true resistant hypertension, whereas it is normal in case of white coat hypertension, and the nocturnal dipping will be blunted in true resistant hypertension, whereas it is normal in white coat hypertension. So here is our second clinical case. A 54-year-old gentleman, Mr. Salman, who is on Ramipril 10 milligrams, amlodipine 10 mg and hydrochlorothiazide 25 milligrams. His blood pressure is found to be elevated, always more than 160/100. On examination, we can hear abdominal bruit, is a lean person, and a creatinine of 1.8. So on evaluation, his renal Doppler showed right renal artery stenosis. So what is the diagnosis? The diagnosis is a secondary hypertension due to renovascular causes. Here are the list of the secondary causes for secondary hypertension, including the renal and the renovascular and the endocrinological causes. These are all to be ruled out before terming a patient as resistant hypertension. This is our third clinical scenario with a 45-year-old female, Ms. Priya, who is on olmesartan 40 milligrams with amlodipine 5 mg and indapamide 1.5 milligrams. Her blood pressure found to be elevated for the past 3 months. And on probing the history, she admits that she used to skip the medication in view of, because she is scared of the side effects and the cost also. After adequate counseling and the patient adherence to the medication, her blood pressure dropped. It came back to normal with 130/80. So what is this? This is uncontrolled blood pressure due to non-adherence of therapy. So our major, this is a CCGM article released in 2023, which lists that pseudo-resistant factors, especially the medication adherence failures, improper measurement of blood pressure, and the white coat hypertension, to be ruled out before we are terming a patient as a true resistant hypertension. And it also emphasizes the need for ABPM before terming a patient as a resistant hypertension. This is our fourth clinical scenario. Here, 62-year-old male, Mr. Rajesh, who is on amlodipine 10 milligrams, telmisartan 80 mg with chlorthalidone 25 milligrams. Its blood pressure is found to be always elevated, that is more than 140/90, which is persistently elevated for the last 4 visits. And the ABPM also confirms the same elevation of blood pressure with the ECG showing a LV strain pattern. So the diagnosis is the true resistant hypertension. So what is true resistant hypertension? As per our guidelines, the AHA 2018, ESC, ESH 2023, and the International Society of Hypertension 2020, they are giving the definition like elevated blood pressure more than 140/90, despite taking 3 or more antihypertensive medication, one of which should always include a diuretic, mainly a thiazide-like diuretic, or a person's blood pressure is either controlled or uncontrolled even after taking 4 classes of antihypertensive. They are termed as a resistant hypertension. So the patient should be on 3 medication, including a diuretic, with the blood pressure uncontrolled. They are termed as a resistant hypertension. Does the definition includes any time frame? No, most of the major guidelines, they do not specify an exact duration. But they emphasize that before terming anyone as resistant hypertension, the patient should have a sustained elevator of blood pressure over multiple visits, probably 3 to 6 months of time, with the confirmed adherence to the therapy and proper BP measurement as needed before terming the patient as a resistant hypertension. So how are we going to manage the resistant hypertension? Through three measures. One thing is the lifestyle intervention, pharmacological treatment, and device-based therapies. So lifestyle intervention, so it's the same, the old wine and the new bottle. It is like everyone discussing about this lifestyle modification and for any metabolic disorder. So healthy eating, regular physical activities, moderating the alcohol consumption, cessation of smoking, weight management, and salt-restricted diet plays a very important role in reducing the blood pressure. So this is a DASH diet. So this is NEGM older article only, which again emphasizes a diet rich in fruits, vegetable, and low-fat dairy fruits with reduced saturated and total saturated fatty acids can substantially lower the blood pressure. So moving on to the dietary sodium and hypertension. Dietary sodium plays a vital role in making the BP resistant to the whatever the medications we are giving. So first of all, these are the mechanisms. One thing is that the dietary sodium can increase the intravascular volume. It can blunt the pressure natriuresis, and it can also reduce the efficacy of the RAS blockers, thereby making the patient resistant to the medications. And it can cause endothelial dysfunction, and increased salt intake can cause the activation of sympathetic nervous system, and it increases the pro-inflammatory and oxidative stress pathways, making the person as resistant hypertensive. This is a very important slide. I want this slide to be in black, colorful, but I don't know, I can't able to make it. It came as black and white only. See, so here it correlates well the lifestyle modification, how the lifestyle modification is going to reduce the blood pressure. The weight loss, that is 5 to 10% of the, loss of weight, or the 10 kg body weight, losing 10 kg body weight can reduce the systolic blood pressure by 5 to 20 mm of Hg and the diastolic by 3 to 10 mm of Hg. And the DASH dias, definitely it has the effect. Like it reduces the systolic by 8 to 14 mm of Hg and 3 to 5 mm of Hg. All other lifestyle modification can definitely have the influence on the systolic BP between 4 to 8 mm of Hg and the diastolic BP like less than by 5 mm of Hg. So moving on to the pharmacological management where we comes into role. So here, so a person who have been treated with a 3 medication including a diuretic, we are terming the patient as a resistant hypertension. The step 2 is to substitute the optimally dosed thiazide like diuretic. For example, if the patient is on the hydrochlorothiazide 25 milligram, we can substitute the hydrochlorothiazide to indapamide, either indapamide. If the patient is on indapamide, we can substitute that to chlorthalidone. So like that we can, next step, the step 2 is to change the thiazide like diuretic. Even with that, if the BP is not under control, then comes our step 3, that is the spironolactone. I can say this drug as a blockbuster. Why? Because there are hell a lot of evidence for the spironolactone, usage of spironolactone in reducing the blood pressure in resistant hypertensives. So first line therapy, so AC, ARBs and the long-acting calcium channel blocker, the maximum dose or optimal dose we can utilize with the thiazide, thiazide like diuretic should be included for the management. And fourth is our agent like that spironolactone. So I'm going to discuss, there are a lot of trials with the spironolactone as an agent for as the fourth line of medication for this resistant hypertension. But I'm going to discuss about only the major 3 trials, which is first is the aspirin trial. This is released in the International Journal of Hypertension. So in this trial, ambulatory blood pressure monitoring was done and also the clinic BP was monitored. So this trial shows that after addition of the spironolactone, the ambulatory blood pressure monitoring nighttime systolic and the day, 24-hour systolic and the office systolic BP was significantly reduced by the spironolactone. Whereas the diastolic values are not significant. So the spironolactone is an important effective drug in lowering the systolic BP in patients with a resistant arterial hypertension. And important of this aspirin trial is the first vigorous RCT trial which made use of a low dose spironolactone is very effective, proven that spironolactone is very effective in lowering the systolic blood pressure. And based on this, we can say that it is a fourth line agent in guideline recommended step-wise management for the resistant hypertension. Next is the landmark study. This is a Pathway 2 trial. Very important trial, very interesting trial. So here I can say before going to this trial, the evidence before the study is that whomever the researchers who are going to undergo this trial, they actually searched about the medications for the resistant hypertension. So they searched the Medline, Embase and many databases, and that all meta-analysis suggested that spironolactone can be an effective BP lowering agent for patients with resistant hypertension. However, the NICE review concluded that quality of evidence is not much up to the mark. That is, the quality of existing evidence was low. They wanted to prove that spironolactone is yet another effective antihypertensive. So what they did is that they have compared they have not only compared the spironolactone with the placebo, they have compared the spironolactone with 2 other medications. One is the alpha blocker, doxazosin, another is the beta blocker, bisoprolol. So this is no previous RCT as compared the spironolactone with other with the other lower, blood BP lowering medications. So making the spironolactone is very effective. So I'll tell you. See, this is the BP, which is the resistant blood pressure of the first, and that green colored bar is the systolic and diastolic BP of the resistant hypertensive. So after with the placebo treatment, the blood pressure has reduced, but it is not up to the mark. Once you compare with the doxazosin or the bisoprolol, both the systolic and the diastolic BP in the spironolactone arm, there is a much drastic reduction in the blood pressure. So making the spironolactone as one of the effective molecule in reducing the BP in resistant hypertensives. And the added value of this study is that in this trial, almost all the patients, they have checked the baseline renin levels, plasma renin levels. So they found out that the plasma renin levels were low. So it has like the plasma renin levels has the inverse correlation with the blood pressure. That has been strongly emphasized by this study. Why? Because the patient already on AC or ARB, they are resistant hypertensives. So if the patient is on AC or or ARB, their plasma renin levels will be high. But here the plasma renin level is low. So saying that the patients have more sodium retention and sodium and water retention. So once we give the mineralocorticoid antagonist like spironolactone, it is very effective in reducing the sodium and water retention and thereby dropping the blood pressure and making the BP under control. So another study is the REHOT study. In this study, the spironolactone with the clonidine, they have compared the impact. So here the 24-hour systolic and diastolic BP reduction and the daytime diastolic. So this study is the only study which shows that diastolic BP is also reduced with the spironolactone compared to the clonidine. And even with this, even after starting the spironolactone, if the blood pressure is not getting a target, then our step 4 comes our alpha and the beta blockers. So we have to check the heart rate before adding the beta blockers. So the fifth line of, the choice of fifth drug depends upon the sympathetic drive. So we have to check the heart rate. If the heart rate is more than 70, we can add the beta blocker or a combined alpha or beta blocker. And the centrally acting alpha agonist, the clonidine patch or guanfacine can also be considered if there are some contraindications to the beta blocker. Clonidine in the tablet form, the oral clonidine is better to preclude, that is better to postpone or later, we can use it later. Why? Because there is frequent administration. It needs frequent administration and it carries the risk of rebound hypertension. And step 5, another drug is the hydrolysine. Hydrolysine we can use, it can be considered, but it is always wise to use with the nitrates. Why? Because it's an afterload reducer, it can reduce afterload. So we have to give a medicine which can reduce the preload also. And hydrolysine and minoxidil, both are the next line agents. For both these two drugs can increase the sympathetic tone and also increase the sodium avidity. So it is always wise to use these medications with a diuretic and a beta blocker to blunt these responses. And any other newer agents, there are certain trials, so including for the ARNI, the Paragon HF trial, but this trial is studied in the patients who are having the heart failure. So for heart failure who are having a resistant hypertension, instead of instead of ARBs, we can consider ARNIs, which has a significant reduction in the blood pressure. And again comes our major important trial, that is a credence trial in regards to the SGLT2 inhibitors. So it can reduce the blood pressure of 3.5 mm of Hg versus baseline. And newer agents are under studies. So next going to the device-based therapies. So here there are 3 therapies. One is the renal denervation therapy, which is very important. We are going to see certain trials on this and the publications, and carotid baroreceptor stimulation and creation of AV fistula for resistant hypertension. So renal denervation therapy, what is this? So this therapy works by interrupting the renal sympathetic nerves that can contribute to the elevated blood pressure in patients with the resistant hypertension. So these are the 3 modalities how they are going to blunt the renal nerves. So either through the radio frequency ablation or through the ultrasound or by drug delivery, they can blunt the sympathetic nerves. So how it is going to effective? So see, the efferent sympathetic nerves from the renal arteries, they can increase the renin secretion from the JJ apparatus, and it can increase the sodium reabsorption. It can cause renal vasoconstriction. So once the patient undergoes the renal denervation, there will be reduced renin secretion, reduced sodium retention and the volume overload, and reduced renal vascular resistance. So, and the afferent sympathetic nerves, they send the feedback signal to the brain to the central sympathetic centers. So by cutting this loop, the sympathetic outflow, the central sympathetic outflow decreases, thereby the blood pressure also reduces. These are the timeline studies. So main studies are 3 important landmark studies are simplicity trials, which is 1, 2 and 3. All 3 trials are released, and the important trial is the radiant hypertension trial and the SIRAL trial. So this is a summary of all the trials. So once you see the simplicity, spiral or the radiance trial, see the blue bars given are the patients who have underwent the renal denervation therapy, and the reduction in the blood pressure is given as a lower. It is like the bars are down. Why? Because it shows the reduction in the blood pressure. And the nearby red bar shows this people who have underwent the sham procedure. What is a sham procedure? Since the patient, see there in these studies, the patients are divided into 2 arms, one with the test and with the control. The control arm, the test arms, the patient are undergoing the renal denervation therapy. For the control also, the researchers, what they did is that they have sent the patient to the procedure room. They have inserted the catheter into the renal artery, but they didn't ablate the sympathetic nerves. So that is called as a sham procedure. That is a dummy procedure. So once you see this, compared to the sham, see the blue bars are all lower. Why? Because it is like there is a drastic reduction in the blood pressure. So after the renal denervation therapy. So key observations are the greatest BP reduction is seen in the early open label trials, and office blood pressure also reduces by 8 to 12 mm of Hg, and ambulatory blood pressure by 6 to 10 mm of Hg. And I'll tell you about this radiance trial. So the most important trial I'm going to discuss now is the simplicity trial. See, this is a simplicity 1 and 2 trial is compared with the simplicity 3 trial. So the simplicity 1 and 2 shows that after the RDN there is a drastic reduction in the blood pressure, whereas simplicity 3 is a negative trial. So why it is a negative trial? See, and there is no much drastic reduction in the blood pressure after the renal denervation therapy. Based on this, the 2017 ACE-AHA hypertension guidelines, they do not recommend the device therapy for the treatment of resistant hypertension. There is a chaos here. Why? Because we can't say whenever a trial is showing a negative result, the procedure is not working well. Why? Because they found out that there are some operative inefficacy, like they have used the early catheter, they have used the older devices, and centers wherever this trial is performed, they doesn't have the much knowledge about this renal denervation. They are very new to that, and the patient selective characters are not good. So they found out that the simplicity 3 is not, the reports of simplicity 3 were not acknowledged after this radiance or the spiral trial, because that showed a hell a lot of evidence, for robust evidence saying that renal denervation therapy of course has a very important role in reducing the blood pressure in the resistant hypertensive people. So, and this is the denerve hypertension trial. So it is an open label randomized control trial. Here the renal denervation along with the medications decrease the ambulatory blood pressure ABPM compared to the medicines alone. This is also a very important trial which is done in 1,500 people. So, and these are the steps to identify the potential candidates for the renal denervation. So all the resistant hypertensive candidates are eligible, and they should undergo, they should willing to undergo the lifestyle modification, and decision making should be discussed with the patient regarding the risk and benefit of the procedure. And contraindications are pregnancy, so fibromuscular dysplasia, and any stented any renal artery, renovascular complications, and the patient having any single kidney. These procedures is deferred. So next we are going to the carotid baroreceptor stimulation. So recently I watched a movie called 11 in Prime actually. Here the psychopath used to kill the people with a device. He used to go near to them. He used to have a rod like some probe like thing which gives the electric stimulus, and he used to keep that in the neck. Maybe it is because of the baroreceptor activation. So the baroreceptor activation BAT involves the electrical stimulation of the baroreceptors located in the carotid sinus using a device which is similar to a pacemaker. So the baroreceptor stimulation, it sends the signals to the nucleus tractus solitarius in brain, and automatically it inhibits the sympathetic nervous system and enhances the parasympathetic activity. Thereby it reduces the heart rate, increases the vasodilatation, and reduces the stiffness of vessel wall, and in kidneys it can increase the natriuresis, and it reduces the renin secretion. This is the mechanism by which the baroreceptor activation will reduce, and the clinical trials like Rio's pivotal trial, Barostim Neo trial, and the spiral trial are ongoing to prove that baroreceptor activation therapy is yet another therapy to reduce the blood pressure in resistant hypertensives. So the indication is that resistant hypertension, intolerance to antihypertensives, the patient with sympathetic overactivity, they can be ideally selected for BAT therapy, and it can also be used in the heart failure with reduced ejection fraction. So the limitations are surgical implantation risk. So the operator efficacy is very important, and the device related complication like infection, anything lead dislodgement, that also to be considered, and the high cost also a drawback. In summary, it is a promising adjuvant therapy for the patients with true resistant hypertension, especially when there is overactivation of when the neurogenic mechanisms are predominant. Next is the creation of AV fistula. So where we are going to create the AV fistula, it is the ROX arteriovenous coupler. It's a stent-like ininitol device. So it is like fixed, it forms a conduit between the external iliac artery and the external iliac vein. So AV anastomosis form, thereby reducing the blood pressure. So ROX control trial, this trial they have carried out for 6 months. It showed that both ambulatory and the office blood pressure were significantly lowered in the coupler group, that is who used the AV coupler compared to the control group. You are still awake? Yes, you are more tougher. Then thank you so much for the opportunity. Happy to take over the questions for discussion.
Thank you, ma'am, for the lucid presentation on resistant hypertension. You have shown various scenarios and how to find out what is resistant hypertension, what's the role of diuretics, spironolactone, clonidine in the treatment of resistant hypertension, surgical management like renal denervation therapy and carotid receptor stimulation therapy. So to the audience, any question from the audience?
Not really a question, I'm just wondering how the...
Sir, they have...
Yeah, okay. I mean, the sham group,
Yes,
they're
sir.
doing an invasive procedure and they aren't doing anything to the patient.
Yes,
Is it
sir.
ethically correct and how did they get the ethical clearance? Any mention of that in those studies?
Sir, they have said that they are getting, I mean, before, they have explained to the patient that either the procedure can be done or cannot be done to you. That is how they have, what they have said is that to not to, reduce the bias, they have taken everyone through the procedure. Only the investigator can know that whether they have underwent RDN or the sham. But the ethical clearance, they would have explained everything. So they have not, there is no special mention about this sham procedure regarding the ethical clearance, sir.
Okay, thank you.
Ma'am, in your practice, like you're saying, like use of ABPM, what are the, like, for all resistant hypertension, you use ABPM, or is there any selected patients you use ABPM?
Sir, that we have to rule out this, that white coat hypertension, sir, before that. So if we are, if you say, if the person is having persistent elevated blood pressure while we check in the clinic, if they deny, because nowadays we are encouraging self-monitoring of blood pressure and self-monitoring of blood sugar levels, sir. So almost all the patients who are having some metabolic syndrome, so we used to say that always to purchase electronic blood pressure apparatus or the, this CBG machine also, glucometer also, so they are checking the values. I used to insist the patient like they used to check like twice or thrice in a day. That too for 3 consecutive days. If the blood pressure is persistently normal and once they come into my cabin, the blood pressure is high, we can diagnose as white coat hypertension. For other things, yes, ambulatory blood pressure monitoring it has a vital role, sir. And I am encouraging for that also, because patients are also asking, they also doesn't want to simply escalate the medicines once their blood pressure is not under control. So they are willing for the ABPMs.
And role of Findrenone in resistant hypertension, ma'am?
So that's what the ongoing trials are there. It is similar to the spironolactone. So it is like a mineralocorticoid antagonist. Here there will be lesser hyperkalemia and the renal dysfunction. So that is under trials, sir. But the well-known agent, the spironolactone, just proved, and it is like approved in the guideline also as a 4th line agent for the resistant hypertension.
Any more questions? If there's no more question, I think we'll close the session. Thank you so much, ma'am.
Thank you, sir.
Thank you, ma'am. I request the speaker to come onto the stage. Dr. Manoj Kumar. I request Dr. Namachivayam sir to hand over the memento to Manoj Kumar sir. Ma. I request Jayasudha ma'am to collect a memento from Namachivayam sir. I request Manoj Kumar sir to give the memento to Namachivayam sir. Thank you, sir. Next session is mixed basket. I request Dr. Dharmarajan sir from Trichy and Dr. A. Marimuthu sir from Chennai to chair the session. First topic, I request Dr. G. Loganathan sir from Chennai to speak on fulminant hepatic failure.
Thank you.
Welcome. I request excellent speaker, Lord Dr. Loganathan, is Best Doctor Award from APA Tamil Nadu, and also received Excellence Award from various specialty in IMA Salem, and formerly professors of Tamil Nadu MGR Medical University, and also Apollo Health Educations. Then he published a lot of papers. Yes, thanks. Welcome, sir.
So good evening to all of you, and with great respect to chairpersons, and my thanks to the organizing committee who really burned their midnight oil to conduct this conference. Appreciate them for calling me and doing a wonderful thing here. I was just wondering, is this topic relevant to all of us? I think it's 100% relevant because from the days, at least 2 decades earlier, we considered a disease, the fulminant hepatic failure, carried around near 100% mortality in our situation. While I was a PG registrar in CMC, we were able to survive 2 patients in whom we made a diagnosis of fulminant hepatic failure. And we told our professor that this is fulminant hepatic failure and these 2 people are alive. Our teacher said, what are the chronic liver disease? So the concept is that when you make a diagnosis of fulminant hepatic failure, the survival is not there, at least in this part of the country. If not outside India, that can be a different story. 2005 or 6, I got a written consent from a patient who I diagnosed to have fulminant hepatic failure, stating that the mortality is going to be 100%, and he survived actually after treatment. So this becomes extremely relevant now because the understanding of fulminant hepatic failure, the causative mechanisms, treatment goals, and how to really do this management, all these things are better known now. I am only highlighting the principles. We know this, for any liver disease always have a protein manifestations. They are not just limited to liver alone because it's one of the major metabolic organ. The symptoms are very, very protein, and it's quite rare, 10 out of 1 million, characterized by hepatic dysfunction or LFT derangement, marked by coagulopathy and encephalopathy. Encephalopathy is an essential component to the diagnosis of fulminant hepatic failure. And the Western literature says a decade before it carried a 50% mortality. As I said, 2 decades earlier, we thought it carries a 100% mortality. Now there is an improved survival with a better understanding of the natural course of the disease and the benefits of intervention, intensive care availability, and the availability of transplantation too. I think we know the various causes are there. Now we understand that there are some etiology-directed treatment in fulminant hepatic failure. So in a patient with a diagnosis of fulminant hepatic failure, it's mandatory that you work towards the etiology also, so that the etiology-directed treatment can be directly beneficial to the patient. And we know viruses, drugs, and even hypoxia cause hepatocellular injury, and there are many other host of things. So to come to the main point actually, the initial care of fulminant hepatic failure includes adequate hydration,
use of N-acetylcysteine, whatever be the cause, adequate control of infection, and to adopt very high standards of care in intensive unit. Preemptive antibiotics are indicated in patients whom you think that they are likely to get into worse forms of encephalopathy, and when you consider that progression of disease is more likely to happen. Endotracheal intubation generally helps general care, and you have a control on airway, and you can have a control on oxygen delivery. You also have a control on carbon dioxide levels, which will help. I'll tell you why. It also prevents aspiration and pneumonitis. So number one, we said hypotension. Most of these patients at admission, they generally have hypotension, and it is associated, if they have a hypotension, it is associated also with severe encephalopathy, and it carries an adverse prognosis, carries an increased mortality. Why it happens? Subsequently, what it leads to? It leads to functional immunosuppression and nosocomial sepsis, which is often seen in this subset of population. So overt bleed is usually uncommon despite a coagulopathy, because there is a balance achieved between the procoagulants and the liver-derived anticoagulants. So despite having a very bad PT-INR, many of these patients diagnosed to have pulmonary hepatic failure do not overtly bleed. Now, do we need to treat that abnormality? Component replacement will be necessary only if there is a bleeding, otherwise it's not required. And second thing is, if you are planning some invasive procedures, failing which better not to, because it also impairs the prognostication. So what all we need to assess? We need to assess the severity, how rapidly the disease progresses, and how quickly the other extrahepatic organs are getting involved. And let us try to understand the cause of the liver injury also. I repeat again for the third time, etiology-directed treatment is possible in around significant number of patients with pulmonary hepatic failure. So you have various etiology, hepatitis B, HSV, CME, autoimmune, BCS, and amanita-phylloids, malignancy, acetaminophen, and other drug-induced liver injuries also, where withdrawal can result in a good recovery. So hypotension or hypovolemic shock is a consequence of poor oral intake, vomiting, and vasodilatation. Poor oral intake and vomiting constitute prodromal symptom of any patient who presents with acute hepatitis, and is normally seen in 50% of the patients who present with acute hepatitis. We need to assess the myocardial function also, and the principle is to look for circulatory volume and restore it. The restoration of circulatory volume results in increased systemic perfusion and adequate oxygen delivery to the vital organs. How do we achieve that? Usually by volume replacement. It's usually crystalloids and very less likely colloids. Vasopressors, if it's fluids, it's not going to help you, then we need to use vasopressors. No hesitation, noradrenaline and vasopressin analogs are commonly used. The next important thing, we talked about circulatory function and hypotension. Now we are going to the respiratory dysfunction. Usually it is not very common in the early phase, but happens in the later phase due to liver degeneration and infection. Now, how many of us will agree to go for an early intubation? Early intubation in patients with pulmonary hepatic failure is to be done in a patient who you believe that the disease is likely to go bad and in severe grades of encephalopathy. The goals of respiratory care are almost similar to any other patient with a critical illness. Controlled hyperventilation. This is why the carbon dioxide levels are important. Controlled hyperventilation to induce hypocapnia is used for an emergent control of intracranial hypertension with cerebral hyperemia. This is extremely important, but this is not something new. This is very, very old actually. But the only thing is, like what I'm going to say now is new. You should avoid sustained hyperventilation. That's important. Avoid spontaneous hyperventilation by using appropriate sedation and mandatory modes of ventilation. As we understand, encephalopathy will be the sheet anchor or central to the diagnosis of our definition of acute liver failure or pulmonary hepatic failure. and the time to encephalopathy has a prognostic value. Kindly understand, if a patient has a low-grade encephalopathy when his presentation was subacute, and in a high-grade encephalopathy in a hyperacute presentation, both of these patients carry a very worse prognosis. Goals of clinical strategy is to, as much as possible, to prevent onset of severe encephalopathy, limits its severity, and reduce the risk of cerebral edema. Cerebral edema and ICH are going to be the determinant in these patients. Intracranial hypertension, as I told you, is the most feared and the deadly complication, and it is the leading cause of death in pulmonary hepatic failure. Many patients with pulmonary hepatic failure do not have intracranial hypertension significantly, and rate of survival in patients with ICH is always better with transplantation over medical management. The neurological status that happens in encephalopathy is in reality poorly understood or partly understood. However, there is an inflammation infection cascade which results in release of local and systemic neurotoxins, including ammonia and its products. And one of the product is glutamine, which has a significant effect on the neurons. Second one is arterial ammonia is a very good prognostic marker. Concordance between the arterial ammonia levels exists between with the intracranial hypertension also, and even with the renal flow. Sustained arterial ammonia levels of more than 150 to 200 is associated with the development of hepatic encephalopathy and intracerebral hypertension. Why, unlike in chronic liver disease, why in pulmonary hepatic failure you have a very severe, severely elevated ammonia? Because this amount of production of ammonia is much in excess of compensatory mechanisms. Hence, in FHF, ICH features are predominant, unlike CLD. Yeah, I think this is something the computation for the ICU people, but I think I'm not going to enlarge on this slide actually. But you have a criteria, and there is a correlation between GCS and the modified Westhaven criteria, which we use normally in patients with hepatic encephalopathy. So, is there a need for monitoring intracranial hypertension? Invasive monitoring, I think, has been tried in these patients, but it is fraught with more complications, and it's used in evolving intracranial hypertension, befitting clinical signs of intracranial hypertension, high risk patients who are likely to develop ICH. And who are those patients? Arterial ammonia greater than 200, age less than 35, and concurrent renal or cardiac failure. However, the use of monitors, invasive monitors, even in advanced centers, have been almost withdrawn or reduced much because of the associated severe complications. The protocol for monitoring managing intracranial hypertension used to use IV hypertonic saline bolus. I think the dose we will not say. Mannitol is another one that can be used. And in resistant cases, hypothermia to around 32 to 34 degree or IV indomethacin have been used. But however, various studies also say that room temperature management is far better, and since 34 to 36 is far better rather than going in for hypothermia, because that is also fraught with more complications. So hypoglycemia is an essential component of pulmonary hepatic failure, because liver is the organ which is involved in carbohydrate metabolism and metabolism of Krebs cycle. So it cannot synthesize, or gluconeogenesis is impaired, so it cannot synthesize required proteins, required glucose, and they can throw hypoglycemic seizures. So these patients are at increased risk. Use hypertonic glucose solution for correction, or even before the hypoglycemia episodes happen. Avoid large volumes to prevent hyponatremia, which obviously increases the swelling of the brain. As much as possible, preserve muscle bulk and immune functions. I think most of us, we do not give high protein because of the fear of high levels of ammonia, which is likely to occur. If you can monitor ammonia levels, you can optimize the dose of proteins to be given. But the recommendation is 1 to 1.5 gram per kg of protein per day. Renal dysfunction again is extremely important. More than 50% of patients with acute liver failure, they do have renal dysfunction. Higher at risk are people who are old aged and commonly seen in acetophen-induced acute liver failure. So let us understand that although renal dysfunction is associated with increased mortality, the resolution of liver failure is often accompanied by a return to pre-existing levels in most cases. I think that's a basic understanding of hepatorenal syndrome and chronic liver disease also. You can have a diseased liver, but the kidney is functionally affected, not structurally affected. Here again, there is a change that has happened now. Early continuous renal replacement is better than intermittent forms of renal replacement. This helps to achieve greater metabolic and hemodynamic stability. So we said early intubation is better. We said prophylactic glucose is better. We said ammonia levels are good to monitor. We also now say that early renal continuous replacement is better than intermittent forms of replacement and a more critical situation. It also helps to control hyperammonemia and other biochemical acid-base disturbances. So we have gone through epidemiology, definition, causes, pathophysiology, and care of heart and lung, brain, kidneys, nutrition and metabolism. And to treat etiology, there are 2-3 things, plex and transplantation. I think you have a huge list. I think we'll be already, I'm about time. I will, with permission, I'll take some more time. So I think there are a lot of things that has come in. The common management issue, this again summary of whatever you have already discussed. I will not go through the list again. There is a huge crosstalk in these patients who have fulminant hepatic failure. We have already seen the various organs are involved. See, lungs are involved, metabolism is involved, hypothermia is beneficial, GI nutrition is essential, cardiovascular maintenance is extremely important. And coagulopathy, though need not be corrected, it is important to monitor that again. Volume management is essential to survival. CRRT, early CRRT is extremely important. It has a positive beneficial effect. Infection control is mandatory in all these patients. N-acetylcysteine, though it was initially used in paracetamol poisoning, now it is widely used in any etiology, independent of the outcome. Outcome is generally good with N-acetylcysteine. So what are the etiology-directed treatment? Plex is something new that has come, plasma exchange. Transplantation will be the ultimate lifesaver. So for each and everything, in hepatitis B, you can use nucleoside analogs, which probably can downstage or result in improvement, but RCT says no. The positive beneficial effect on etiology-directed treatment is only with acetaminophen right now. But now we are having evidence in yellow phosphorus, plasma exchange can be increasingly useful. And again, penicillin G in amanita fluids is something that we can try out actually. So I think CMC has done a lot of trials on this plex, and they are expanding the indications for use of plasma exchange. They have found that it certainly improves the survival, and it is also recommended by American Society as a standalone or a combined modality. Hypothesis is that it reverses the hepatic congestion and thereby improves the microcirculation, reduces inflammation, restoring liver function. I think they have been, even in postpartum acute liver failure, they have been able to produce positive results, and more so in rodenticide, it has been through ISG, they have been able to prevail upon the government, and the training has been given to all the district headquarters hospital for adopting this plex in patients with ratol poisoning. So I think these criteria, I think I'll skip. Transplantation, I think we know, but more number of transplantations are happening now compared to 20 years earlier, where the positivity was only around 35 to 40%. Now the survival has gone up to 80 to 85% across India. So to understand, liver transplantation is still the main line of management. Plex is successful in specific conditions. Etiology-directed treatment is successful in select situations. Kindly prevent, identify early, and treat to success. Team management is the only key to a fruitful survival of the patient. As I said earlier, it's a multi-organ crosstalk is considerable here, so you need to balance everything. Because this is like dengue. You have a infection, and it is a time-based event that is happening over a period of 14 days. In fulminant hepatic failure also, the result is either all or none. All is 100% survival. They live completely without any residual disease. And if they die, it is 100%. There is nothing like a residue of a recovery from fulminant hepatic failure. I think these are the situations where we need to give all our effort to make them survive. So to put it in a single slide, many causes, many organs, multi-organ crosstalk, few treatment options, many survivors now, a promising future. And thank you all.
Thank you, sir, for the excellent, wonderful lectures. So what is the role of bromocriptine? Any role of bromocriptine in the treatment of acute?
Bromocriptine?
Yes.
I think my review of literature doesn't say much on that, sir. I will have to learn from you.
Yeah, trial and so many studies are, they said this is trial for bromocriptine can be useful.
I think the review of current literature and recommendations from various international bodies do not mention about it, sir.
Okay. Thank you, sir, for a nice elaborate speech about various causes, clinical features and treatment, etc. Actually, we are receiving lot of acute fulminant liver failure from Tiruvannamalai, Kallakuri district to our MMC. We are doing lot of flux therapy, sir. For patients, we are spending around 50,000 per patients. We are saving lot of farmers from Kallakuri, Tiruvannamalai district. Actually, they are having machines, but they are not doing. But we are doing lot of services to the poor patients. Actually, we should do at Tiruvannamalai and Kallakuri level. Actually, government given mission, everything, but they are not, still now they are not started. So better to start early, save the patients, particularly rat color paste therapy. And transplant, how much you are doing, sir, how much you are saving the patients? Any idea, sir?
No, I think from my own personal experience, I will say in 2004, I transferred my first patient to SAW in Gangaram Hospital in New Delhi. They were there for nearly around 6 to 9 months to get the liver, and they successfully is still alive. 23 years or so, he is still alive. When I was in CMC in 1998, we did one, and that person is also still alive. But over a period of 2 decades, we had a big number of emerging liver surgeons in the years of 35 to 40, and all of them have now the experience of around 15 years. So even Dr. Rela could not produce a wonderful survival in the initial days. In fact, we moved from Global then to another hospital in Mumbai, and then subsequently, after settling down in Global, he was able to produce some amount of good results. The results at the best centers are close to 85%. Now they are not taking up DDT, deceased liver donors. Now they are going in more for a live liver transplantation, a live donor liver transplantation. That's what they're doing. Survival closer to 85%. To be very honest with you.
Okay, sir. Thank you, sir.
But the problem is, kindly understand that the percentages may be useful for doctors, but for the individual, it's all or none phenomena. Either he dies or he lives. It's like this. If a person after transplant lives for 24 hours, his possibility of living for 1 week is at 95%. If he lives for 1 week, then his possibility of living alive up to 1 month is again 95%. If he lives for 1 month, then his probability of living for another 5 years, 1 year, it is around 95%. That important difference is, unlike renal transplant, immunosuppression in the initial phase is really equivalent to the amount of immunosuppression that we give in renal, or even lesser than that. Over a period of time, they are on a single immunosuppression. So they are nearly not exposed to such an amount of infection-related events as compared to renal transplantation. Survival is better, actually.
Sir, what about, sir, you told glutamine? Are you using, sir, how it is role?
See, the problem with glutamine is like, this is available. Medically, this pharmacologically, it's available as sachet. In a liver patient, we need to be extremely careful in giving glutamine. I am a strong believer in glutamine because I think as an MD student, I attended one meeting in the current global hospital, which was earlier by different name. So that time we had some US person, an extremely good person. He conducted a meeting on nutrition. So glutamine is the only thing everyone talked, because that's the only nutrition for the enterocytes. But unfortunately, like we saw, glutamine will result in increased ammonia production. So that will lead to encephalopathy. So glutamine in encephalopathy is not good. If you are giving a glutamine containing powder or a nutrient, you need to be extremely careful whether they will develop into, watch for it actually. Within 2 days you will see them going into deeper coma.
Thank you, sir. Thank you, sir. Any question from floor auditorium?
More you ask, more I will say.
Thank you, sir.
Sure.
Thank you, sir.
Thank you very much.
Next
Thank you,
speaker.
chairpersons. Thank you, organizers.
Thank you, sir. Next speaker. Sir, Dr. Ravichandran. Yes, Dr. Ravichandran from Kallakurchi. Yes, next, sir. Yeah, next. Huh? Sorry. Okay.
Game changes in number
Okay. Dr. Rakesh Saheba. Yes, next speaker, Dr. Rakesh Saheb is from Hyderabad, other state speaker. Almost look like a mini Tapicon. Game changers in endocrinology. Dr. Rakesh Kumar Sage is Professor of Endocrinology at Ostmedia Medical College since 2009 and is also Medical Superintendent since 2024 onwards. He is President, South Asian Federation of Endocrine Society and is also President, Diabetes in Pregnancy Study Group of India. He is also President, RSSDA. He is also President, Endocrine Society of India.
Thank you, sir.
It is also
I think
section editor of endocrinology book, then associate editor for IJDDCC, then governing body member of Association of Physicians of India since 2010 onwards.
Thank you, sir.
Thank you, sir. Continue to speak, sir.
So, at the outset, I would like to thank the organizers, our chairpersons for the kind words of introduction, the organizers for inviting me to be here, particularly Dr. Pallinappan. And the topic he has given me is game changers in endocrine practice today. So I think if you look at the endocrine practice today, we would say that we are facing a huge burden of diabetes and many other endocrine disorders like thyroid problem, thyroid nodules, and these are some of the things that I will try to address in my talk. And we have seen a lot of change which is happening because of novel medications that are available today for management of diabetes. Particularly, I'll briefly touch upon the GLP-1 analogs and the SGLT2 inhibitors, which have actually revolutionized the management of diabetes, because they are not only helping in management of diabetes, but of the hyperglycemia, but also providing organ protection, that is cardiovascular protection and renal protection. So this has made a lot of difference. And then there is emphasis on technology now, and we are speaking of targeted therapy. So I'll briefly touch on these areas. So if you look at the therapies, incretin effect we know is decrease in people with diabetes, and so we have the incretin based therapies, of which the GLP-1 analogs are the ones which are very important. They increase the levels of GLP-1 in the body. GLP-1 is important for increasing the insulin, the glucose dependent insulin secretion. Apart from that, it has several other effects, like on the brain it reduces satiety, that's why it helps in weight reduction, and through also other mechanisms, and also it has an effect on the cardiovascular system also. So the GLP-1s have evolved over the period of time, and then we have several GLP-1 analogs available now. Today, mainly being the liraglutide is available, semaglutide is available, and tirzepatide. These are the three ones which I'll briefly speak upon. So if you look at the GLP-1 analogs, they bring about a significant reduction in the HbA1c levels. So if you see all across the board, you'll see more than 1% reduction, average more than 1% reduction. So that's a very good reduction. Most of the other medicines work to about 0.5 to 0.6% or something in that range. So this is a very effective therapy, and which does it without any weight gain and without causing any hypoglycemia. So those are the two advantages of these of the blood glucose reduction that is happening with the GLP-1 analogs. And then they have other metabolic benefits in terms of BP reduction, also slight reduction in BP and reduction in body weight. So in addition to that, these were the major limiting factor was that they were all injectable molecules. Now we have an oral GLP-1 analog, that is the semaglutide, which has been developed by adding adding a molecule that prevents its degradation in the stomach, and it improves its absorption in the stomach. So that makes it orally available, although the bioavailability is very less, 1% only. So you need to use it once a day as against semaglutide, which is injectable is once a week. So this oral semaglutide has also been found to be very effective as compared to all the comparators. It works very well in terms of reducing the HbA1c, doing it and also reducing the weight. So these are the two major benefits. And if you look at the defects, major defects in diabetes, the GLP-1 analogs address 6 out of the 8 defects. So therefore they are very useful drugs. And beyond glycemic control also, they have beneficial effects on the liver, the brain, the heart, and even the liver. They have been shown to reduce the fatty liver, and that's this is probably one of the therapies which have been shown to provide a histological benefit. In some of the recent trials, they have shown histological benefit in terms of reduction of fibrosis also. The fibrosis score came down by 1 degree reduction from F4 to F3. Reduction of the fibrosis score was seen with that. In addition to that, they have all the cardiovascular benefits, where you have the cardiovascular outcome trials, CVOT trials, LEADER trial, the SUSTAIN 6 trial have shown benefit of the use of liraglutide, semaglutide, and then you have other trials also. But the major trials which I wanted to highlight is these two trials. And so therefore, what has happened is that guidelines have also changed now, saying that if you want to decide on which therapy to use, first look at the presence of or absence of cardiovascular disease, look for renal disease, and if they are there, then you choose these molecules, the GLP-1 analogs and the or the SGLT2 inhibitors, as is shown here. This is a 2023 one, but 2025 also we speak of similar triaging patients based on the presence or absence of cardiovascular disease and liver and renal disease. So let me just tell you that in addition to that, we have this tirzepatide, which is a twin cretin, which is a GLP-1 and a GIP analog. So earlier GIP was not considered to be very important, but now we have benefits seen with GIP and agonism also. And you have these twin cretins, which is again once a week injectable preparation, which is recently introduced into our market, and which shows a very good reduction in HbA1c, as you can see here, as compared to all the other molecules also. You see that as compared to semaglutide, it works even better than semaglutide in terms of reduction in HbA1c, which is, as you can see, on the average 2%. We are speaking of more than 1% with the GLP-1 analogs. With this dual analog, it is more than 2% reduction in HbA1c, and more than 90% of people are achieving the target of less than 7% HbA1c. So which is again a very remarkable achievement. And when you look at the weight and those who are reaching less than 5.7%, these are people who are considered to be having remission of diabetes. So you can see that almost 50% of people were achieving that target also. And when you look at weight reduction, you see that the weight reduction on the average was about 12 to 20 kgs weight reduction with this molecule. And if you look at the number of people achieving less than 5% weight loss, more than 80% people achieving that. 15% weight loss, which is considered to be very good, very significant, and causes reversal of diabetes also, you can say, that also was seen in about 30 to 40%. So again, a very useful molecule. So having looked at that, let me now quickly speak a little about the SGLT2 inhibitors. They also are useful molecules which have shown to have benefit. Apart from glycemic reduction, they bring about reduction in weight. They have cardiorenal benefits, and they have been shown to be beneficial even in non-diabetics in terms of reduction of in improving heart failure and also CKD. So they work mainly by increasing, by decreasing the glucose reabsorption in the proximal tubule, and that leads to increased glycosuria, and that leads to slight reduction in the plasma volume, reducing the blood pressure, and also causing a tubulo-glomerular feedback, which produces the renal benefits. Now, when you look at data from either of these studies, you have empagliflozin, dapagliflozin, and canagliflozin, of which EMPA and DAPA are the commonly used ones now. And if you look at their benefits in terms of glycemic reduction, again you see a good reduction in the HbA1c levels, and they have other, because they produce the weight reduction, they reduce body fat and increase the uricosuriya and the diuresis they cause. All that leads to benefits in terms of the cardiovascular and renal outcomes. And you can see data from the various CVOT trials have shown that these molecules are beneficial in terms of reducing the cardiovascular outcomes, and also the renal outcomes have been shown in the various renal trials. And this is the EMPAREG trial, which was the first trial in 2015, which came out with all these benefits. And then you have benefits of this in terms of heart failure reduction, and also improvement in the preventing the fall in the GFR in people with CKD. So I think these are two game changers in the field of diabetes in terms of management of diabetes. And then looking at other aspects of diabetes, one is that technology has been used for, this is an insulin pump. Pumps have been available for a long time, but now we are seeing, if this is a pump which has got a closed loop pump, which is a closed loop pump, means it is attached to a sensor, a continuous glucose monitoring is done, and then using a fuzzy logic system, it is regulating the insulin delivery also. So you have got a sensor, you have got and then that sensor is connected with the pump in terms of providing data on the glucose levels, and based on the inputs from the pump, the infusion rate is adjusted, and that so that's called the advanced closed loop system. And the users can actually set the target glucose levels with options of 100, 110 or 120, and then they can also set up the desired level that they want. And you find that people are getting time in range of more than 70-80% are seen in many of the patients. So this is something which has again changed the management, particularly of type 1 diabetes. Now, thyroid nodules are very common. Thyroid nodules are seen in maybe 40-50% of people have some thyroid nodules, and they are very incidentally detected, and only 5% of them may actually be malignant or may need to be operated. But the vast majority, you have to pick up these 5% from the large number who don't require any surgery. So ultrasonography is turned out to be a very useful tool, and then you have the scoring done by ultrasonography, and then the FNAC with the bedside staging. But in all this, what happens is there's some of them which are very low scores. They certainly you are confident you don't have to do anything. Then you have those which are other extreme, you operate them. But the in-between ones, what to do is always a dilemma, and almost 20-30% of these remain in that in-between zone. So that indeterminate nodules, what has to be done to reduce unnecessary surgeries? Several different tests have come up. Those are called the use of various genetic testing, BRAF and other mutation testing has been done. They have not become very popular in our country. They are popular in other Western world, but in our country those have not become popular. But one study from our own country which has made a difference, and which is probably going to be a game changer earlier in the coming years, is looking at the plasma cell-free DNA and identifying which are the ones which are malignant, which are the ones which are benign nodules. And what they did was that in this group from IPGMR, they looked at plasma cell-free concentration of 67.9 as a cutoff between benign and thyroid malignant nodules. And this is an easy test, which can be done with a little bit of training and and low resource requirement, and they can be applied to indeterminate nodules, particularly in the stage 3 and 4, but SIDA stage 3 and 4, where the diagnosis is difficult, and they can help in predicting malignancy and also monitoring the response to treatment. And they can also predict the presence of mutations, also driver mutations, and can have a significant impact on patient care. So that is one other aspect that is going to be a game changer. Then another thing that is happening is that use of targeted therapies is becoming very common, particularly because of the identification of these mutations. So you can use therapies which are specifically addressing these mutations. You have got, so that is leading to what is called as precision endocrine oncology. So you have different agents which are available. The RET NTKR signaling pathways is the one which generally have these oncogenes, and we have selective molecules which are addressing these. The ones listed out here, I will not go into details of this, the tyrosine kinase inhibitors and all the other molecules which are regulating transcription and can have a significant targeted effect on these cancers. So that is improving the outcome of these cancers, endocrine cancers. Then another common thing that we see is hot flushes. So hot flushes are because of at menopause, because of drop in estrogen levels, because of which what happens is that there is a stimulatory effect on kisspeptin and NKB neurons with a reduction of dynorphin inhibitory activity, and this leads to a overstimulation of the KNDY neurons, increasing the activity of the thermoregulatory center, which makes it hypersensitive to all the peripheral sensors, causing these hot flushes. So periodic hot flushes which happen in menopausal women is a significantly distressing symptom. So earlier the only therapy that we had, a good therapy, was estrogens, and because the estrogens have a significant impact on, have a risk of various problems like thromboembolic phenomena or certain cancers which are increased. So we are looking for non-hormonal alternatives, and this molecule fezolinetant has come out as a good NK3R antagonist which blocks this pathway and leads to improvement in the symptoms. So this is the first neurokinin 3 receptor antagonist which is available for these vasomotor symptoms. It is being studied and lot of good data in terms of the symptomatic improvement, but we still need to have data on what is their effect on bone, what is the effect on cardiovascular status, mental status, and sexual health of these women. So this is something which is again going to be a game changer in terms of management of menopausal symptoms. Osteoporosis, again a very common problem. We have now several new agents available. We have agents which improve the bone formation, particularly rozosumab or even PTH analogs, and abaloperitide also is important molecules that are available, and they are going to be again used not only as single agents but in sequence also. So initial use of teriparatide followed by using denosumab to prevent its loss of the bone, or using bisphosphonates to prevent bone loss, is something which has come up as an important change in the management of osteoporosis. That is again a game changer in the management of osteoporosis. And then we have the precision endocrinology, particularly for MODY gene testing. So I will not go into details because I have completed the time. So this is a woman who was a 22-year-old woman who started on insulin, but because she had these 3 generations of diabetes, autosomal dominant pattern of inheritance, she was tested. Genetic testing was done, because when you do a MODY calculator, put it in the MODY calculator, you get a higher score, and she went for a test. Similarly, this 4-month-old baby who was otherwise managed with insulin was again underwent a genetic testing, and what we found is that in both of them we found that they had these genes which were typically in the genes for MODY, and these are people who respond to sulfonylurea. So both of these patients responded to sulfonylurea. They could be off insulin and could be managed. So this is how genetic testing made a difference. So I think there are many therapies and testing, and all these are becoming game changers for endocrine practice. So endocrinology is rapidly evolving towards precision and integration. Therapies are being targeted towards weight reduction, metabolic benefits, and comorbidities. The future is going to be tech-driven, multidisciplinary, and patient-centric care. Thank you. With that, I'll conclude. I'll be happy to take any questions.
So thank you, sir, for our nice elaborated speech. Sir, are you using GLP-1 semaglutide?
Yes.
Because it is cost-wise highly economically costly. How much it is effective for cost?
Yeah, so the major problem, a major limiting factor today is the cost of these therapies. But I think we have generic liraglutide, which has made the cost very affordable to most patients. It is available at almost 1,500 to 3,000 rupees a month. So that makes it very useful. And semaglutide also has gone off patent. And within another 6 months to 1 year, we are going to see many Indian manufacturers making semaglutide. So that's how the cost is going to be brought down. But certainly these molecules have benefits. And but when you look at even at the present cost, if you look at the long-term benefits that they get in terms of weight reduction and from the early use, the benefit that they get in terms of preventing complications, provides the cost benefit.
What about, sir, physolinonant for postmenopausal flush? Physolinonant, you are using, sir? Physolinonant. Yes. Physolinonant for postmenopausal flush.
That one, yes, sir. That is not yet available. So I would say that that is something which is likely to become a very useful molecule when it is available, but it's not yet available in our country at least. It is introduced in some of the countries, it is not available, but now here it's not yet available.
Okay, thank you, sir. Any questions from floor audience? Okay, thank you, sir. We can close. Next speaker, Dr. V. Ravichandran from Kallakurichi. Current scenario in OH therapy in type 2 diabetes mellitus. Current scenario of OH therapy. Sir, directly put CV. CV. Actually, sir is very dynamic persons. All of you know, 6 months back, sir conducted nice mid-Tapicon at Kallakurichi. All of you know, it is a very small place, our state central place, very remote place. From the place is conducted very nicely. At that time, I was one of the speaker about the recent advance in ILD. The program was very successful that time period. Now, I request, sir, please start your speech, sir. Thank you, sir.
Thanks, sir. Respected chairpersons, my seniors, my friends and colleagues and students, good evening to everyone. I hope everyone's insulin, GLP-1 acted very well, and your glucagon already has started. Before your patients wearing very thin, I would complete very quickly. But one unfortunate thing, my talk is not on the list today, and my previous speaker, his talk also is not on the list today. Unfortunately, both talks have some homology. So I thought I would discuss some of the basic mechanisms, what happens in some people who are destined to develop diabetes mellitus, what are the biochemical derangements, and how we can proceed with those people. As we all know, diabetes mellitus, particularly type 1, type 2, both, it's a hyperglycemic state, fasting more than 126, postprandial more than 180, and at any point of time, the blood sugar, random blood sugar more than 200, and HbA1c more than 6.5. What is the big deal? Of course, glucose is fuel. If we have more glucose, we are getting energy. What is the big deal in it? So again, we all know that a persistent hyperglycemia through glycation end products, through polyol pathway, through inflammation, it damages vascular endothelium. Hereby it damages all the organs supplied by the blood vessels, particularly microvascular complications, macrovascular complications, neuropathy. In diabetes mellitus, the worrisome complications, nephropathy, atherosclerotic cardiovascular disease, and that ongoing insulin resistance damages the important organs, particularly fatty liver. This all will produce long-term complications. Once you develop diabetes mellitus, your life is at risk. So, what are all the, if we look back, the historical perspective, the diabetes mellitus was early recognized in 1500 years before Christ, that BCE. But till 1920, the diabetes mellitus was a fatal disease. Only in 1920s, 22, I think that insulin was recognized and segregated from human's body. After that, the diabetes was considered as a monohormonal disorder till 1950, when that glucagon was recognized. After that, it was considered as bihormonal. The glucagon raises blood sugar and the insulin reduces blood sugar. In 1970s, the gliptins, the role of gliptins were recognized that when we ingest both that terminal ileum and the duodenum, they releases GLP-1 and GIP. In turn, they releases insulin from the pancreatic cells. And that amylin was again discovered in 1987. It was secreted along with insulin by beta cells. So till that recent, that multi-hormonal interplay, the diabetes is considered as a multi-hormonal that interplay. So in some people who are destined to develop diabetes mellitus, type 2 diabetes mellitus, that initial that biochemical abnormality, the derangement is in the form of insulin resistance, that muscles and liver are resistant to the actions of insulin. So that overnight insulin resistant will produce fasting hyperglycemia throughout the night, that hepatic glucose production is more, but that by the time that beta cells are healthy, they secrete more insulin to compensate that insulin resistance. But as time advances, again that beta cells, they fail to secrete enough insulin. So it causes postprandial hyperglycemia as well. Soon after ingestion of our meal, along with insulin resistance, along with decreased insulin, that hyperglycemia, postprandial hyperglycemia ensues. So till recently, the cause for type 2 diabetes mellitus was considered as traditional triad: insulin resistance by liver, insulin resistance by muscles, and beta cell, progressive beta cell failure. But in 2009, Dr. D. Frons, he proposed some of the biochemical mechanisms. They also contribute to the hyperglycemia. So what are they? So apart from these three, that comes that incretins. The incretins, already are told that after our food ingestion, that our gut produces GLP-1, GIP, which in turn releases insulin from the pancreatic cells. That effect is blunt in the people with pre-diabetes or diabetes mellitus, type 2 diabetes mellitus. And that particularly GLP-1 not only releases insulin but also suppresses glucagon. this effect is also blunt. Paradoxically, that glucagon is over-secreted in diabetes mellitus, type 2 diabetes mellitus, after our food intake. That further worsens hyperglycemia, postprandial hyperglycemia. And one more mechanism, as to overcome that insulin resistance, our beta cells overact and they secrete more insulin that produces more lipogenesis in the adipose tissue. It in turn, that is still that adipose tissue, lipolytic effect, lipogenesis, anti-lipolytic effect, these are all not clearly understood, but somehow that lipogenesis, that adipose deposition, fat accumulation, triglyceride accumulations in the both fat cells, both hepatocytes, they contribute more insulin resistance, that more inflammation, that produces more damage to all the organs. Then glucose conservation, this concept. So normal person, normal healthy adult, they excrete excess glucose when the blood glucose crosses more than 180. But the SGLT2 receptors present in the proximal tubule, they absorb, they excreted, they reabsorb the excreted sugar in the urine, so conserving that glucose and maintaining the hyperglycemia. This threshold 180 milligram per deciliter is elevated in type 2 diabetes mellitus to more than 300. So this is another important mechanism. So increased glucagon. This glucagon over secretion is often under-recognized in diabetes mellitus. This abnormality also leads to hyperglycemia in type 2 diabetes mellitus. The neurotransmitter. After our eating, we should have satiety. Our hunger should be abolished. These neurotransmitters, serotonin, dopamine, and other forms of neurotransmitters, they help in achieving satiety, thereby reducing further calorie intake. These abnormalities together, this derangement together, they cause hyperglycemia in type 2 diabetes mellitus. This together, Dr. D. Franz called it as a ominous octet, but the list does not end here. Further list, another 4, gut microbiome, chronic inflammation as happening in adipose tissue, mitochondrial dysfunction in all the cells, and oxidative stress again, that leads to progressive beta cell death. These all contribute hyperglycemia. Together they are called now dirty dozen. So now coming to the oral anti-hypoglycemic agents. We all know we have 5 or 6 weapons in our hand. How to tackle, how to start, when to start. When the HbA1c is more than 7, we can start, particularly in type 2 diabetes mellitus. First, I want to clear one thing. For the first time the patient comes to us, if the patient is in catabolic state, or if the patient has symptomatic hyperglycemia, the drug of choice, treatment of choice is insulin. Only when the patient has asymptomatic, comes in the pre-diabetic state or some asymptomatic hyperglycemia, the patient is detected in the routine investigation screening, then what are all the possibilities, what is the latest algorithm? Earlier that, of course, that first abnormality, the primary abnormality lies in the insulin resistance. So what are the weapons we have to tackle this insulin resistance? 2 drugs, they address insulin resistance. One is biguanides, another one is thiazolidinediones, that is pioglitazone. These 2 drugs, they address insulin resistance. We can start either one of these. Preferably metformin, it is well documented, well reported and well studied. for longer period of time since 1950s. So metformin is a wonderful drug. It acts at multiple levels. So we can start with either metformin or pioglitazone. Earlier algorithm, we will add sulfonylureas. Add-on therapy, we will add sulfonylureas because of the advent of newer drugs like GLP-1 analogs, SGLT2 inhibitors. Particularly, the sir told that multiple levels, that GLP-1 analogs acts at multiple level. So we can go further with that, with the drugs. The next add-on therapy, we can add either GLP-1 analogs or SGLT2 inhibitors, either this or that. Particularly when we have high risk status for cardiovascular, history of any cardiovascular events in the families, or the patient is above 60 years, or the patient has associated hypertension. So we can start with a GLP-1 analog. Oral, we have oral GLP-1 analog, that semaglutide. Usually that my topic is OHA, so semaglutide is now available orally. So we can start GLP-1 or SGLT2 inhibitor, particularly if you have preserved ejection fraction failure or reduced ejection fraction failure, cardiac failure. So we can start SGLT2 inhibitors. SGLT2 inhibitors, they act at the proximal tubules. They cut short the absorption of glucose, leading to renal glycosuria. Along with the renal glycosuria, it causes natriuresis, sodium output in the urine. So it reduces BP, it reduces tension inside the vessel walls, increasing that survival rate, reducing that hospital admission rate in cardiac failure patients, SGLT2 inhibitors. Either you can start GLP-1 or SGLT2 inhibitors depending upon the comorbid conditions. Third, one sir talked about that endogenous GLP-1 elevation. So alpha glucosidase inhibitors, we can use alpha glucosidase inhibitors. This alpha glucosidase inhibitors, it does stop that cleavage of disaccharide to monosaccharide. In that way, that disaccharide is excreted in the stool because carbohydrate is absorbed in the form of glucose only, in the monosaccharides. Here, the conversion of disaccharide to monosaccharide is blocked. The disaccharide is excreted in the stool. Indirectly, it activates, the disaccharide activates GLP-1 secretion also. That another one important drugs like DPP-4 inhibitors, dipeptidyl peptidase inhibitor, that normal endogenous GLP-1 hormones are very short-lived. They are cleaved by DPP-4 enzymes, which are available in the vascular endothelium, particularly that portal circulation and all the cells. What happens? This GLP-1, naive GLP-1 is cleaved by DPP-4. By giving drugs, some gliptins, we have gliptins in our hand. By giving gliptins, we can stop this breakage of GLP-1, increasing that naturally available GLP-1 to stimulate insulin. Nowadays, that apart from teneligliptin, we have one more gliptin, algogliptin, that produces some heart failure, and terligliptin is recently available. We can take terligliptin once in a week. Once in a week drug you can take. Other things you have to take daily. And GLP-1 agonists are told that multiple actions, it acts at various levels, because that we have ominous act at 8 phases almost, except that renal site, it acts in all the sites. GLP-1 acts in all sites, including that neurotransmitter, that it increases satiety, it reduces hunger. Only complication, it produces some stomach fullness, and pancreatitis rarely. So really that algorithm management I have told. Earlier, before this advent of SGLT2 inhibitor, GLP-1, the add-on therapy, we would add sulfonylureas. Now, everyone is scared of sulfonylureas because why? Because that it induces more insulin leading to hyperinsulinemia. It, as normal insulin, it promotes lipogenesis. In turn, it worsens insulin resistance. And one more thing that with the secretion of more insulin from pancreas, amyloid secretion also increased, which leads to amyloid deposition in between the pancreatic cells, leading to pancreatic failure very soon. So now that current strategy is wherever possible, wherever the patient is affordable, you can start as add-on therapy along with metformin, SGLT2 inhibitors or GLP-1 analog. Then DPP-4 inhibitors should not be combined. That you keep it in mind. GLP-1 analog and DPP-4 inhibitors should not be combined, as there is no additive synergetic effect, because that GLP-1 analog we are giving is not affected by DPP-4, the enzyme present in the body. So DPP-4 inhibitors will not add any additional benefit to that. And nowadays, and a lot of doctors are talking about triple therapy. So triple therapy is more effective. What is the triple therapy? Metformin. Metformin addresses that insulin resistance, and other thing that pioglitazone. Pioglitazone addresses again that insulin resistance, particularly that adipose tissues and hepatic glucose output. And third thing, that exenatide or some other this, now we can use that oral semaglutide. It addresses all the sites. So together they do wonders in the management of diabetes mellitus without the use of sulfonylureas. And I think I should stop now because your patience is wearing out. Thank you very much for your wonderful patience. Thank you.
Thank you, sir, for your elaborate history of treatment of diabetes from insulin and OH very nicely, sir.
15 minutes is very...
Thank you, sir. Okay. And the pathogenesis of diabetes and drugs like insulin sensitors and secretors and DPP-4 inhibitors, etc. Sir, are you using about pioglitazone?
Yeah.
Pioglitazone is using.
I use a lot.
Okay.
I use a lot.
Like, have you experienced any side effect because you stopped a few years back because of bladder cancer? That is why I'm asking.
Sir,
Depending on the dose only, sir.
Yeah.
Less than 15 milligram is okay. More than 15 milligrams.
You start with 7.5 milligrams, sir. Then you stop with 15. Not you don't go beyond 15. That will add. That one more thing, that weight gain, even 15 milligrams, that weight gain is mostly subcutaneous fat. That visceral fat is getting reduced with the help of pioglitazone. That is one more advantage with the pioglitazone.
Thank you, sir.
Thank you, sir.
Any questions from audience?
Thank you, sir. Monogenic diabetes mellitus. And one more thing, that in Modi, that sulfonylurea is the drug of choice.
Okay, thank you, sir. Thank you. I think we can close the sessions. Thank you. Where is organizer?
May I request the chairperson to kindly present a memento to Dr. G. Loganandan. We now request the chairperson to facilitate Dr. Rakesh. Shahe. We also request the chairperson to kindly present a memento to Dr. Ravi Chandran. We kindly request to felicitate our chairperson. Let's now proceed to the next session.
Shanmugam sir and Shivakumar sir. Dr. Shivakumar sir and Shanmugam sir has chairperson.
I invite Dr. K. Shanmugam sir to chair this session.
We invite the first speaker for this session, Dr. Bijan Oliver John, to speak on healthy aging, a boon to elderly.
Okay, very good evening to one and all. So, I was supposed to be the last man batting today, last play, but due to team interest, I have been promoted up. Hope I do justice to the situation. So now, my talk is healthy aging, boon to elderly. It's just a general topic. So with a lot of interesting case scenarios about patients. Yeah. Okay, so after 2 days of your experience in CMC, or the past 2 days with a lot of academic feast and all, hope, can you guess who this is? Only less PGs are there. Idaskar, of course, you would have seen the Idaskar statue also. But this Idaskar who was very young, but now, the photo next, the same very Idaskar many years later. So that's how the aging is. It is a process. So now, so definition of health, you all know the WHO definition of health, no, it's a complete state of physical, mental, social well-being, and not merely an absence of disease or infirmity. So, like, it's also multi-dimensional, involving all these dimensions. The only if the person is healthy in all these dimensions, it has to be healthy. So now, there's something called as wellness. So, what is wellness? The WHO defines wellness as the optimal state of health of individuals and groups, and wellness is expressed as a positive approach to living. So, health is a goal, whereas wellness is the active process of achieving it. These are some of the 8 dimensions of wellness. So, either you can be well or you can be ill. So, both are opposite directions. So, it's how we go about it. I mean, the government of India has brought a lot of this Aishman and wellness, Aishman Bharat, health and wellness centers. Actually, many poor people in the primary centers are benefited. Now, coming to the concept of longevity. So, of late, in the last few years, now people are living longer. So, this is from an article which says that people can live up to 150 years if there is no stresses at all. That's it, actually, how we are designed. We have been designed to live longer, but because of a lot of other stressors in many forms, our life is cut short. So, we can divide like elderly or as a young, old, and oldest old, from 60 years onwards. Whereas in India, we consider above 60 years elderly, whereas in Western, we say above 65. Then, the scenario, as it says, no, the elderly people are increasing. So probably if you continues the present state, it will be around 417 million 2050, and it's 1.6 million less developed countries. So people are living longer and it's just increasing. So, and if you see this age in India also, no, so probably the last data was 132 million above 60 years, whereas likely to probably double or even triple in the next 30 years, 2050. That's how fast it is. So, what is our main goal? So, people in front of us know the age group is humongous, and how we are going to tackle it. So, our goal is like add life to years and not years to life. So, this WHO started this decade of healthy aging. That's 2021 to 20. This 10 years called a decade of healthy aging, and we even observed this. This was in 2020 in our hospital. So, from Vellore Medical College, we observed this. So, now coming to the topic proper. So, I told about health, and we all know about aging. Okay, it's inevitable. But what is healthy aging? It's also a WHO definition. It says that process of developing and maintaining the functional ability that enables well-being in older age group. So, the main key factor is the functional ability. And what is this functional ability? The health-related attributes that enable people to be and to do what they have reason to value. It is mainly made up of the intrinsic capacity and the environmental characteristics. So, the functional abilities depend on the intrinsic capacity. Now, what is the intrinsic capacity? It is a composite of all the physical and mental capacities of an individual. How you are inbuilt, what is happening within you, that determines your ability. And the well-being refers to the happiness, satisfaction, and fulfillment. Now, what are the domains of functional ability? These 5 important domains, as the WHO states, like you should be able to meet basic needs, able to learn, grow, and make decisions, decision making. Third, being mobile. So, immobility is a dreaded factor. As we say, like immobility, instability, incontinence, inanition, all are dreaded. They call it geriatric giants or geriatric syndromes. So, as you are mobile, you are fine. Once your mobility is restricted, then automatically the decline starts. Next, you should be able to build and maintain relationships, and finally, you should be able to contribute something to the society. That's very, very important. Am I useful? Just I am above 60 doesn't mean that I am nothing, I am useless. No. Even after 60, you can able to contribute a lot to the younger generation, to your grandchildren, a lot. So, you have a lot of role to play. But there's something called these risk factors. If they come, then automatically cause the decline in your functional status. So, definitely elderly, this multi-morbidity is a very important factor. So, all this hypertension, diabetes, MI, then cancer, visual impairment, stroke, all these factors, so all can cause a decline in your functional ability. So, as I mentioned earlier, functional ability is the most key factor for healthy aging. But once all these conditions start, slowly the decline starts and the functionality decreases. So, now, as I said, these are the functional healthy aging. Okay. So, sorry. Okay. So now I told about the intrinsic capacity and the functional ability. These are three important graphs. So one is that blue thing, no, it is an optimal trajectory where it remains high. The intrinsic capacity remains high till the end of life. That's very good. Then another thing is the red thing, no, it has a declining trajectory, the rapid decline and steadily until death. So this is declining. So either it will decline or it will be stay high. But there is a state that's interrupted trajectory which states that event causes a decrease in capacity with some recovery. It just oscillates. So we should try to somehow maintain in the, even if probably affected by a lot of issues, try to maintain your intrinsic capacity. So this is how that as the age advances, no, the graph showing about the functionality intrinsic capacity. Now this is a public health framework for healthy aging. So depending upon your, either if you have high capacity or the declining capacity or the intermediate capacity, you have to take appropriate measures. Suppose if you find your intrinsic capacity is high, then you have to make sure that it's a preventive aspect. So if it is a declining, then it should be a tertiary. So it will be more advanced care. Depending upon your intrinsic capacity ability, the framework or health approach by the physician changes. So as I told, no, the elderly always present atypically. They cause mortality, morbidity. Then they are not present like younger people. They just progress more rapidly. And a lot of financial, health and social sequelae, lack of physiological reserve, which we term as resilience. So resilience starts diminishing. So that somewhat causes a lot of comorbidities. And just a word about geriatric syndromes. I told, no, frailty, delirium, dementia, depression, falls, sleep disorders, pressure ulcers. So my next speaker will be discussing about that, how we are going to assess them. But these syndromes, you should have it in mind. So all the diseases are common in elderly as occurring in a younger age group as a physician. But as a geriatrician, you should have an idea about these syndromes so that the quality of life can be somewhat better. So this is in our ward actually. This patient is a 80-year-old person. We just did a test, something called as a tuck test, timed up and go test. That also we'll discuss later. But just how he did no comorbidities, 83 I think. So just, so I'm not able to play the video. Okay, sorry, that video that this person was to do within 10 seconds. The tuck test, the cutoff second is the patient was able to stand, walk for about 3 meters, come back and sit. So that's a normal, that's about 10 seconds in this patient. Whereas this patient had a COPD, but he couldn't do that. He took around 15 seconds. So as your comorbidity or illness starts, that's functionality. Tuck test is something done to assess your functional capacity. Probably so you can just see this. So I think it's around 14 seconds or something. So I'm just telling an example. So as your illness advances, your capacity decreases. So always approach is start low, go slow. Always don't start on medicines. Of course, we have a talk later on medical management. So you should assess the patient as far as possible. Try for non-pharmacological methods before starting any medicines. So always prevention is better than cure. So like primary prevention was very, very important. The health promotion like health education, environmental modification, nutrition intervention, lifestyle behavior changes, and specific protection. So we have a diet pyramid, food guide pyramid, how we know like how the elder diet should be. More of fruits, vegetables, water, legumes, beans like that. So as far as try to avoid all the unwanted fats and etc. So this is the pyramid we have. The physical activity is very, very important. So like even in the CMC, we start this lifestyle medicine. So we have the 6 pillars, I think. Yeah. So diet, physical activity, stress management, then sleep, then also social communication. So there are 5 to 6 pillars they concentrate on. So that if you do that, automatically your general improves. So this one of a worker in a hospital around 70 plus. He used to ride cycle and also very active. So like he insisted on the diet and the physical activity. This we did in it was 5 years back. How he told about that, I just highlighted it during COVID. How physical activity and diet is very important. Unfortunately, we lost him some couple of years back. He fought COVID, but still ultimately he had to succumb to the COPD. So that's one thing. This example of a person who had to complete a marathon by running the Toronto Waterfront Marathon, Fauja Singh. So he's still alive. So that's motivating for us. Now coming to sleep hygiene, as I said, no, sleep is one of the important pillars in lifestyle. So very, very important. Avoid caffeine, alcohol, limit liquids in evening, because once the sleep gets affected, automatically the general gets affected. So avoid naps in the afternoon. Spend more time outdoors in early evening exercise. So sleep is very, very important, which we neglect. 8 hours of sleep is very important. This is a patient, 103 years old patient, who was admitted for just a gastritis. So she is also one example where no bystander, we are taking care of her. That's one example. And this another patient. This person is a 103-year-old farmer from Ranipet. So we came in the paper. So he was admitted for gangrene. So they were hesitant. The surgeons were hesitant to take on amputation. They got my opinion. So should we go, sir? What will happen? The anesthesia complications, surgery complications, like that. I told her, everyone have a right to live. You do, it's a high risk. So ultimately, they went forward. So the post-op, no complication was there. He was discharged, 103 years. And it's only because of the support of his sons and who did take care of him. So ultimately, we lost him last year. So he came to thank our administration team for all the things. And this is another patient, 90-year-old Sivagami patient who underwent a OGD scopy successfully. No cob, only for that anemia and scopy, and she was uneventful. So this patient is a 91-year-old patient admitted for hypoglycemia. His wife is on the right and daughter is on the left. So what I want to say is the family support is very important to take care of elderly people. If a good caregiver and family support, automatically people will live healthily. And this another patient, 91 years old, he's a photographer who used to do cycling. Just one day before he was cycling, I think he fell down, but still he is now fine. So I can give a lot of examples. So as I told you, the social activity is important in elderly patient, one of the pillar. So we have this celebration in our ward. This is during some Christmas week, our dean gave us gifts and all. So that's what to say, to improve there, that physical, mental, social, I told, no. All the dimensions of health has to be, this during Pongal, we're involving the patient and the attenders. This is like example of physiotherapy. Suppose patient not able to mobile, another issue can have to undergo physiotherapy. So to live is the rarest thing in the world. Most people just exist. So aging is not lost youth, but new stage of opportunity and strength. So I think this is the mantra I want to share today. So elderly have life to live, and they can live healthy depending upon our attitude towards them. So we need to add life to the years and not years to life. Thank you once again for this opportunity.
That was a wonderful speech by Dr. Bijin John. As like you said, aging should be with dignity, and the quality of life is important. And with the multimorbidities and age-related physiological changes, treating geriatric patients with any disease is a real challenge. Yes. And I'm really happy to see that the Tamil Nadu government has recognized this problem, and in all medical colleges there is this separate geriatric ward.
Yes, sir. Yes, sir.
I'm happy that you are doing a good work there. Thank you.
Thank you so much, sir.
Thank you, sir. An elaborate discussion on healthy aging. I invite the next speaker, Dr. Pranitha, to speak on comprehensive geriatric assessment in practice.
Good evening. Good evening to all the delegates who are present here, and thank you, the organizing committee of Tapicon, for having us here and talk on our geriatrics. So coming on to my topic, which is a comprehensive geriatric assessment, and we all knew, as the previous speaker has already discussed, how the Indian population is growing up, and we are seeing projections of older adults, and it is by the year 2050 we are going to see a huge rise, around 20% of our population being covered by the elderly. Looking at in our southern part of the country has more elderly as compared to the northern and the central India. And coming specifically to Tamil Nadu, we are constituting about 20% of the older adults in our population. So as we see, as the numbers are more, we are going to see more and more of these older adults in our day-to-day practice, in our outpatient as well as in the inpatients. So what is a comprehensive geriatric assessment? It is a multidimensional interdisciplinary assessment for evaluating the medical, psychological, physical function and socioeconomic problems to detect unidentified and potentially reversible problems and to develop a coordinated and integrated management plan for treatment and long-term care of an older adults. So it takes into account of the full holistic care of the older adults. The main goal of CGA is to identify the needs and the problems. It is main gold standard for managing the frailty, and also to evaluate the health status. As we all know, the complexity of the older adults because of the multiple comorbidities, polypharmacies, and multiple issues in them. So the strength of comprehensive geriatric assessment lies in it is a multidimensional assessment, and they take into consideration of the physical as well as the other domains in the older adults. Do we really need to do comprehensive geriatric in all the older adults? The answer is no, because it is because when the adults who are very well maintained, they are very independent for their activities of daily living, and all their comorbidities are very well maintained, we really don't need CGA for them. Or on the other hand, the patients who are very sick and they are getting palliative care treatment or end-of-life care treatment, those also we can skip as a CGA. The group of people who we want to who we want to capture in comprehensive geriatric assessment are the patients who are very frail. So as in the community, we are looking adults with a functional disability, frailty, increased falls risk, cognitive decline, or those as high risk of healthcare utilization. On the other hand, admitted patients with fragility fracture, failure to thrive, recurrent pneumonia, and pressure sore. So these are the people we would like to do CGA and assess which domain is involved and to plan a personalized care for them. The rationale behind the comprehensive geriatric assessment is early detection of the risk factors for a functional decline and linked to a specific intervention which help to reduce the incidence of functional disability and dependency in older adults. So going on to the domains of the CGA, the physical health, which is same as the standard of care for all the adults. We look at the physical health, there are multiple comorbidities in them. Along with the physical health, the other thing which we are looking is the functional independence, whether the person is independent for his activities of daily living or not, and what is causing the dependency of ADLs. We also look at the mental health, the cognition, as well as the depression or the involved in the older adults. The another important part which is taken care is the socio-economic status. We assess the family of the patient. As Dr. Bijan has already mentioned, the social circuit is very important in the elderly. Who is taking care of them? What family background they are coming from? What is their economic status? Who is the person when they are admitted in the hospital is going to take care? So all these things are assessed in comprehensive geriatric assessment. And last but not the least, is the patient is capable of to give his advance directive to know what matters most for the patient, for himself. It is a comprehensive test. So not one person, it is a difficult task for one person to assess. So the CGA is done as a group, as a team, and the physician and the geriatrician assess the physical and the mental health. There is a pharmacist who assesses the polypharmacy. The nurses provide the various personal care aspect to the patient. The important role of the physiotherapist and the occupational therapist is important to assess the gait, balance, and ADLs. The social worker assesses the social issues, and other parts, like if the patient having a speech swallowing difficulty, speech problem, then the role of a speech therapist comes in. The people who have a malnutrition, the role of dietitian comes into. So assessing each of this is very important. I am not going to very much depth in all this thing, because in day-to-day practice, what screening test we can do as apart from the standard of care for the older adults. So as a standard of care, history taking is very, very important, which is the same as we do for the other patients. The little bit slight difference what we make is we also take the screening for the geriatrics. We also take a screening history for a geriatric syndromes. A patient who needs CGA, who comes to our OPD, we would like to ask on history, how is his memory, is he depressed, or is there any lower urinary tract symptoms, is there a history of fall in past 6 months, how is the sleep, how is his vision, hearing, and has he lost any weight over the past 6 months, to assess for the malnutrition. So this part is slightly different for our, from our standard history taking, which we do in the younger adults. So another important thing is the assessment of the functional status, which is known as activities of daily living. We use Barthel index to assess the activities of daily living, and based on that we divide the patient with whether he is fully independent, partially dependent, or dependent for his activities of daily living. Going for ILDL, this can be just asked on a history, whether he is able to do shopping, making the telephone, managing the medication, using his mobile phone, or some household works. The third important thing is the gait and the balance. It is very important to assess that, because around 10 to 15% of the patient who fall, they develop a fragility fracture, which is associated with lot of morbidities. And many of them develop fear of falling, so they stop walking even if there is, they can walk, just because they have a fear of falling. So this is the easiest screening test, as Dr. Bijan has already showed us the video. I am not going to too much depth into this. This is a time get up and go test. When the patient in OPD, we just tell him get up from the chair, walk 3 meters and come back. And based on this, we can assess the risk of fall. This is when we know the patient is a risk of fall, the further test for the assessment of fall risk can be done. Cognitive evaluation is another thing which we assess in our OPD. So we have two things for assessing the cognitive assessment. The mini-cog comprises of a 3-word recall test and a clock drawing test. If we know that the person is falling behind in the mini-cog, there is an assessment point whether he is cognitively intact or not intact. If we know that there is some deficiency and cognition is impaired, the further confirmatory tests like mini-mental scoring, mini-mental status test, and further tests can be done to assess the cognition. The simplest question which we asked for a patient to depressed, which is a basic screening with a high sensitivity, is during the past month, have you been bothered by feeling down, depressed or hopeless? And during the past month, Have you been bothered by little interest or pleasure in doing things? If the patient answers such question, then the higher test like the geriatric depression score and all these things can be done to diagnose and treat appropriately. So once we gather all this information and we do screening test for these patients, once we know the physical status, the complex comorbidities, their functional, their mobility, medication, the comprehensive geriatric assessment help us to create a problem list for these patients and to give a personalized care and to intervene at a specific point. For example, not every older adults will have a similar problem. For example, some of them may be having only the mobility or the balance issue. Then the role of physiotherapist, occupational therapist come in to assess that problem. If some of them are having only the psychological problem, then the assessment of that can be done and the personalized plan can be generated. So the question is, does CGA really makes a difference to the patient? The answer is yes. There are multiple studies which are done in the older adults who are undergoing the standard care as well as the comprehensive geriatric assessment, and many of them have shown benefit in mortality as well as in morbidity. So these studies are done either in the community setup and some of them are in patients, mainly the patients who are admitted with the fragility fractures. There are few of the new applications which has come up in various societies, and comprehensive geriatric assessment is even applied to subspecialties. The two of the examples are the American Society of Clinical Oncology recommend geriatric assessment guided management in the treatment plan for all older adults receiving chemotherapy. The second is American College of Cardiology, which also recommends to assess frailty in patients who are undergoing cardiac surgery, especially the aortic valve surgeries. There is this new concept which is initiative in few of the American hospitals which is coming up new. This is the easiest way to look at the age-friendly health system. So they have this framework of 4 M's, and here the what matters most is the patient. What matters most to the patient? Some of the patients will ask for very they want very tight control of their blood pressures, they want very specific guidelines to be followed. However, another half of the patients will have only they want to be very comfortable. Even if they have at the end stage, they want to be comfortable. So that's the question, what matters? Medications, we are going anyway in the next session, we are going to hear about the medications, mentations, how is the cognition as well as if any depression, and the mobility. So summarizing, comprehensive geriatric assessment is a multidimensional and it is multidisciplinary. It established the goal-oriented management plan for frail older adults, and it improves patients' well-being and reduce hospital readmissions. So thank you very much. Thank you everyone for your patience hearing.
Comprehensive assessment is mandatory. It should be done during every visit. Very clear explanation on comprehensive assessment in geriatric care. Thank you, ma'am.
Thank you, sir.
I call next speaker, Dr. Gobinath sir, to speak on drug management in elderly.
Thank you. Thank you, sir. Thank you, sir, for the introduction. I thank the organizers, especially Dr. Satish, for asking me to do this talk. I think it's a very important talk, as more and more people that we see are older adults. So I think this is an important thing, that, and a lot of older people are on multiple drugs. I bring greetings from the Department of Geriatrics at CMC Vellore. Yeah. This is the next slide. Can I do it here? Oh. Right. So what I'm going to do in the next 20 minutes is not rocket science, just simple common sense principles that we all have to use in day-to-day practice. The problems in older people are many, and one of the main reasons why older people suffer due to medications is because they have multiple medical conditions. That's a given. That's an obvious. Very few older people lead a healthy life, but most often people have some medical issue that need to be sorted out, and in that reason they also need to be on medications. So this meta-analysis in 2021 showed us that polypharmacy is very prevalent. Almost 50%, 1 in 2 older adults is on more than 5 drugs. And hyperpolypharmacy, which is more than 10 drugs, is about 31%. So 1 in 3 patients is on more than 10 drugs, which is quite alarming. PIM is potentially inappropriate medications, was used in 28%. So it's almost 1 in 3 older adults that we see is on a medication that is potentially inappropriate to them. So they concluded that polypharmacy and hyperpolypharmacy are widely prevalent in India. Right. The other problems in older adults, the drugs that we use, one thing that has been categorically done in previous large trials is they have excluded older people from large trials, especially the very old, the frail, the 85s, the 90-year-olds. And that's one thing that skews the trial results. So we cannot take them verbatim. And there's a lot of use of herbal and complementary medications in India, and we know that there are hidden steroids, there's a lot of heavy metal, there's a lot of oral hypoglycemic agents. So there's another reason that leads to issues in older people when in terms of giving medications. And there are a lot of changes, age-related changes in the renal, the hepatic system. There's impaired neurocognitive function. There's increased body fat. This leads to increased levels of diazepam. So diazepam acts longer. There's reduced body water. So lipophilic drugs actually act longer, like lithium, for example, acts much longer than in a normal person. There's reduced renal function, either due to the aging process that I just mentioned or because of various diseases that they suffer. So this is just an example. You can see that the levels of diazepam in a younger person, it kind of declines quite fast, whereas in an older person, the levels decline quite sharp, then it stays on for almost 192 hours. And one of the active metabolites of diazepam is desmethyl-diazepam. The levels go up and then come down, whereas in older people, it stays elevated for a longer period of time. And there are a lot of drug interactions with herbal products. A lot of our older people are on ginkgo biloba. Yesterday I saw a gentleman who was on 2 various preparations of ginkgo biloba, one with zinc and one with another pyracetam, I think. So there are a lot of ginkgo bilobas. These are drug interactions that we have to worry about. St. John's wort is available in Amazon for 300 rupees. A lot of people use it for depression, wound care, so on and so forth. So all these herbal medications can interact with drugs that we give, especially warfarin and selective serotonin reuptake inhibitors. So what is the burden due to medications? 15% of older people get admitted in the hospital due to an adverse drug reaction. My friends, this is an alarming figure, and this is something that we see from day to day. It's not something that's come from Western countries. All of us, I'm sure all of you senior physicians, we all see this in our practice. Many emergency visits are due to drug-related complications. The more the medications, the higher the risk of drug-drug interactions, more less side effects, and likelihood of non-adherence. Right. So in the next maybe 10 minutes, I have only 10 minutes more to go. We'll quickly go through some of the principles that we have to use when we treat a patient. So the first principle is a complete drug history. I think I can't overemphasize the importance of taking a complete drug history. So these are the examples that we've had. So an older woman with sort of severe peripheral neuropathy, and she's been taking low-dose nitrofurantoin for many years. The urologist started it for prophylaxis, and she thought it's giving a good relief, so she kept continuing for years together, and then she came to us with neuropathy. There's a gentleman who was on elderly lady who was for treatment for Parkinson's disease. Actually, she's been receiving Stemetil. She's been taking Stemetil for many, many years. I saw this gentleman just last Tuesday, an older lawyer. He's been on Esogres L, and that is levosulpiride. And he's been on therapy also for Parkinsonism. So there is a side effect, and then there is a medication to treat the side effect. So I've seen at least 40-50 cases of levosulpiride-induced Parkinsonism. 74-year-old gentleman being evaluated for ILD. He's been on amiodarone for VT, and he's developed an ILD now. And drug history is extremely important from the past, the present, from the medication box is very, very important. So I always ask the patients to bring all the medications every time they visit me. The second principle is always maintain a problem list, maintain an allergy list is very, very important. So an elderly man who's admitted with a massive hematosis, admitted in the orthopedic ward, he's had a hip fracture surgery, they gave him aceclofenac for pain relief, and sure enough he had a massive duodenal bleed. And he has had duodenal ulcer 5 years prior to this. So this all happened recently. So always check for a possible side effect before you start a drug. So for example, you avoid non-selective beta blocker and asthma. We generally tend to avoid anticholinergic drugs when they have a higher post-void residue, because there is a risk of developing urinary retention. So always remember, can you try non-pharmacological measures in older adults? Avoid a pill for every ill. So constipation, try increasing fluid intake, increase fiber, increasing activity. Then you can, if unsuccessful, try osmotic laxatives like lactose. Never start older people on Dulcolax. Please, never start an older person on Dulcolax. Insomnia, very often we find that the reason for insomnia is actually because of the, where is it? The other way around. Yeah. Insomnia, very often what I find is people have pedal edema, they're on nifedipine, they're on pedal edema, and they think it's BPH, you start on alpha blockers. The simple thing that may just help is to stop the nifedipine or shift the nifedipine to the morning, and that will reduce the insomnia due to nocturia. So there are so many things, BPH, heart failure can cause insomnia. So you try to find the reason and don't just start them on benzodiazepines or other sleeping pills. Behavioral and psychological symptoms of dementia, we generally tend to avoid antipsychotics, try diversion therapies like music, game therapy and all that. Low backache, 50% of our patients tell me with physiotherapy, 50% of them are much better when they try physiotherapy for low backache. Acupuncture also is quite helpful. Is the patient's symptom due to drug side effect? I think I can't emphasize this again and again. I always think, is the patient's symptom due to a side effect? And this is the lady who's been on amlodipine, metformin. Doctor sees there is pedal edema, they start on Lasix, that causes hypernatremia. So this keeps going on and on. So it becomes a vicious cycle. I just saw this gentleman about 5-6 months back. He is a retired postmaster. He started on enalapril by cardiology, developed cough. Sure enough, he was referred to a pulmonologist. He was done, HRCT was done, spirometry, all happened in CMC. I just stopped the enalapril and everything is fine. So that's very important. This lady, the 65-year-old lady from North India, she came with cerebellar ataxia, and we acquired and found that she was on O2, which is a combination of ondansetron and ofloxacin, and we stopped it, and sure enough, she became better. So always, is that symptom due to a drug side effect? Always important to ask. So this leads us to the prescribing cascade. It's a common cause of polypharmacy in older people. Try not to treat a side effect of a drug with another drug, which is bad. Some of the common examples that we see in geriatric practice is a painkiller, NSAID, you start them, they develop hypertension, then they need antihypertensive therapy, amlodipine, edema, and furosemide, HC hydrochlorothiazide causes gout, painkiller, and then the blood pressure goes up. Pseudoephedrine for urinary retention, and then they need an alpha blocker. Treat the patient, not the results. A classic example of this is asymptomatic bacteriuria. Very often, and it's highly prevalent in older women, mainly diabetic women. There are significant colony counts with actually no symptoms. There's a very common practice outside, and even all of us, we treat older patients without definite symptom. They may just say, I have some urgency. We end up treating them with antibiotics. There's no indication to test if patients have pyuria without symptoms. So there's no role for routine culture. The only indication, 3 indications that we have to treat are pregnant women, which is not very common in older people, prior to urological procedures, and recent renal transplant patients. Start low, go slow, as Dr. Bijan rightly pointed out. We had a lady who started on TSH was 13, she was started on 50 micrograms of thyroxine. She came with atrial fibrillation dose with palpitation. So always start low, go slow, increase the dose gradually. Atenolol and amlodipine, as an example, have very long half-life, so it may take up to a week for the drug to kick, the full effect of the drug to kick in. So don't increase the doses in the second or third day. Is the patient taking the medication prescribed? You may give all fantastic drugs, semaglutide, liraglutide, finally the patient not going to take it. So this is a study that was done, and they found 51% of the time that the medication the patient is taking is not recorded on the doctor's chart. And on the contrary, 29% of the medication that was documented in the chart, the patient was not taking. So it's very, very important. The risk factors are many. There's age, there's number of medications. If you see multiple specialists, you see a nephrologist, see a cardiologist, neurologist, they keep adding medicines. And then this cognitive impairment again can lead to non-adherence. There's lack of understanding of how to take, there's inability to take, there's a genuine inability to take the medication due to dysphagia, so on and so forth. And there's a conscious non-adherence due to lack of fear of side effects, there's lack of understanding of benefit, and there's financial implications. Like semaglutide in CMC costs 319 rupees, which is beyond even me. So for everybody, I can't take it for years together. Semaglutide is beyond me. Again, I always follow the brown-bag technique. Patients will not get medicines unless they have shown me the medicines. I'm very clear about it. I'm very unpopular among them, but that doesn't matter to me. I always ask the patient to bring the medicines at every visit. It's called the brown-bag technique. I just recently had a lady who I thought the patient was on glimepiride, 1 mg. The HbA1c says 8.8, so it was around 60, 66. I asked the lady didn't come. The son came. So he brought the medicines, the glimepiride was not there, but he said, now I've kept it at home. Then I made the glimepiride 2 mg, and she came with hypoglycemia. So always remember, please check the drugs that they're on. Always try to get a family member to supervise the medications, especially if they have cognitive issues. These dosages are very cheap. It's available on Amazon. Any pharmacy shop will have this for 250 rupees. Watch for drug interactions. They have almost countless. Some common examples that we face is warfarin and antibiotics, antifungals. Ciprofloxacin and theophylline, I never give it together because we've had patients with seizures due to ciprofloxacin and theophylline. Antacids and cipro levels may go down. Aldactone is very risky, but we still give it. Yes, we do give it. And ATT and antiepileptics, we all know. The one thing that I dread the most is the triple whammy and the double whammy. I've had a couple of patients die because of this. So ACE inhibitors, NSAIDs and diuretics are a deadly combination. Due to all of us know why they are a deadly combination, so I'll skip this for the time being. We don't have time. And we always should try to tend to use drugs that have multiple indications. For example, BPH and hypertension, prazosin, beta blocker for IHD and hypertension. Migraine and seizures, I like to give topiramate or valproate rather than give phenytoin and propranolol or prothadin. So always think if the disease is settled, can you stop the drug? For example, depression, you can taper the drug. Peptic ulcer disease, patients are on pantoprazole for years together. Vertigo, people are on Vertin for years together. Asymptomatic TB inversion, somebody starts ecosprin. Should you continue that? Definitely not. I generally stop it. Triglyceride lower medications. Aspirin for primary prevention, there's a lot of controversy on that, but I generally don't give it. And withdraw drugs that can cause side effects. Use common sense while linking. Don't get carried away by pharmaceutical guys. I'm sure there are a lot of guys who are here. They are sponsoring our conference, but please use common sense. Many trials don't include older adults. So the relative risk reduction stays the same. The 50% risk reduction, whether the absolute risk reduction is 1% or 10%. So there's always something that we have to keep in mind. I think I'll skip this. Basically, what it says is one size doesn't fit all, and this works for diabetes and hypertension. So again, the SPRINT trial showed us that more intensive therapy is better than less intensive therapy. But again, more intensive causes confusion. The people come and say, I'm feeling very drowsy and sleepy. So again, you have to tailor it to the particular individual. We generally, as like guidelines say, use thiazides. Please don't use thiazides in older adults as first line unless it is mild hypertension. We generally try to use CCBs, then we go to ACRBs and then thiazides. Alpha blockers, centrally acting drugs, please never start it as first line. Beta blockers are never first line in older people. There's no doubt about it. Use NSAIDs and opioids with caution. So you can look at the deaths due to opioids in the US. So from around 5,000 has gone up to almost 30,000. This is due to medications and all other drug addiction. So it's dangerous. Again, the opioid pain reliever drug deaths have gone up. So this is a study that was done they published in NEJM. So basically what the study showed is celecoxib in carefully selected patients can be used for long-term pain relief. So we generally tend to use celecoxib if they have issues. So if they don't have heart failure, the blood pressures are okay, if they can avoid dehydration, if they can regularly monitor creat, I generally give it in patients who have severe osteoarthritis. One thing that we should remember in this slide is that if you're giving aspirin and other NSAIDs, make sure that you're giving at least 2 hours apart, because aspirin efficacy comes down if you're giving NSAIDs and aspirin together. Try to maintain the 2 pillars. So the 2 pillars are in geriatrics is bone health and mental health. So benzodiazepines, I avoid it like the plague. So it causes falls, sedation, cognitive impairment, dependence. So please avoid long-term benzodiazepines should always be avoided in older people. I think I've almost finished. So yeah, find the most cost-effective option. There are vitamins from 2 rupees right up to 9 rupees. So please use the vitamin that's the cheapest. Multivitamins produce very costly urine. So if you want your patients to have very costly urine, you please can go ahead and use multivitamins. And this is already documented in the Guardian also. And a lot of articles have said this also. One thing that we always do is we think giving treatment to older people is futile. So never do that. Don't under-prescribe when it's appropriate. For example, giving aspirin for secondary prevention of ischemic heart disease or stroke, statins, ACE inhibitors, go ahead. Please give it. If you think that will be useful, please go ahead and do it. Generally, the reasons for under-prescribing is physician hesitation. Already the patients are on medications. Should I give the medication? And patient factors. Ensure the current route. This is my last slide, sir. So this is always remember, especially this is for IP patients, when you have patients on Ryle's tube, don't give them Excel preparations, don't give them retard preparations. You have to change it to a plain preparation. And this is one thing that always leads to, you think the drug is not working, so then you add a new drug. So never do that. Change, when you're Ryle's tube, change it. The only exception for this is you're giving aspirin. If you're giving ecosprin, there's the only drug that I know that can be crushed. Atenolol and amiodarone also can be given in a Ryle's tube. If you want to give PPI for acid suppression, when a patient on the Ryle's tube, you should give them lansoprazole, and no other PPI is good when you're on a Ryle's tube. Right, this is the last slide. One thing that we always don't do is use subcutaneous route. I love this route because a lot of drugs actually can be given subcutaneously, and a lot of people, I'm sure, are doing home care. So if you want to give, IV fluids, for example, it's very difficult. You have to put an IV line. So subcutaneous fluids, you can give up to 50 mils per hour. So you can almost give 1,200 ml per day. You can give Lasix, you can give Perinom, haloperidol, hydrocortisone. There's only a few drugs that I've mentioned, but you can give any number of drugs through the subcutaneous route. It's very safe, it's easier to maintain, it's cost effective, less skill required by the nurse. Generally we use the chest and the abdomen to use it's called this hyperdermatochlorid, that's what we call it. And it's a commonly used method in palliative care, and home care, I'm sure it will be useful. So summary, consider every prescription as an experiment. The outcome is uncertain. So you have to individualize medications based on the patient's circumstances. Use basic principles of pharmacokinetics and dynamics, and use common sense as well. Drug reconciliation takes time. We're all very busy clinicians. It takes time, but it's extremely beneficial. Avoid a pill for every ill, and don't underutilize when it's essential. We can use drugs safely and effectively for older adults. Thank you, sir.
Wonderful speech by Professor Gopinath. So these patients have multimorbidities, and they see more than 2 or 3 specialists, and polypharmacy is very common in them, and also drug duplication is also common. We do come across patients with 2 or 3 antihypertensives written by the cardiologist as well as the diabetologist and all. And another question for you, sir. You told to avoid benzodiazepines, but inevitably most of the geriatric age group patients have insomnia. So what do you suggest for that?
Sir, one thing that we should do is try to find a cause for the insomnia. So very often what we find in clinical practice, I'm sure Dr. Pranitha and Bijan can also pitch in if they want, we find that people who have insomnia also have depression. The cause for the insomnia is the depression. So treating them with antidepressants, especially the sedative antidepressants like mirtazapine, trazodone, is actually beneficial. If it's just primary pure insomnia which is not due to depression, I generally tend to give them amitriptyline 5 mg, 10 mg. The one thing that also helps is melatonin 3 mg, 6 mg. But generally trials say that you should not give it for more than 1 or 2 months. But I have people on melatonin for years together. They sleep like a baby. I don't know why it happens. Maybe it's just a placebo effect. But amitriptyline low dose, trazodone also is very good. We generally tend to avoid the SSRIs because that they cause 50% of the time the SSRIs can cause more awakefulness rather than sedation. I think that has been recently come to think. I've used it for 2 patients, but both times I've been unsuccessful. Is lemborexant. They say it's very good, but it's 44 rupees per tablet, and it didn't work, and the patients were very upset. So I said, okay, I'm not giving it now. Stop on it. Yes, sir. But yeah, tryptomer 5 mg, 10 mg, it works like magic in a lot of people.
Sir, how to give fluids through subcutaneously?
Just a normal thing, sir. You just have to, it's generally we put it on sometimes we put it on the hand if you have kind of exhausted. So we put it on the chest, put a just needle under the subcutaneous fluid, you can connect the IV line. The only thing difference is through IV line you can give 80 mils per hour, about 85 mils per hour. Here we start with 30, then you can go up to 45 mils per hour maximum because the absorption rate is less when compared to an IV.
Okay, sir. Will it spread, sir?
No, it'll get into the tissues. It'll get into the tissues. Some of the drugs actually have a pure subcutaneous preparation, so these drugs cannot be given as a subcutaneous route because they cause irritation. But many of the drugs that I mentioned, so haloperidol, I've given many times. I've given subcutaneous. I've given Perinom also. I've given metoclopramide also. I've given subcutaneous. And IV fluids can be just given subcutaneously, but the rate of infusion has to be slower than a normal IV infusion.
Thank you, sir. Individualized care is always better. Thank you, sir, for the wonderful discussion on drug management in elderly. Thank you, sir.
Thank you, sir. About 45 mils, sir. Some literature says up to 60 and all that. I think it's better to stop with 42 to 45 mils is what we give. So that works out about 1 liter per day. The use of subcutaneous, I have used it a lot in palliative care, but older people at home, it's very difficult to maintain IV line, risk of infections with IV line, thrombophlebitis. Subcutaneous can work actually very well, but you just have to do the 40 to 45 mils per hour should suffice. No, sir, in the chest. No, it isn't. It isn't. Contrary to what we think, it is actually not painful. IV lines are more painful. So there's a lot of data. Actually, in India we don't use it that commonly, but in other countries like in Australia, for example, the subcutaneous route is quite often used. And I've given a lot of haloperidol. I've given it in syringe drivers. Put it in the thing, and just give it as a 20 milligrams in a day, haloperidol and metoclopramide, mainly for palliative care So I'm not saying subcutaneous route will substitute intravenous, but that's something that we can all use. We should be more trained in it. So I think that's something that we should be following. Yes, correct. Absolutely right. So some of the drugs that I mentioned there, like hydrocortisone, Perinom, haloperidol, Lasix can be given subcutaneously. You can't give Kcil, for example. You can't give potassium chloride subcutaneously because it'll irritate the skin. But many drugs, not a lot of drugs, a few drugs, definitely fluids can be given. There's no doubt about it. So at home, if you have an older person, if you want to give them basic 1 liter per day, just as a supplementation, please consider subcutaneous. It's a cannula. So there's a special cannula that comes. It's not it's like we used to call it the butterfly, no, sir, the butterfly thing. So generally we can chest, abdomen, or the back. Sometimes we give the thighs and the hands also. There's a lot of subcutaneous tissue in the chest and the abdomen. So there's a lot of thing for the fluid to seep in and then get absorbed. So chest and abdomen are the preferred sites. I think we should be using subcutaneous more, and we should be teaching our postgraduates and nurses also. Some of our nurses are very good in the department, but I think there's...
Practice, the patients are complaining. Even
Oh,
if it's
subcut routes, the subcutaneous route. Okay, okay.
some patients are complaining.
With skin irritation,
Will it
sir?
produce infection, you know?
No, sir. No. Does it cause irritation, sir? The complaint is the irritation that comes with the... What is the complaint that they have, sir, with the subcut route?
Some malnutrition and dehydration.
Oh, okay.
Those who are not able to get IV line.
Ah. So it can be useful if you're not able to get an IV line, if you have exhausted all the IV sites.
Yes.
You can, and one thing that we have also done is give two subcuts. So we can give up to 2 liters per day. So sometimes we do 2 subcuts, one in the chest and one in the hand, and we can give...
Whatever for adults we can give, sir?
Which one, sir?
Middle-aged people, can we give?
I'm not sure, but I guess it can. I don't know why it can't be. My practice is mainly with older people. I don't know, sir. I mean, it must be useful, I guess.
Very long back, one pediatric patient came with AG with severe dehydration. I could not find the vein. So I gave it in the IM. Our large fluid only I gave. Then I referred to CMC only. Then they were discussing about this route of administration. Is there any scientific basis for giving this IM route? I was fresh from the college those days.
Okay.
That time I couldn't make the IV line.
Sure.
So I gave it and the patient survived.
Very good, sir. Thanks. In intraosseous also we give. So intraosseous fluids also are in children, that is.
Put the patient in a position the neck down and
Yes.
go for EJV.
Sir.
External jugular vein is a very easy process. you can
EJV,
do.
yes, sir. EJV, yes.
And
But at home and all that, may be difficult to maintain an EJV. Obviously, in the hospital, most of our guys, all the IV lines are registered, they're
Yes, sir. That is
invariably-
IJV. What you are telling is IJV.
No, EJV also. We give EJV. EJV is a peripheral line.
Yes.
We can do it.
And one more thing about the young people, when you are giving even small extra extraction of fluid, that will cause pain. But in case of elderly people, because of subcutaneous fat is very less, and the skin and the adherent to the
There is
thing
lots
very
more space.
Possible space is there.
Sure.
So there is less possibility for pain.
Okay.
Whereas in young adults or somebody, it will be definitely
It will be painful. Okay. So that's the answer to the question. Thank you, sir. I don't know, sir. I don't know. We have never had issues. I mean, we have given subcutaneous quite commonly. We have never had issues in our department.
Subcutaneously, but in the medicine they have mentioned only intramuscular, intravenous only.
Yes, sir.
How is it possible to give
Sir,
subcutaneous? They have not mentioned anything in the product name.
It's not very, sir, one thing I've also done is I've given...
Suppose if you use subcutaneous, if it will land into some problem.
I've given, off the record, I've given subcutaneous olanzapine also. but olanzapine, as you rightly pointed out, olanzapine, it says IV, IM or oral, meaning IV and IM. But I have given olanzapine and it did work. So, but as you say, a lot of drugs, they will not mention subcutaneous. Some of the subcutaneous preparations are specifically prepared with a preservative that will go subcutaneously. But yeah, a lot of drug inserts don't have that SC route.
Do you have any problem while giving subcutaneous at your place?
No, sir. We give the other thing that we commonly give is morphine. Morphine is excellent to give subcutaneously. You just give subcutaneous morphine, works very well, 2.5 milligrams. It works for longer duration because it gets absorbed slowly. It takes a longer time and acts for a longer time. Yeah.
Okay, thank you.
Thank you, sir.
About the absorption, sir, when you are talking about subcutaneous, it will be erratic, right?
Yes.
When you are
Yeah.
giving
So we generally have to give a slower rate, sir. Definitely a slower rate. It can't give the full dose like an IV can definitely not be given. Yeah.
Yes.
I think we will conclude this session. The last talk is on interesting case of mist was cancelled.
Thank you, sir. We request the speakers to come on stage for felicitation by our chairpersons. I invite Dr. Bijan Oliver John. So, I request Dr. Pranitha. Dr. Gopinath. May I request Dr. Alagnatasan to felicitate our chairpersons, Dr. Sivakumar and Dr. Balamurugan. Thank you, sir. That concludes our events for today. We'll continue our events tomorrow at GRT Hall. Thank you.